everyone. A very warm good morning to esteemed guests and fellow members of Aprasocon. On the behalf of the organizing committee, once again I welcome you all and not wasting much time. Yesterday we have a lots of brainstorming session and today also is going to be a fabulous one. So without wasting any time, let's heading towards the first session. It's about the PG Best Paper Competition. And for that, I love to invite the assessor to the podium, Dr. Subodh Singh sir, Professor Dr. Amresh Balyar Singh sir, and Dr. Bhattendu sir. Sir, please. One more. Okay. So over to you, sir.
Hello. Hello. Sessions are usually the best sessions of any conference, and although the attendance is less here, and those delegates will miss some of the finest work that our PGs are doing. So they were playing cricket in the morning, so they will take some time to come. But nevertheless, we will start it. So for all the PGs, I don't see many here. They're there? Okay. So this is a 10-minute session where you have to speak for 7 minutes, and there are 3 minutes for questions and answers. So there are points on how many questions you tackle. So if you do not know the answer of any question, just pass it, right? So, and if there is a comment, you need not answer the comment. You need to answer only the question. And it will be a good idea to limit to your time, because if you pass your time, then some numbers will be deducted. So, so Dr. Balyar Singh has also come. Shall we start, Dr. Sanjay? So now I invite Dr. Meenakshi M. Parashar. Dr. Meenakshi, please come. Can you put his slides on? टेन मिनट्स के दे दो टाइमर 10 मिनट का टाइमर तो यहाँ दिखता रहता है ना 10 मिनट टाइमर दो हाँ
हेलो
हाँ 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 या राइट या 7+3 You are ready to give the time? Meenakshi, your time starts now.
A very good morning to everyone present over here, respected dignitaries on dais and respected seniors. I am Dr. Meenakshi Parashar. I am going to present a paper on short-term and long-term functional evaluation of reconstruction of foot, heel and ankle defects. Now, foot and ankle defects impact a person's daily life, and reconstruction is surgically challenging. The aim of lower limb reconstruction is a functional limb. For that, we have a durable cover, stable durable cover for early weight bearing, for a painless walk, for early shoe wearing, and so that patient can perform daily activities as quickly as possible. For that, we need a vascularized cover, and the mainstay has been free flap transfer. We have used two flaps in our study, which is a radial forearm flap and an anterolateral thigh flap. The primary objective of our study was to assess the functional outcome of foot and heel reconstruction at 6, 12, 18 and 24 months. And our secondary objective was to assess the intraoperative and postoperative complications. We have taken few tools for assessment. For functional recovery, we have considered revised foot function index score, which is a subjective patient-related outcome measure. And for sensory recovery, for touch sensation, we have used the Winston monofilament test. And for static 2-point discrimination, we have used an odd leg calipers. Now this is a diagram showing the foot function index score, where the score ranges from 0 to 100, and it is a patient-related questionnaire where higher scores indicate worsening of the foot-related quality of life. It is based on 5 subskills: pain, stiffness, disability, limitation, and quality of life. Ours is a retrospective study, and the sample size has been 20. We have conducted the study from April 2021 to September 2022, and local ethical committee approval was obtained and informed consent was taken from all patients. The flap selection in our study depended on the size of the defect and the depth, the number of subunits involved, and the functional and aesthetic needs of each subunit. We have taken consideration to the subunit principle given by Hollenbach, as I quote from the Graben-Smith 9th edition. The zone 5 requires high functional and low aesthetic needs, so we have considered ALT, and for the other ones, radial forearm flap. Inclusion criteria, we have taken a continuous anterior tibial artery and posterior tibial artery detected by CT angio and a stable ankle joint for soft tissue injuries, and patient with significant comorbidities were not included. Coming to exclusion criteria, a mangled limb or severe crush injuries to the ankle or lower third that may affect the vascularity, or where AT and PTO was significantly atherosclerosed, were excluded from our study. Statistical analysis was done and obtained data was presented as mean plus minus standard deviations and percentages, and the p-value less than 0.05 was considered statistically significant. Now this is demographic representation. Highest patients were manual workers, and trauma was the most common etiology with 16 patients. Males 15, and that is 75%, and female 5. Now for the radial forearm flap group, the operative time was comparatively less than the ALT flap, that is around 4.5 hours, and operative blood loss was 400 ml. For ALT flap group, it was around 5.5 hours and 600 ml. 4 cases of the ALT flap needed blood transfusion. Now only one flap of the ALT flap group had a total flap loss. That was because of venous congestion, and bulky flap was detected in 3 flaps out of the 8 flaps who came for debulking. No significant infection or seroma was found in any of the cases, and 1 case of radial forearm underwent flap ulceration, and 2 of ALT flap underwent flap ulceration. Now these are few of the cases. This is the first case where we have done a radial artery forearm flap for a case of melanoma of the zone 5. We have considered radial artery forearm flap, and this is the long-term follow-up of the patient. He has obtained a good stable durable cover. This is case 2, similarly an ankle defect where exposed endoachilles. We have done a radial forearm flap and the long-term follow-up. This is a traumatic injury of zone 5 of sole, where we have also done with radial forearm flap, and we have achieved a good cover. Now few of the anterolateral thigh flap cases with exposed endoachilles. Patient had a bulky flap. And this is the video showing the patient having no difficulty in walking even with a bulky flap, but later he underwent debulking surgery. This is the donor side which has healed well. Now size was another criteria in choosing the flap. Here we have chosen a ALT flap since large defect was there. For achieving the rounded contour, we have chosen an ALT flap. Again, another case of zone 3 where we have done an ALT flap and patient did not come for debulking. This is a long-term follow-up of the patient. Again, another patient of zone 4 where we have done an ALT flap. Same patient had good functional recovery. Debulking, he underwent debulking, and we were able to achieve a good aesthetic outcome later on after debulking. So all flaps found to regain some sensation over time with a varying intensity and magnitude, and all sensitivity tests were significantly better at 18 to 24 months compared to their initial values, but they were still poorer than the surrounding area. Tactile sensation was the first to recover and followed by pain and 2-point discrimination. 2-point discrimination test was initially negative for the first 6 months. ALT being bulkier took more time than the radial artery forearm flap group, and sensation recovered at periphery earlier than the center. We achieved 95 success rate in our case, and only one ALT flap failed. And since many were from lower socioeconomic status group, all were satisfied with the functional recovery. Now this is a bar diagram showing the mean monofilament levels where the flap periphery attained better sensation earlier than the flap center, but it was significantly poorer than the surrounding tissue. This is the foot index score we have scored, and the foot function index score of the patients we have calculated. Now how our study is different from other studies is we have considered zones of foot which no previous studies had undergone, and our short-term and long-term results were better than algorithm. And none of the radial forearm flap visited for debulking because they were thin and pliable. Our limitations of our study were it was a retrospective investigation, and we have used only 20 number of cases. We have not used suprafacial ALT in any of the cases. These are a few review of the literature. In our opinion, reconstruction can be simplified according to zone of foot and size of defect to get good functional and aesthetic outcome. So both can be workhorse flap for achieving dual purpose of any reconstruction, that is form and function. These are few of the references. Thank you.
So this paper is now open to questions.
So in the introduction, you've said employee and worker. Workers are also employees. What was the distinction?
So I meant to say manual workers, manual labor workers, and office employees.
So blue and white collar
Yes.
workers, okay. Why were muscle flaps not included in the study?
So we chose to compare between the faciocutaneous flaps, We have reviewed literature where we found faciocutaneous flaps better above the muscle and SSJ. So that revision surgery could be done in the faciocutaneous flap groups. For the debulking and other, they achieve better stable durable cover than the muscle flap and graft.
Okay. And what about the flap that failed? What did you do next?
So for the flap one failed, we went for VAC, and then further cover was again done with SSG only.
You've mentioned zones,
Sir.
but your comparison centers around the heel, right?
Sir.
So how have you compared the other zones?
So we have considered also the subunit 4 and 3 also. All the 3rd, 4th and other zones also we have taken into consideration.
Because in your exclusion you have said ankle injuries and lower leg injuries.
Sir, only a stable ankle joint we have included. Those with non-stable ankle joint we have not included, sir.
About the nerve coaptation, did
Sir.
you do the nerve coaptation also?
Yes, sir. All the flaps were, nerve coaptation was done in all of the cases.
All the cases were
Sir.
done. And one more thing is you have also done for the sole of the foot and also non-weight bearing area.
Yes,
on
sir.
the leg also.
Yes, sir.
So how could you compare both?
Sir, for weight bearing, non-weight bearing, we have all compared. We have only seen the functional recovery and the sensation recovery, which was comparable for both. Patient, even with weight bearing areas, they achieved good functional recovery.
Functional recovery means?
No painless walking and no problem in gait and
Okay,
durable cover was.
fine. Thank you very much. Thank you.
Thank you so much, sir.
Keep her slides ready, please. स्लाइड मत रहिएगा, कंक्लूजन स्लाइड को रखे रहिएगा ताकि उस पर टाइमर चलता रहे, ठीक है, सो दैट वी कैन सी द टाइमर. ठीक है, put the slides. Okay, Ahana, your time starts now.
Good morning, respected dignitaries and my teachers and colleagues. I'll be presenting my paper on the efficacy of autologous platelet-rich plasma for the treatment of scars. There are numerous invasive and non-invasive modalities to manage scars that have been used alone or in combination over several decades. Silicon-based products have been considered as one of the first-line management options for mature scars. However, there is no single treatment modality of choice or a universally accepted treatment protocol till now that has stood the test of time. One of the newer avenues in scar management that has shown great promise and has been tried over several years is platelet-rich plasma. As we know, an autologous platelet-rich plasma has an increased level of platelets, around usually 3 to 7 times of the mean platelet concentration in whole blood. The primary objective of the study was to compare the efficacy of intralesional autologous PRP injection in scars in comparison to a control group which was managed with silicon-based products. The secondary objectives included studying the success rate in terms of the aesthetic result, symptom improvement and outcome in terms of complications using autologous PRP due to various etiologies. It was a randomized controlled trial that was conducted from August 2022 to May 2024 and included post-surgical and post-traumatic scars of duration 6 weeks to 1.5 years, ranging between 2 to 8 centimeter size in maximum dimensions based on our parent article. There were two groups. The control group used silicone products, whereas the test group advocated the use of intralesional autologous PRP. We calculated our sample size based on Melek et al., which gave us a sample size of 34 with 17 patients in each group. Both the groups had 10 males and 7 females each. We developed a questionnaire that focused on the demography, scar characteristics, CBC, complete blood count, as well as the platelet count of all the patients in order to maintain a uniformity. A blood sample of 10 ml was aspirated and collected in sodium citrate vacutainer. We went ahead with a centrifugation of 800 RPM for 8 minutes after discussion with our pathology and other plastic surgery team colleagues. On achievement of the clear demarcation of 3 layers, the PRP was used after a single spin to be used directly into the scars. It was injected into the scar in the next 15 minutes of its production using a 26 gauge needle. The procedural endpoint was scar elevation with blanching. The patients in the test group were managed with 1 sitting each at 0, 1 and 3 months. The control group advocated silicone-based gel or sheet application depending on which location of the scar it was on the body for a minimum of 3 months with a minimum again of 12 to 24 hours daily wear time. We ensured that it is uniform in both the control as well as test group, and our results maintained a statistically insignificant result in comparison to that. We went ahead with a scar assessment of POSAS and Likert scale as well as digital photography, which was done at 1 week, 1 month, 3 and 5 months respectively after the procedure. This was the patient and observer scar assessment scale, which gives us an inversely proportional score with terms of improvement in the scar. These are some of our results. This was the infraorbital, left-sided infraorbital post-traumatic scar of 3-month duration of the control group. This was another scar, which was a post-surgical scar over the left arm, which was of 1 year duration. And this was an abdominal scar, post-surgical scar, again the last follow-up at 5 months. In our test group, this was the first case of PRP that we did. It was a post-traumatic scar over the left side of face. What we observed is that not in terms of surface area, we achieved more pliability as well as we achieved more changes in the pigmentation as well as maximum changes in the thickness. This was another scar of a post-surgical scar over the dorsum of foot. This was another abdominal scar, post-surgical scar, wherein we saw again significant changes in the thickness as well as the pigmentation. This was a case of post-surgical scar over arm. In our results, we found out that it was a statistically insignificant representation based on the anatomical location. When we studied the change in POSAS observer over time, we found a statistically significant trend in both the groups. However, it was more significant in the test group. When we went to the POSAS patient interpretation, we found that they were more comparable. However, the control group, when compared to the test group, they could not match up with the test group's change in the scar. On Likert scale, we found that majority of the patients in the test group were extremely satisfied, whereas majority of the patients gave a neutral response in the control group. Also, we studied the PRP to platelet count ratio and we ensured that it was a threefold uniform increase over all the 3 doses that was given in the test group. Coming to the discussion, maximum clinical change was observed and documented at 5 months post the first discussion in terms of both the POSAS observer as well as the patient parameters, which was reinstated by our parent article Melek et al. Klosova et al. Has also showcased that PRP has helped in enhancing the overall scar quality that included thickness and pliability of the scar, which was also in accordance to our study. There was a statistically significant difference in the Likert scale as compared to the control group, as also proven by Tehranian et al. In the last few decades, PRP has been studied extensively in post-acne scars and post-burn scars, along with a hypertrophic component or a keloidal component attached with it. However, there is less extent of research in evaluating efficacy of PRP alone in mature post-traumatic and post-surgical scars with no hypertrophic component involved in it. In our study, we could also ensure a uniform threefold increase in the platelet count in the PRP concentrate. We had certain limitations during the course of our study. We had a small sample size and a short duration of follow-up of only 5 months. Double blinding could not be achieved as the doctor was aware of what intervention was being given to the patient. Also, prior to procedure, we could not achieve a pre-decided POSAS score, which was not present in our inclusion criteria. There is a need for more studies in future for future exploring of the combined treatment options of PRP with other amenities such as laser. To conclude, PRP when compared to conventional treatment products such as silicone gel sheet showcased a significantly more efficient, reliable and faster extent of aesthetic and symptomatic improvement and thus proves to be a safe and sound modality in healed scar management. Opting for intralesional PRP alone for post-surgical and post-traumatic scar management in the early maturation stage can be considered. Thank you.
This paper is open to questions.
You've compared 2 modalities. One is a single episode where you give an injection. The other one requires patient compliance over a period of 3 months' time.
Yes, sir.
So how are they comparable?
Sir, that is what we wanted to show, sir. When we did review literature, we found that patients who are undergoing only silicone gel, they usually need a more sustained time to keep on acting. Whereas PRP, only over the course of 3 months, if I give 3 injections, I can achieve that same level of improvement. So that is in fact one of the aims of my study, that is what we wanted to prove, that if I have a patient who is continuously every day using silicone product, whereas can I do something to just minimize this much of hassle for the patient and just get better, faster improvement with just 3 doses of PRP.
The other thing is the photography.
Yes, sir.
Your pre and post-ops are not standardized. Your pre-ops have a background because you've done probably in the OPD,
Yes, sir.
but the post-ops are not having
Yes.
the same background.
Sorry, sir.
So
Yes,
there,
sir.
in terms of scar photography, that can be a difference.
Yes, sir. Yeah, agree, sir.
About one thing is you used only injection and the silicone gel.
Yes, sir.
So what about massage or pressure garments?
No, sir.
No, you didn't.
No, we did not use pressure garments. For silicone gel, we used to tell them, for the patients who had over the face, we used to advocate after silicone gel, sunscreen, whereas over other areas, we used to advocate silicone sheets. We ensured that it was uniform, whereas patients receiving PRP also, sir, we did not advocate massage in both the test as well as the control group.
Then how do you know? So one is the invasive treatment.
Yes, sir.
Other is not non-invasive.
Yes, sir.
treatment.
Yes, sir.
How you are comparing the two? Because
The comparison was based on scar characteristics, sir, post-procedural based on POSAS score. We did not take into account the procedure. I agree that the mechanism of actions are different, sir, but we just decided based on the parameters that POSAS offered in both the groups in terms of vascularity, pigmentation, pliability, surface area, etc.
Thank you, Hannah.
Thank you, sir.
Thank you. And the Dr. M. Shivaramakrishnan. Can we have his slides? Shivaramakrishnan, your time starts now.
Good morning, respected jury on the dais and off the dais. Today I am going to present my paper on pearls and pitbulls of muscle flap versus fasciocutaneous flap for reconstruction of lower limb defects. It's a prospective comparative study. Muscle flap and fasciocutaneous flap differs on the type of the pedicle entry. Though it has many similarities, still we have compared both the flaps in terms of parameters such as donor morbidity, flap inset, and other complications. The aim of the study is to compare the effectiveness of muscle flap versus fasciocutaneous flap during reconstruction of lower limb defects following trauma. It's a prospective comparative study conducted within 1st of March of 2023 to 1st of March 2024 with a minimum follow-up of 6 months. My sample size is 30, 15 in each group. All the patients with lower limb trauma admitted to our department were included, and exclusion criteria being age less than 5 years and greater than 70 years, and the patients with diseases like Berger's, Raynaud's, and not belonging to the part of the study were excluded. The study variables included the socio-demographic data such as age, gender, socioeconomic status, history of comorbidities, smoking status, defect presentations depending upon the size, classification, bone trauma, surgery, that is a type of surgery, duration of follow-up, resurgery, whether it is done or not, complications, donor side morbidity, with outcomes such as flap loss, resurgery, post-operative infections, and the follow-up duration. A detailed history is taken according to the size, site, type, and etiology of the defect, with Gustello-Anderson classification for open fractures with orthopedician opinion. First culture was sent for measuring the infection. CT angio was done to know the vascularity status of the limb. Thorough debridement was conducted, and VAC system was used for the patients with gross infection and with non-healing tendency. The defects were classified above the knee, upper third, middle third, lower third, ankle and foot defects. Coming to the results, the baseline characteristic comparisons, the mean age was around 33 to 38 years. In gender, there were more of in male as compared to female. Economic status, both it included lower and middle economic status, with history of comorbidities such as diabetes, hypertension and smoking history, but it was not relevant or significant. Coming to the comparison of the defect of the presentation, the size of the muscle flap varied with 7 to 9 centimeter, and for fasciocutaneous flap it was 9 to 11 centimeter. And with the defect characteristics, the above the knee, upper third, middle third, lower third, ankle, as they compared, it was not so significant in both the muscle groups. Flap types, the muscle flap which were done more are gastrocnemius flaps with 40% of the cases, and in fasciocutaneous flap more were done of the ALT flaps, with donor side morbidity which was significant in our comparison. Morbidity in muscle flap groups was nearly 67%, whereas in fasciocutaneous flap group it was 27%. So on applying a chi-square test, p-value was found significant in the comparative study. Coming to the outcomes, comparing complete flap survival, total flap failure, partial flap failure, wound dehiscence, and applying chi-square test, we found that both the flaps are equally good and it was irrelevant, means both the flaps are equally good. So some of our works in fasciocutaneous flap, we have done a peroneal artery perforator based flap for a middle to lower third defect. For a foot defect, we have gone for a middle plantar artery based flap. For a foot defect, we have gone for a free ALT flap. In muscle flaps, for upper third defect, we have done a gastrocnemius flap and then covered with a skin graft. Then for a dorsum of the foot defect, we have done a gracilis flap, free flap, and then covered with a graft. And then for the lateral malleolar defect, we have done a peroneus brevis flap. And for the dorsum of the foot, for a larger defect, we have gone for a pre-LD flap. Some of our complications include partial to total flap failure. Partial failure being in the case of the free ALT flap, and total failure was in case of a peroneus brevis flap. Comparing my study with other studies with Vladimir et al., Forti et al., and Joan Perro et al., and Yazar et al., it showed that my study had a higher donor site morbidity and flap site complications in muscle flaps as compared to that of the fasciocutaneous flap. So the complete flap survival was 80% in muscle flaps, whereas 73% in fasciocutaneous flap. Total flap failure was 1 in case of muscle, whereas in fasciocutaneous flap we didn't have any total flap failure. Similarly, in partial flap failure, we had 1 case in muscle and 2 cases in fasciocutaneous. In wound dehiscence, 1 and 2, and in donor site morbidity, higher in case of muscle flap as compared to that of the fasciocutaneous flap. So the limitations of my study is, though it's a prospective comparative study, but generalizability of the inference is not possible owing to the small sample size that I have taken. So concluding my study, we found that muscle flap had a higher donor morbidity, which was also statistically significant as compared to the fasciocutaneous flap. The study showed that almost equal proportion of complications among the 2 flaps, and the flaps, when properly selected on the site and size of the defect, are successful and yields better functional outcomes. Thank you.
Thank you. This paper is now open to questions. Yes.
Sir, so it's only about the size.
Both the pedicle and the free all together.
Yes, sir.
Okay.
Any single factor, see both the groups you said that they are equal in result, but single factor which is important in this for
The single factor is the site and size of the defect, sir.
okay.
And the other thing is that both the flaps are equally good, both the fasciocutaneous and muscle flap in terms of the antibiotics, or in terms of the wound healing, in terms of the bone union. Yeah, but still we found that in our study that if we are taking a bulkier muscle flap, then there is a little bit higher donor site morbidity as compared to that of the fasciocutaneous flap.
Okay.
Otherwise,
What about infection?
infection rates are, though in literature we found that muscle flaps, when used, they combat infection more easily as compared to fasciocutaneous. But in our study we found that both the flaps had a equal rate.
No, it's not the flap. It's something else determines,
So,
whether the patient is going to have infection or not. What is that?
so age of
No. Which factor determines
comorbidity status
No.
and age.
debridement?
So we have.
Okay, that's the only factor determines whether you are going to have post-op infection more or less. Thank you.
Your study is spread over a large area and your sample size is not enough to warrant a firm conclusion.
So,
What do you have to say about that?
that is a limitation of my study, sir. That only have done 1 year, and with the 6 months follow-up, and my sample size is
It
30.
would have been better to confine to a particular area
Sure.
for better comparison.
Sure.
Thank you.
Thank you.
Are there any other questions? No? Thank you, Shiva Ramakrishna. So the next speaker is Dr. Akansha Rajput. Slides of Dr. Akanksha, please. Yeah, your time starts now.
Good morning, judges, seniors, and my colleagues. My study is comparative analysis between subfacial and dual plane technique of prosthetic augmentation mammoplasty in trans women, shaping identities. In 2011, the Indian census identified 4.78 lakh population as the third gender community, amongst which the trans women, the male to female transgender population with confirmed gender dysphoria was about more than half of the population. So breast augmentation is usually the first and the foremost step taken by these population as the first step and a key step in the transformation journey as a part of their gender affirmation surgery procedures. So while we studied the literature, we found out that there was umpteen amount of data published on breast augmentation in biological females. But there was a paucity of literature describing the effective and safe techniques for breast augmentation in trans women. So with this in mind, our aim was to compare subfacial and dual plane approaches for prosthetic breast augmentation in trans women in terms of a better operative technique. Our main objective here was to assess and compare the post-surgical and patient-related outcomes in subfacial and dual plane technique in trans women. My methodology comprised of a study design which was a randomized prospective study. The study population was 14 trans women above 18 years of age and mentally capable of consenting for this procedure. The study period was June 2022 to January 2024. Sampling method was a convenient sampling method, and patients were randomized in a 1:1 ratio based on an online software into two surgical approaches. My data collection tools were patient performa comprising of the demographic details, the surgery-related, implant-related details, and the post-operative outcomes like VAS score and the breast Q questionnaire. The surgical technique, we selected the implant size based on the patient's anthropometry and the surgeon's experience. It was a single surgeon's team. And we implemented Motiva round nano-textured silicone implants in all our 14 patients. The intramammary approach was also common in all our 14 patients. The subfacial implant placement was a standard method, and dual plane we implemented type 2 or type 3 in dual plane technique. Coming to my results, there were 14 patients with 7 patients in each group. No patient had any pre-existing comorbidities or addictions. No patient had a history of past surgery or deformity on their chest wall. Based on our demography analysis and the implant characteristics, all the features were comparable between the two groups. However, there was a significant difference in the duration of surgery between the two groups. So these are my baseline characteristics of patients in the subfacial and the dual plane. As we can see, the skin pinch test, which is an essential part of selecting the implant in these patients, it was common and not a confounding factor. And hormonal intake was also not a factor in our study, but some patients had taken it prior to presentation in our department. And even the implant characteristics were also spread out and not a confounding factor between the two groups. Based on the surgical outcomes, it was observed that the duration of surgery was lesser in subfacial plane, while in dual plane, it was higher. So p-value was significant by about 0.01. Coming to the VAS score, there was a statistically significant difference between the VAS score at third month follow-up between the two groups, with a higher rate of decline in subfacial group. All components of breast Q questionnaire, the subscales showed a statistically significant improvement from first month of follow-up to the third month. However, there was no statistically significant difference between the two groups in overall scores. But we did find that dual plane had a better outcome with respect to the satisfaction with breast appearance at 1 month, which almost nullified by 3 months follow-up. So this was our breast Q scale comparing the subfacial and dual plane, and as we can see, when we compared the 5 subscales, the satisfaction with breast appearance was better in dual plane, which was significant, about 0.019. We did not find any wound or implant-related complications in both the groups. All patients were satisfied with the final appearance of their breast, and there were 3 patients overall out of 14 who wanted larger implant size, and they were willing to undergo further surgeries in the future. These are some of my clinical photographs, and subfacial plain 22-year-old trans woman with a 280cc Motiva implant. This is another photo of subfacial augmentation with a 325cc Motiva implant. These are the clinical photographs for dual plane, 24-year-old women with a 300cc Motiva implant, and a 25-year-old trans woman who underwent dual plane augmentation with a 325cc Motiva implant. So in my discussion, I would like to highlight the fact that dual plane and subfacial plane both are effective techniques of augmentation mammoplasty, but less studied in transgender population when you want to compare the two. So my parents' article was a Balakrishnan et al. Study based in 2020. It was a descriptive retrospective analysis of 42 trans women, and they said, they observed that subfacial plane was superior than other planes because of the tougher fascia, better implant stability, and improved post-operative comfort. The study also mentioned that creating a subfacial pocket is quite straightforward and hence less time consuming. But when you're trying to establish a dual plane, there's a lot of technical skill and meticulous dissection involved, which the surgeon needs to keep in mind, and that was also quoted in one of the studies in 2019. When coming to pain analysis, another study, recent study in the last year said that when various cosmetic surgeries were performed on the breast, the subpectoral breast augmentation recorded the highest FAST score amongst the various techniques. These results were similar to our study, and we strongly believe that subfacial implant surgery gave a more natural result to the patient and helped in a speedy recovery. The limitations of my study here would be a small sample size, a short follow-up period, and potential for surgeons' bias as a single blinded study. I would like to conclude with that implant-based augmentation mammoplasty is a safe procedure frequently pursued by trans women. My interim results here shows that subfacial plane is a better augmentation technique in terms of operative time and post-operative recovery. There was a better post-operative satisfaction with breast appearance, which could be attributed to the larger mean size of the implant in the dual plane group. So with a larger sample size implemented and a longer follow-up period, I may be able to substantiate these results in the future. Thank you. Thank you all.
Thank you. This paper is now open to questions. Yes. Take a mic, please.
You have told that it is a randomized study.
Yes, sir.
How you have nullified the bias? How you have made the randomization? My first question.
Yes, sir.
Second question is how you have calculated the volume
Yes, sir.
and the markings, for instance.
So volume, actually it was based completely on the surgeon's experience, and we did not implement any formula that has been studied in the literature so far. I would like to do that in the future when we implement more patients and include more patients in my study. And your second question, we randomized based on an online software. I spoke to my statisticians also. They said that since it's a convenient sampling method, it's not a large one, you better go with a online software where you randomize the patients as they present to you. That's why it is called a convenient sampling method. Knowing the fact that this population is underprivileged, less observed, less catered to, they are not easily available to us, and they also don't present to us because of the stigma held in the society. So we adopted this convenient sampling method just because of that reason, and we try to be as non-partial and non-biased as possible. So that's why it is a single bias study, and I'm definitely saying there's a surgeon's bias involved here. So I would like to pursue that in the future for sure.
Thank you. Can I ask you a question?
Yeah, go ahead.
So you have analyzed with Q-score.
Yes, sir.
Who has done the analysis?
Sorry?
Who has done the Q-scoring?
Sir, Q scoring I have only done. I sat with all my patients and translated every statement to them.
Okay, you have done.
Yes, sir.
So you have told that in your study there is only one bias.
Yes, sir.
So what are the biases in the study?
So one is the surgeon's bias, then probably I would say it was
First is
just
selection bias.
selection bias.
That
too,
comes under randomization.
Yes, sir.
Then outcome bias. So if you are doing the study and if you are doing the analysis, definitely there will be inclination for bias.
Yes, sir.
So if you are comparing two groups,
Yes, sir.
ideally that should be evaluated by independent observer
Yes, sir.
who is not included in the study and who had no access to the randomization.
Yes, sir.
If you have doing the study, if you are doing, definitely there will be a outcome bias.
Yes, sir.
So one is selection bias, another is outcome bias. What are the other biases?
Pertaining to this study.
Okay, thank you.
Thank you very much. Dr. Akanksha, one question. See, when we take photography for research purpose, so there are certain format we follow and certain positions also we follow. Did you follow those criteria for dress photography?
Yes, sir. Sir, I had taken the bird's eye view as well and the oblique views as well, but I have not put it here. But I have taken all the...
Please review your photograph and also review literature of how the photograph should be taken.
Okay, sir. Yes, I'll
Thank
do
you
that.
very much.
Yes,
Thank you.
Thank you.
Bye.
Is by Dr. Pragada Sushmita. Can we have her slides, please? Wait,
Yes.
Pragada, let your slides come. An audience, please ask pointed questions. Yeah, your time starts now.
Yes, sir. Good morning to the dignitaries on the dais. Topic of discussion is effectiveness of surgical offloading procedures for 4-foot trophic ulcers. Myself, Sushmita, MCH second year resident from some hospital. Introduction. Pressure ulcers are common complications in patients with peripheral neuropathy. Peripheral neuropathy is mostly related to diabetes mellitus. Diabetic foot ulcers are frequently related to elevated pressure under a bony prominence. Conservative treatment includes offloading with orthopedic shoes and custom-made orthotics or plaster cast. While casting in plaster is usually effective in achieving primary closure of the foot ulcers, but recurrence rate is high, as high as 60%. Surgical offloading and correction of foot deformities has good short-term and also long-term results. Surgery alleviates the pressure under the bony prominence, thus enabling prompt ulcer healing, negating the patient's dependence on expensive shoes and orthotics with a lower chance of recurrence. Aims and objectives of the study to evaluate the effectiveness of surgical offloading procedures in healing 4-foot trophic ulcers, and to assess the recurrence rate and to evaluate overall patient outcomes, including the pain reduction, quality of life, and cost effectiveness. Materials and methods of the study. This study was conducted in some hospital with a sample size of 20 diabetic foot cases who presented with non-healing ulcers on the forefoot. It was a prospective and descriptive study. Patient complete history was obtained, were clinically examined, and relevant investigations were done. Appropriate offloading surgical procedures were planned like metatarsal head excision, callus arthroplasty, and percutaneous flexor tenotomy and tarsal tunnel release were done. Data was collected and analyzed by appropriate statistical methods. And what for the ulcers present over the base and interphalangeal joints of the great toe were treated by callus arthroplasty, and ulcers over the metatarsal head were treated by metatarsal head excision, and the ulcers of the tip were treated by either closed or open flexor tenotomy. And metatarsal head excision is an effective surgical option for plantar trophic ulcers over the metatarsal head. Incision placed over the dorsum at the affected metatarsal head and removed at the surgical neck. This procedure helps by reducing the plantar pressure on the forefoot, which is crucial for promoting the healing and preventing the further ulceration. This is the preoperative picture. Over the 5th metatarsal head, we can see the trophic ulcer, and for this we have performed the metatarsal head excision. And the ulcer present over the great toe, we have done callus arthroplasty. We will explain the next slide. And this is the post-operative picture after 20 days and after 2 months, which the ulcer was completely healed. And this is the under preoperative picture of the trophic ulcer of the metatarsal head, and the post-operative picture after 3 months. This is the under preoperative and post-operative picture. Coming to callus arthroplasty, ulcers planted to the interphalangeal joint of the hallux will be treated by a modified callus resection arthroplasty. Skin incision will be just middle to the extensor hallucis longus tendon, and the joint capsule will be opened longitudinally and the joint is exposed. A 4 to 5 mm slice of bone and cartilage will be cut from the base of the proximal phalanx perpendicular to the bone axis with a saw, detaching the short flexor. A shallow cup-shaped indentation will be created in the proximal first phalanx with a bar drill. to increase the congruency with the metatarsal head and promote the smoother movement, and increases the toe shortening effect and facilitate the forming a pseudoarthrosis. The joint capsule will be sutured tightly and the wound will be closed in layers and the putty and the dressing stuff. This is the preoperative picture of the great toe. The ulcer is present over the base of the proximal phalanx. Percutaneous flexor tenotomy. Tip of ulcers will be treated by percutaneous flexor tenotomy. For long flexor tenotomy, the tendon of the toe will be placed under tension by dorsiflexing the ankle and toe. The patient will be asked to actively flex the toe to cause bowstringing of the flexor tendon. A beaver plate will be inserted at the midline of the base of the middle phalanx, making a tiny puncture wound. The tendon will be gently cut by careful side-to-side micro movements of the blade tip without straying medially or laterally to avoid the injury to the neurovascular bundle. At the end of the procedure, inability of the patient to flex the distal interphalangeal joint will confirm that the tendon has been completely severed. And tarsal tunnel release. Tarsal tunnel syndrome leads to complications like trophic ulcer, especially in diabetic individuals. Can improve the blood flow and release the nerve compression which aids in healing of trophic ulcer. 2 incisions are given. One incision is on the posterior third of the medial aspect of the lower leg along the course of the tibial nerve. Second incision is at the angle along the course of the lateral branch of the tibial nerve. Flexor retinaculum is transected, thus relieving the pressure on the tibial nerve. Observations of this study: 20 persons were examined, analyzed, and based on the location of the plantar trophic ulcer, surgical offering technique is planned. In this study, 12 were male patients and 8 were female patients. The age preponderance among the diabetic foot patients ranges from 32 to 75. The mean age was 57%. Patients as young as 32 years and as old as 75 years have developed diabetic foot complications. Patients have either one limb or both in the few patients. Majority of the patients had the right foot involved. And among the 20 patients, the right foot was 15 and left foot involved was 5. In my study, the results, a total of 20 patients were included in the study and were operated with the various surgical operating procedures best suited for the deformity and the site of plantar ulcer. Site of wound with which the patient presented varied among the study group. According to the location of the trophic ulcer, internal operating procedures were performed. After the procedure, these patients were on plantar cast applied for 3 weeks, and these ulcers showed good healing rates at about 8 to 10 weeks. Average time taken for the trophic ulcer healed to was 9 weeks. 2 patients had wound infections and dehiscence due to uncontrolled diabetes, and no recurrence is seen among these 20 patients. And 4 patients lost the follow-up. 90% of patients had their ulcer healed in 9 weeks. Conclusion of the study: surgical offloading is a good intervention for managing trophic ulcer, especially in patients with conditions like diabetes and other neuropathy, by reducing the pressure on the affected area. These procedures help in managing ulcer effectively. Surgical procedures aim to offload pressure from the ulcerated area, allowing for better healing and reducing the need for expensive orthotics and special footwear. Additionally, surgical offloading has been associated with low rates of complications such as infections and dehiscence, and allow patients to return to their daily activities more quickly.
Thank you, Dr. Pragada. This paper is now open to questions. Mike.
Dr. Pragada, how is a posteriotibial neurovascular decompression and of surgical offloading surgery? Your presentation is on surgical offloading. So you do PT and VD, posteriotibial neurovascular decompression. Is that offloading surgery? How is it?
For releasing the retinaculum, in abdominal release also, we will cut the retinaculum with the compression of the tibial nervous release.
Yes.
So sensory is retained. You can alter the biomechanics, like patient can feel the pain. So trauma is reduced.
But this will not be called strictly a surgical offloading technique. Metatarsal osteotomy. Did you do any metatarsal osteotomy?
Yes, we can do.
Did you do any
Yes, we have done. But
So-
mostly we have done osteotomy. Then osteotomy, we have done osteotomy.
So how do you decide whether to do osteotomy or osteotomy?
Any osteomyelitis changes in the bone means we have done for directly osteotomy.
Yeah, thank you. One thing is you excise the surgical head of the metatarsal. Okay, so what happened to the joint surface of the proximal phalanx?
Soft tissue we have intercourse is some soft tissue there.
Okay, you didn't do anything to the articular surface
No,
of
sir,
the base of the proximal phalanx.
nothing.
Okay, and see, you did many procedures.
3 procedures we have done.
There should have been a diagrammatic representation, how exactly you did the procedure. That should have been more informative to the audience. Okay. Thank you very much. Thank you. Bye.
That is by Dr. Gopika Jit. So may we have the slides of Dr. Gopika? Tell me when you are ready, Gopika. Time starts. Okay, your time starts now.
Good morning, respected seniors and my dear friends. My paper is on exploring the anatomical variability and perforator characteristics in suprafacial ALT thigh flap through lateral approach and observational study. Suprafacial ALT, as we know, is ideal for defects requiring minimal bulk with thin, pliable, free flaps and superior aesthetic outcomes. However, the variability of its vascular anatomy can complicate dissection, posing challenges for the surgeons. Preoperative imaging investigations offer insights but may not be always available or may not be affordable. There are no studies from India on detailed anatomy of the ALT flap from the suprafacial plane, and studies on lateral approach are rare and results are conflicting. Our study emphasized on the vascular anatomy of the ALT flap in the adipofacial fatty layer. Our objective is to analyze the perforator characteristics and the anatomy of ALT flap pedicle dissecting from the suprafacial plane through the lateral approach. This was an observational study which was done on 27 patients who underwent suprafacial ALT flap harvest through the lateral approach. Preoperative assessment of the perforator site was detected using the handheld Doppler. Intraoperative recordings, including the site, size, number, type, origin of perforators were identified, and the perforators were classified according to the use ABC classification system. This was our surgical procedure. We marked the flap using preoperative Doppler, handheld Doppler, and flap elevation was done through the lateral approach, identified the perforator, and we retrogradely dissected it towards its origin. Results. Among 27 patients, we had 85.2% of male patients with the mean age being 44.11 years. ASI's perforator distance mean was found to be 20.63 centimeters and the mean pedicle length was 9.21 centimeters. We had a total of 39 perforators, with each individual having at least one perforator. There were no cases where perforators were absent in our study. Perforator B was not found in 3 cases where we found A or C. In 6 cases, we found identified branches of sizable diameter which were arising from the main perforator in the suprafacial plane. According to the course, we found that majority belonged to the musculocutaneous type, 51.3%, and it originated from DLCFA. From the oblique branch, we had 12.8% of the perforators, and from the descending branch, we had 87.2%. These were the vascular patterns we observed. So we had single perforators in majority of the cases arising from the descending branch, and triple perforator in a single case where 2 were arising from the oblique branch and 1 arising from the descending branch. The average distance between the Doppler detected location and the actual location of the perforator was found to be 1.79 centimeters. The anterolateral thigh flap was successfully raised by lateral approach in all our cases. There are various imaging modalities described in literature, but they are not without complications or cost issues. And although acoustic Doppler has got high sensitivity, it may detect vessels other than the actual perforator, and the course of perforator is also difficult to assess with a Doppler. CT angiography, according to the previous studies, it is useful in reducing the time required to harvest, but there's no significant reduction in post-operative complications overall. Besides, in lead individuals, the course might be misleading. Apart from that, radiation exposure, contrast-induced nephrotoxicity, cost and availability are the other issues associated with CT angiography. Regarding the lateral approach, there are few studies where they compared medial approach with lateral approach. Though some studies show that it takes more time in harvesting flap with the lateral approach, the others are against it, and they find that perforators, when they are not emerging from the DLCFA, it is easier to identify using lateral approach. Also, it is found as one of the 5 simple techniques of rapid elevation of ALT. In our study, we found that lateral incision, we get a well-defined fascia in the lateral aspect, and the superficial fat and the deep fat can be easily distinguished from the lateral aspect. And identifying the supraphacial vascular plexus of the perforator was found to be easier. And once we identify, we trace it back and identify the origin of it, take it along with the flap. We did not encounter any cases lacking perforators as described in the previous studies. Though we found venous congestion was associated with the musculocutaneous type of perforators, which was the majority type. This study provides a comprehensive examination of ALT perforators from the suprafacial plane along the lateral approach. Through the lateral approach, we could readily detect the perforators, even if it's not emerging from the DLCFA, and successfully harvest it in all the cases. So this technique allowed us for a better identification and preservation of perforators, leading to enhanced precision during dissection. These were few of our cases where we found the B and C septocutaneous perforator, another case with a septocutaneous type B perforator, and type B musculoseptocutaneous perforator. Thank you.
Thank you, Dr. Gopika. This paper is now open to questions. Yes, please.
Well, good morning. Have you assessed the diameter of the perforators?
Yes, sir. Initially, we started off measuring the diameter, but then we realized that there is a high variation intraoperatively. It all depends upon the intraoperative blood pressure of the patient, or if in case the vasospasm occurs. It is not reliable in a live case, unlike we see in cadaveric studies.
So
There
how
is-
much, wait, okay, fine. What is the variations of the literature and your anatomical variations? Your study, I mean to say.
Sir, the major fact we found was that in all the studies they mention about absent perforators, which we did not encounter.
Okay. Thank you.
Yes.
I have one question. In cases where you found multiple perforator arising from multiple branches of LAD artery, so you preserved the dominant perforator and the branch giving, from which it is arising, or multiple perforator on different branches, you preserve both the branches like?
It varied from case to case, sir. This is what we observed, we have recorded, but what we took dependent on what the site was and how we designed the flap.
I mean, if the dominant perforator,
if we wanted a more
largest perforator is at the center of the flap, then you can rely on the same single perforator.
Yes, we can rely on the single
If it is
perforator.
eccentric, then maybe two perforators.
Yes, sir.
Is
Eccentric.
it like that?
If it is eccentric, sir, and in case if we require a longer pedicle length, then we'll go for the distal most perforator and
Dr. Gopika, one thing is why, you did it on the patient itself, agree?
Yes.
So, because you are comparing a study, then why didn't you do cadaver studies?
Our study was on intraoperative findings only, sir.
Okay.
Study was done
And
only.
one more thing is, you also mentioned about the size of the perforator. So, what are the criteria you used for determining the size of the perforator?
Size of the perforator, sir, we use a vernier caliper intraoperatively, but later on we recognize that it is not reliable because it is getting varied with the blood pressure of the patient, or when it goes into vasospasm. It is not actually reliable intraoperatively, which is also described in the literature. Uh, Size of the perforator will be reliable only in cadaveric studies where there won't be any disturbance due to the variation in the blood pressure of the patient.
And if you have to include fossa, because it is suprafacial.
Yes, sir.
No? If you have to include fossa, can you use this technique?
Yes, sir.
How?
Lateral, through the same lateral approach, through the same incision, we can just identify the perforator and include the fascia along with it.
No, how can you? No, because you have to see the perforator, you are raising the flap, fat above the fossa, then going to the perforator. Then if you have to, then you give another incision
Over the fascia.
So then that fossa will get devascularized, no?
Yes, sir.
Okay, thank you. It was a nice presentation.
Thank you, sir.
My question is, have you assessed what is the average distance from ASIS to the
We have, sir.
dominant perforator, and
Yes,
what is
sir.
the pattern?
We have found it as 20.63 centimeter as a mean distance from the ASI, sir.
But that is not what is described typically for ALD, I think.
No, that's fine. She has measured it. Thank you, Dr. Gopika.
Thank you, sir.
Can we have the Dr. Jyoti Ranjan Pradhan? Jyoti, your time starts now.
Yes. Esteemed jury, respected teachers, and dear colleagues, today I am going to present a paper on a comparative study between ligation and stripping of the great saphenous vein versus subphacial ligation only for the varicose vein surgical approach. Varicose vein is a general term used to describe the bulging veins usually seen on the legs when standing, and also underlying incompetent veins that reflux and cause the surface varicose veins. Importantly, varicose vein is often used for superficial venous reflux even in the absence of the visible bulging veins. Varicose veins are not just a cosmetic problem. Most deteriorate with time, leading progressively to discomfort, swollen ankles, skin damage at the ankles, venous leg ulcer, superficial venous thrombus, and bleeding venous ulcers. Open surgery, that is high ligation, usually accompanied by stripping, is the conventional approach for the varicose veins, but it has been proven that the revascularization of the strip tract occurs with 23% of the people showing some strip tract revascularization within 1 year and over 80% in 5 to 8 years. Though high ligation with stripping is the traditional approach for the varicose vein, yet only subfacial ligation with stripping is proven to be equally effective. This study compares the advantages and disadvantages of both these modalities of treatment. The objective here is to find out if only the ligation of the great saphenous vein is better than ligation and stripping of the varicose vein surgery for with respect to the relief of symptoms and complications. This is a prospective comparative study conducted for cases of varicose vein of lower limb admitted in the Department of Plastic Reconstructive Surgery in our hospital during the period of 1st March 2023 to 28th February 2024. All patients diagnosed with unilateral varicose vein and aging from 30 to 70 years were included in the study. whereas the patient with peripheral arterial disease, DVT, patient with venous ulcer, and cardiological and neurological unstable patient were excluded from the study. The sample size was taken as 30, and every consecutive patient fulfilling the inclusion criteria was assigned an alternate group. A detailed history was taken, routine investigation with color Doppler was done, and after random grouping of the patients, each underwent the assigned surgical procedure, that is either ligation and stripping of the GSB or only subfacial ligation. All patients were kept under continuous follow-up for 6 months to 1 year. The study variables here were duration of surgery, bleeding, hematoma, infection, hypoesthesia, and saphenous nerve injury. The results are thus described. Out of the total 15 patients taken in the procedure for ligation of stripping, the mean duration of surgery was 65 minutes, whereas for ligation only it was 48 minutes, which clearly shows that ligation of stripping took some more extra time. And in case of bleeding, the 6 patients out of 15 in the first category, that is 40%, had bleeding intraoperatively, whereas in category 2, that is only 1% out of the 15 had bleeding, that is 6.7%. This amounts to 0.03 of the p-value, which is significant. While comparing the hematoma, only 3 out of the 15 patients had hematoma, that is 10%, whereas only 1 out of 15 in the ligation category had hematoma, that is 3.33%. This amounts to p-value of 0.2, which is not significant. For hypoesthesia, 4 out of the 15 patients had developed hypoesthesia post-operatively, that is 13.33%, whereas none of the patients in the ligation only category had hypoesthesia, which amounts to 0.031 as p-value, which is significant. And comparing the infection on either in either categories, 2 out of the 15 patients in the ligation plus stripping category had infection, which is 6.67%, and none in the ligation category, which amounts to 0.14 p-value, which is not significant. These are some of our 2 of the cases. Pre-operatively, subfacial ligation without stripping is done. And in this case, ligation stripping was done. And these are the post-operative results of the second case. Concluding, the subfacial ligation with stripping is equally effective with less surgical complication, although high ligation with stripping remains the traditional approach for varicose vein. Thank you.
Thank you, Dr. Jyoti. And we have ample of time for questions to this paper.
Sir, here we conclude that only ligation of the great saphenous vein and incompetent perforator is equally effective to ligation with stripping. Sir?
High ligation, you have mentioned.
High ligation is the ligation at the saphenofemoral junction.
Okay, I have a question.
Yes, sir.
So, of course, today, the value of this paper I don't understand because once, last decade has seen a resurgence of laser.
Yes, sir.
So, how does this paper stand today?
Sir, even today in the tertiary care hospitals where the lasers and radiofrequency ablation is not available, this is the routinely undertaken procedures.
Slowly fading, very quickly fading. Okay, next
Yes,
thing
sir.
is, how did you locate the perforators?
Sir, after doing the color Doppler study, the perforators are marked. And after that, we undertake the surgery.
So how much time before your surgery do you do the
So
location
the day
of the
before the
perforator?
surgery, we do the
day before.
perforator marking. Yes.
And you personally go and mark the perforators?
No, sir, the radiologists have done this.
That's where the dissonance is. Okay. Thank you.
What was the longest follow-up?
Sir, in this study, it is 1 year, sir.
So coming to the length of the study,
Yes, sir.
there are, I find quite a few objections to the study in the way that
person's asked, is to kind of, this surgery has become almost like history.
Yes, sir.
So especially the comparison of these two groups, subfacial and the stripping. The stripping has been given up long since.
Yes.
So this is not a time-worthy study to take, compare these two.
Yes.
You should have done a study comparing the surgical and non-surgical group.
Yes.
I think you do that in the next time.
Thank you, sir.
Any other question? Thank you, Dr. Jyoti.
Thank you, sir.
The next paper, Vidush Kumar. Can we have the slides for Dr. Vidush Kumar and the audiovisual team? So when you talk, you are just behind the speaker, so he gets disturbed. So please keep your voices low. So can we have the slides of Dr. Vidush?
My topic for today is expanding surgical frontiers in the treatment of electrical burns and their functional restoration. So coming to introduction, post-electrical burn patients are difficult to manage due to deep injury involving all the structures up to the bony level. An adequate flap cover is often required to resurface the defect for preventing the complications. Aims and objectives were to assess the efficacy of various flaps for reconstruction in patients with electrical burn injuries and to establish the role of flaps in reconstruction for patients with electrical burn injuries and its sequelae. The study design was a retrospective observational study, and the participants included the patients treated at our center from 2019 to 2024. Inclusion criteria was all the patients with the electrical burn injuries which were treated with flaps during their acute stage or for their sequelae. And the exclusion criteria was the patients who were treated conservatively with or with skin grafting alone, or who had expired during their hospitalization or were lost to follow-up. The material methods, we found total of 72 patients in the past 5 years, in whom a total number of 89 flaps were done, and these were categorized based on the type of flap surgeries performed and the area reconstructed and the outcome. So here are the various division of the flaps. We can see the number of local flaps was the maximum, followed by the distant pedicle flaps. So in the local flaps, scalp transposition flap was done the maximum number of times, followed by local transposition flaps. In regional flaps, cross finger flaps was the one which was done the maximum number of times. Distant pedicle flaps, groin flaps and abdominal flaps were mostly done for wrist defects. And 2 free flaps are also done, but both of them were not for the acute stage. Coming to the region-wise distribution, the maximum number of flaps were done for upper limbs, followed by the head and neck. And the outcome, total 91% of the flaps had survived, and only 9% of the flaps showed any complication. Total gender distribution-wise, 92% of the patients were all male, and the age group in which they presented, the most common age group was 21 to 30 years of age. So here are a few clinical photos. Here are 3 cases of scalp transposition flaps, the pre-op and the post-op photos. This is the FDMA flap. This is one trapezius myocutaneous flap and bilateral biopedicle flap cover done for the defect over the posterior occiput and the nape of the neck. This patient had come with a history of 3rd degree and 4th degree electrical burns to face, neck and abdomen. So they had done, at our center, he had undergone PMMC flap for the neck cover along with the IMAP flap for the cover over the primary flap defect and the local flap cover for the residual defect on the abdomen. This is another, this patient had come with the electrical burn injury to the face and was reconstructed with the deltopectoral flap. Here is the cross finger flap, and this is the abdominal flap which was most commonly done for wrist injuries. Here is the post-op video of the patient showing functional restoration. And this is one of the free flaps which was done. This patient had come with a history of, he was a 2.5 months old electrical burn injury, already undergone scalp transposition flap which had failed. So he had come with a exposed calvarium. He had undergone a free radial artery forearm flap. Coming to discussion, choosing an appropriate flap still remains a challenge in electrical burn injuries. And as per a study by Yun Chuan, various flaps have been shown for the reconstruction of deep burns similar to our study. And Holt emphasizes the need of flaps in the electrical burns reconstruction and shows the importance of timing the surgery. Free flaps are also not always possible. And we believe loco-regional flaps remain the cornerstone of reconstruction in electrical burn injuries. And unlike graft, flaps are superior in resurfacing the injuries with exposed tendons and joints. And coming to conclusion, the maximum electrical burn injuries occur in men. Most common age group is 21 to 30 years of age. And using flap for reconstruction will shorten the hospital stay and the need for prolonged dressings. And free flap is not often possible in an acute setting. The donor site morbidity is minimum, and most flaps will settle well without any complications, and the range of motion in joint areas is also good. The reconstruction with flaps will provide a better aesthetic and functional outcome in the electrical burn injuries. Thank you.
Thank you, Dr. Vidush. This paper is now open to questions.
What is the preoperative investigations you do for the atrial anatomy, and do you investigate in all cases? What are the investigations you do preoperatively in this?
For electrical burn patients, sir?
For the flap.
For the flap, sir. Sir, ideally we can do we can check the handle Doppler also to check whether the supply is good or not, what is the caliber of the vein and the arteries are good or not. Otherwise, CT angio can be done, sir, to look for the patency of the vessels.
You do in all the cases of the CT angio? Or
not all cases, sir. Ideally, we should do, but not always required, sir. Based on a clinical acumen also, we can choose the patient.
Have you do any comparative analysis of this normal and also electrical burn? Like in the supposing you are doing the local flap, comparing this atrial anatomy and the electrical burn, what is the difference between the normal and also the electrical one who is suffering from this, covering a flap for this one?
So we had not compared that in this study, sir, but...
That's fine. Thank you. Not compared, that's fine. Next question. Any other question? Yeah, go ahead.
How you have assessed the outcome when you are resurfacing after a electrical burn to the forearm or the hand?
Sir, the main study which we had done was to show the versatility of the options available with various flaps which are being used for electrical burn injuries, sir. Outcome as such, we had just seen whether the flap done for the patient required any further surgeries to resurface the defect or not, sir.
Surgical outcome or a functional outcome?
Sir, surgical outcome, sir.
Okay, thank you.
So what was the earliest time you did your flap in an electrical burn case? I mean, within how many hours or days from the time of injury?
Sir, we have the earliest was 5 days, sir. That was a scalp transposition flap, sir. In 5 days, that was the earliest we had seen, sir, in our center.
Okay.
Does angiography help for determining the level of amputation in electric burns?
Sir, it will help, sir, but mostly what we are doing at our center, sir, we will be, if in electrical burns, we'll look at the clinical appearance of the limb, sir, whether it is surviving or not.
Would you look at the muscles and other?
Yes, sir.
Yeah, then,
yes, sir.
Okay. If there are no other questions, thank you, Vidush.
Thank you, sir.
Next speaker is Dr. Lipsha Swen.
Good morning to esteemed panel of jury, respected dignitaries and my colleagues. I am Lipsha Swai. Today I am going to present on reconstruction of soft tissue defects due to chronic wounds and algorithmic approach to clinical decision making. Chronic wounds are the wounds that have failed to heal in an orderly process within 3 months of time, producing unsatisfactory anatomic and functional results. The etiology are diabetic foot ulcer, neuropathic ulcer, pressure sores, peripheral vascular diseases, venous insufficiency, infection, trauma, malignancy, autoimmune diseases, burn, etc. Reconstruction of foot is challenging because due to lack of donor sites, it is hard to replace this glabrous tethered specialized thick skin which is designed to withstand the weight bearing stress and ambulation. The limited arc of rotation of the local foot flaps contribute to further difficulties. Foot reconstruction aims to provide adequate soft tissue coverage and maintain the functional recovery. Reconstruction plan is individualized considering the factors like the defect size, location, donor site availability, involvement of surrounding structures, and morbidity of the surgical procedures. Local wound care, skin grafting, loco-regional flaps, microsurgical free tissue transfer or amputation are the few options available. This study focuses on an appropriate reconstructive algorithm using various techniques which are tailored to each wound presentation for ensuring the best possible functional and aesthetic outcome for the patient. Aims and objectives: to assess the aesthetic and the functional outcomes of various surgical strategies for the reconstruction of soft tissue foot defects caused by chronic wounds. This is a prospective observational study conducted at our institute. That study period from October 2023 to September 2024 with a minimum follow-up period of 3 months. 30 patients were taken aged between 20 to 70 years who underwent various reconstructive procedures for foot defects according to the defect size, site and need for soft tissue padding. The inclusion criteria: all the cases of foot defects of size 1 to 15 centimeter due to diabetic foot ulcer, neuropathic ulcer, pressure sore, trauma, infection or tumor are included in this study. The exclusion criteria consists of patients who are not willing to be a part of the study, patients with peripheral arterial diseases, autoimmune diseases or any other vascular disorders, and larger defects of size more than 15 centimeters. The study variables include the socio-demographic data, age, gender, economic status and the etiology of the wound, defect presentation, size and location of the defect, type of procedure, donor site morbidity and whether there is a need of resurgery. The outcome variables include flap loss, resurgery, post-operative complications, recurrence, under aesthetic outcomes, color match, skin contour, scar and bulkiness of the flap. Functional outcomes include pain, activity of daily life and quality of living. The methodology: first, there is enrollment of the patients with foot defects after informed written consent, detailed history regarding the etiology, site of the defect, size of the defect along with the comorbidities. Local wound care, control of diabetes, pus culture and sensitivity, all the routine investigations and special investigations like ultrasound Doppler or CT angiogram, identification of the perforators and location of the arteries using a handheld Doppler before planning the flap. Patient distribution is done depending on the location of the defect, the dorsum of the foot, plantar forefoot, midfoot or hindfoot, defect size and the degree of the need for a soft tissue padding. After debridement, the defects are covered with appropriate flaps depending on the size, location and the availability of the flaps. Smaller defects are managed with local flaps, medium to large defects with the loco-regional flaps, and larger defects are managed with free flaps if when other options were not available. And superficial defects on the dorsum were done with SSGs. 3 months follow-up was done for observation of the surgical outcomes. The foot and ankle outcome score was used to evaluate the post-operative functional outcomes, and the aesthetic appearance was assessed by patient or patient relatives. These are the results. The table 1 shows the socio-demographic profile of the patients. The age of the patients were between 20 to 70 years, the mean age being 38.5. Out of 30 patients, 67 patients were male and 33% were female. Most of the patients belong to the low economic society. And among etiology, 40% was of the chronic wounds were due to diabetes, followed by pressure ulcers. Table 2 is distribution of the defects in different flaps. Out of the 30 cases, in 9 patients we have done SSGs, in 9 patients local random flaps, in 10 patients regional pedicle flaps, and in 2 patients free flaps. Out of the 9 cases of SSGs, 5 defects were on the dorsum of the foot, and 4 were on the midfoot, and in hindfoot 0. On local random flaps, 6 flaps were done on the defects present on the plantar aspect of the forefoot, 2 on midfoot and 1 on hindfoot. Regional pedicle flaps, 1 defect on the dorsum of the foot, 2 on plantar aspect of forefoot, and 7 on the hindfoot. Among the free flaps, 1 was done on a defect on the dorsum of the foot and another one a defect on the hindfoot. Various reconstructive procedures done on the patients. Among the local random flaps, 4 were VY advancement, 2 were rotational flaps, 2 were transposition flaps, and 1 was a keystone flap. Among the pedicle flaps, 7 was medial plantar artery flap, and 1 was dorsal metatarsal artery flap, and 2 were toe fillet flaps. Out of the free flaps, 1 is a radial artery forearm flap and 1 is gracilis muscle flap. This table shows the complications of different flaps. These are the outcomes of different flaps. The aesthetic outcomes was assessed by using the Likert scale on the basis of 4 parameters: the color match, skin contour, scar, and bulkiness of the flap. The functional outcomes were assessed with the help of 3 parameters: the pain by using the visual analog scale, activities of daily living by using the Likert scale, and the quality of living by using the Likert scale. These are some of the photos showcasing our works on the reconstructive methods. This is a case of VY advancement flap with a defect over the plantar aspect of the forefoot. This is a rotation flap. This is a transposition flap. This is a keystone flap. This is a case of medial plantar artery flap. This is a toe fillet flap. This is a DMTA flap, dorsal metatarsal artery flap. This is a free radial forearm flap done after the resection of a malignant melanoma of the foot. This is a free gracilis flap done due to a chronic wound because of trauma over the dorsum of the foot. These are few complications. First is a wound dehiscence due to VY advancement flap, which was managed with local dressing. Second is a partial flap loss in a medial plantar artery flap. My conclusion: the aesthetic outcome was more satisfying with local and free flaps than with pedicle flaps and skin grafting. Flaps provide a stable, supple, durable, and a sensate coverage. The free flaps offer the most extensive reconstructive capabilities. Regional or free flaps bring better functional recovery. The wound complication rate in local random flaps are higher as compared to the regional or the free flaps due to higher degree of tension and insufficient soft tissue padding. The limitations of my study is the sample size was small, so it was difficult to test the substantial comparisons. Follow-up of the patient was done only for a period of 3 months. Hence, the long-term complications and the durability of the skin graft or flap could not be assessed. Thank you.
Thank you. We have time for 2 short questions. Yes.
Hello. So you have mentioned in the inclusion criteria that is 1 to 15 centimeter. Okay, so and you have mentioned this as a local regional flap and all. So do you think 1 centimeter square wound can be closed primarily?
On the dorsum of the foot, we can close it primarily, but on the plantar aspect of the foot, maybe due to tension, there may be wound dehiscence further on. So,
But I think 1 centimeter wound also can be closed primarily. And one more thing, is this your thesis topic?
No, sir.
Okay, because so elaborative discussions were there.
Any other question?
You studied, sensory recovery of the class. How did you do that? And because 3 months period, I think is a less time to evaluate that.
Yes, sir. Just by asking the patient whether he is able to feel the sensations or not.
Okay, fine. Thank you.
Thank you, sir.
To that question, how do you quantitatively assess the sensation? You have talked to the qualitative, but how quantitatively you assess the regain of the
by
sensation?
2-point discrimination test.
One of the methods. Other methods? Okay, there are filaments.
Lips, your time is already over. Right? Thank you so much. The next speaker is Dr. Surya Yashashwi. May we have the...
Good morning. I'm going to present my paper on a versatility of anterolateral thigh flap across diverse defects. So as we all know that since its description by Song in 1984 and elucidation of the vascular anatomy by Cormack and Lamberti, ALT free flap, as a free flap, it has been widely recognized across the globe. And it is a reliable flap because it has a large area of skin and it has a variety of anatomy. That means it is customizable flap so that it can be used for reconstruction of various defects. So it was well described in literature for defects of head and neck, mainly oral carcinoma, buccal mucosal and tongue reconstruction as well. And apart from that, it was also described for various defects of lower extremities, upper extremities, breast, etc. In this presentation, we review our 4-year experience with the use of anterolateral thigh flap as free flap and as well as pedicle flaps. And our aim was to highlight the ALT free flap versatility and its efficacy in addressing reconstruction of various defects. And our objective was to evaluate the form and function of ALT on follow-up. So ours is a retrospective study. We had 52 cases operated in the last 4 years with ALT. And we have evaluated and identified the usage of this flap in the reconstruction of various defects, apart from those required for head and neck reconstruction. Demographic information, pathology, the anatomy, the number of perforators, recipient vessel used, and the flap outcome were taken into our consideration. And these were the number of cases that we have done in the last 4 years with ALT. It has been an increasing trend, but it mostly depends upon how the patient presented to us and what the stage of the disease was and what the location of the tumor was. So if we consider the oral, tongue and buccal mucosal reconstruction as a single entity and the rest of the reconstructions as a different entity, it has been almost equal in number in the last 4 years. And recently, till December 2024, we had about 7 other indications apart from the tongue and buccal mucosal cancer. So coming to our indications, majority of the cases, 55% were used for tongue and buccal mucosal, which is tongue as in total or near total glossectomies, because hemiglossectomies we have been doing radial artery forearm free flaps. And buccal mucosal reconstruction in 23% of the patients. Apart from that, other indications such as foot defects, Marjolin's ulcer of the scalp, distal leg defects, mid-leg defects, palatal fistula reconstruction, Fournier's reconstruction, and BKS stump defect were also done by us. So this is one patient where we had to reconstruct both the dorsal and plantar aspect of the foot. And we had done a coaptation with the lateral cutaneous femoral nerve with deep peroneal nerve. And 6 months post-op, we had a very good sensory recovery. So mid-third leg defects, this patient has presented to us with a bad crush injury of the mid-third of the leg, where we had to do multiple stage debridement for wound optimization along with the negative pressure wound therapy. And we harvested a 45 into 10 centimeters large elongated ALT flap, and they have covered it with the ALT, suprafacial ALT, as a result of which we had a loss in the distal part, for which we had to use BTM and negative pressure wound therapy, and outcome was very satisfactory after 1 year follow-up. So we can see this patient who has a very good outcome. Next, distal leg defects also were done, and this particular patient had venous congestion, for which we had to do negative pressure wound therapy for the salvage of the flap. Distal forearm distal forearm margolin ulcer reconstruction. This particular patient, non-healing ulcer, margolin ulcer of the scalp, where the dura is exposed. We can see the pulsatile dura. For this, we had to use TFL as a dural substitute, and which had a very good outcome. We had done the anastomosis with superficial temporal vessels. This is a PBC hand release, for which we had done suprafacial ALT. The flap was contoured into the shape of the defect, and this is used as a pedicle ALT for reconstruction of scrotum in post-Fournier's debridement. So this is a palatal fistula, for which we had which was communicating with the nasal cavity, for which we had to harvest a very small ALT, 18 to 4 centimeters. Initially it was bulky, but on follow-up we had the flap has settled very well. So this is for reconstruction of post-traumatic hand amputation, and this is for BKA stump defect. So Parry-Romberg syndrome, so again we had to use facial artery and internal jugular vein as recipients. So we had a variety of cases where see a tongue, near total and total glossectomies were reconstructed with a very good outcome. So buccal mucosa also, we have been doing a lot of cases. And this particular case, the anterior tonsillar pillar, posterior pharyngeal wall, the buccal mucosa, everything was used and was reconstructed, and we had used the vastus lateralis to obliterate the dead space in the maxillary antrum. Our observations were 80%, more than 80% were males, and mean age was about 30 to 50 years, and mean flap area, the flap area was about 80 to around 150 centimeters square. Perforator origin, we could see about 86% of the patients had the perforator's origin from descending branch, and others were oblique branch. 29 perforators, 29 patients had single perforators, 34% had 18 perforators, 9.6% had single perforator, 3 perforators. And the type of perforators also 52%, 31%, and musculocutaneous was 28.7%. So majority of the cases, 52% were musculocutaneous perforators. About 4 patients, 7.6% had venous congestion, arterial insufficiency in 2 patients. So it is important because it has consistent vascular anatomy and the large skin paddle. It is reliable because it supplies large area of skin. And people like us, it is important because it has a steeper learning curve, for which people like us will be able to do it in a better way. Thank you.
This paper is open to questions.
So how many of these patients were from trauma and how many from the tumor group?
Yes, sir. So traumatic case, like I have not in this study separated, differentiated between trauma cases and tumor cases, because majority of the cases, about 55% of the cases that we did are of oral head and neck reconstructions, particularly the carcinoma of the tongue and the buccal mucosa. But the other indications also had cancer, because non-healing ulcer of the forearm, non-healing ulcer of the scalp, all these are marginal ulcers, these are also squamous cell carcinomas. So we have done a variety of trauma, mostly pertaining to the foot, distal leg and the mid leg defects, which were which were lesser than less than around 30%, because we have been doing a lot of cancer reconstruction lately.
Okay, so do you think there is a difference in the rate of complications in these two groups?
Yes,
and
sir,
if
definitely.
So, why?
So the flaps that we had unfortunately lost were trauma cases because of venous congestion mostly.
Dr. Surya, one thing is, what was the purpose of this presentation?
The purpose of this presentation, we wanted to show our experience with the use of ALT flap across various defects from head to toe. We just wanted to show that this flap is reliable in reconstructing many defects over across the various defects across various parts of the body.
Thank you.
Thank you, sir.
Yeah.
Dr. Surya.
What
One
is the
last
chance
question.
of sensory recovery in a case of free flap when you are not doing any knob coaptation?
Sorry?
When you are not doing any knob coaptation in a free flap,
yes.
So what is the chance of sensory recovery?
When we are not doing,
Yeah.
so sensory, that our experience with nerve coaptation was very good, but then we have not tried to assess how many patients had a good sensory outcome for patients for whom we have not attempted a nerve coaptation. Thank you.
Dr. Surya, the rationale behind using ALT as a filler in Parry-Romberg.
Sir, we have had options of having a parascapular flap initially. Then we thought we'll go ahead with an ALT because of we wanted to have a control over the bulk of the flap as well. So we went ahead.
Parry-Romberg is a very unstable disease over a length of time, not just this 1 year or whatever. So today the whole thing has swung in favor of autologous fat grafting, not flap cover.
Yes.
So that's why I was a little worried about
this. We had done in our initial days 4 years ago. So
this happened 20 years ago. The
yes.
conclusions.
No, we wanted to.
Yeah. Okay. That's okay. Thank you.
Thank you, Dr. Surya.
Thank you, sir.
Speaker is Dr. Prem Prakash Malik. Can we have his slides, please? Your time starts
Very
now.
respected teachers, good morning. I am going to present a paper on aesthetic outcome of gynecomastia by using conventional suction lipectomy and institutional experience. First of all, gynecomastia is a benign enlargement of male breast. It affects roughly 1/3 to 2/3 of the male population at some point of their lives. It occurs in invariably severity that occurs in men of all ages. The condition can negatively impact quality of life, patient satisfaction, and has been recognized for many decades. It occurs mainly in 3 age groups, infants, pubertal, and old age. In infants, it affects 60 to 90% of infants. It is transient. It resolves usually by 1 year, and it is due to the transplant placental estrogen. In pubertal gynecomastia, it starts from 10 to 17 years. It affects 1/3 to 2/3 of the adolescents. It is due to the relative estradiol excess to testosterone. 90% of these patients resolve within 3 years of onset. The old age gynecomastia is due to the hypogonadism or drug therapy. It occurs mainly at age group of 50 to 80 years. Coming to objective, to assess the aesthetic outcome of conventional suction lipectomy on grade 1 and grade 2 gynecomastia. Materials method, study setting in our IPD, period of study 2 years, that is 1st October 2022 to 30th September 2024. Study population, patient admitted to IPD during the study period with grade 1 and grade 2 gynecomastia. Inclusion criteria, grade 1 and grade 2 gynecomastia, age group 18 to 35 years. Exclusion criteria, grade 3 gynecomastia, patient not giving consent to participate in the study, cardiologically and neurologically unstable patient. My sample size is 45. Materials method, study tools like bedded tickets, IPD tickets, we took history and diagnosis, laboratory reports like clinical parameters and radiological findings. We use a breast evaluation questionnaire to assess the patient satisfaction and aesthetic outcome. In methodology, we admit the patient in the outdoor and examine and grade the patient according to the severity. We do routine investigation, blood parameters, ultrasound and FNAC. After fitness for surgery, we transfer them to the OT, infiltrate the tumescent. Then we aspirate by the conventional suction tubing and machine. After the aspiration, we use do gland excision and we do not give any sort of drains. We do compressive dressing for at the time for OT, and after that we admit the patient to 3 days, and after that we discharge with a compressive dress We follow up usually after the 3 months of the to assess the aesthetic outcome and patient satisfaction. Materials method, study variables. The predictor variables are patient age, patient BMI, grade of gynecomastia, preoperative breast asymmetry, total operating time, volume of fluid aspirated. The outcome variables are time of surgery, amount and type of aspirate, pain, hematoma. The best aesthetic post-surgery are scar, symmetry, flatness, nipple areola complex, and patient satisfaction. Statistical analysis are done in Microsoft Excel and analyzed in SPSS version 20.0. Coming to results, the characteristic like age, the mean age was 29, the BMI was 28.3, the grade of gynecomastia more in the grade 2 patients. The obesity is most common comorbidities in my study. There is 38% of patients having the history of smoking. Surgical details, 22% patient complains of pain after mild pain after 7 days of surgery. And the hematoma occurs in 0.04%. Post-infection rate was very low. Seroma is also very low. The amount of fluid aspirated is more than 500 ml usually. Coming to patient satisfaction for before and after the operation using our best evaluation questionnaire. We evaluate the patient according to the appearance of the chest, appearance of chest by dressed and undressed, and appearance of chest dressed and undressed by doctor and patient. The green line shows the post-operative line and the red line shows the pre-operative line. We used to give the score of 5 if they are satisfied, 0 if they are unsatisfied. The patient satisfaction with specific chest features post-operatively, that symmetry, numbness, nipple and areola complex, shape of the chest, flatness and scars. The red line shows the pre-operative satisfaction and green line shows the post-operative satisfaction. Coming to instruments we use the conventional instruments like the tubing we use hospital supplied by the hospital. Coming to our few of our works, this patient complains of he not able to wear the tight t-shirts, so he came to us for the liposuction and we did liposuction in this patient and patient satisfaction after the 3 months. The upper row shows the pre-op pictures and the lower row shows the post-op pictures. This patient was teased by his colleagues when he was not wearing any t-shirt, that's why he came to us. Then we did surgery, the upper lobe of the pre-op and the lower lobe of the post-op. This patient was primarily gone to the psychiatry OPD for depression, but after evaluation they sent to us and we did the liposuction for this patient and patient was satisfied after the surgery. Conclusion, suction lipectomy and glandular excision using conventional tubing resulted in satisfied patient and acceptable outcome according to the observer ratings. It could be useful alternative with an outcome that correspond to the more expensive methods. My limitations, there are small sample size. This is a single center study and based on single surgeon, and there is a single technique. Thank you.
This paper is now open for questions.
How do you make the nipple size horizontal same on the both sides?
Sir, we choose one point and we align both the nipples on the same line, sir.
To align it properly? Do you have any parameters for that or you just on a clinical appreciation?
On a clinical assessment, sir. Yes, sir. We counsel the patient, sir. If he is more unsatisfied, then we do it. Or if he is satisfied to wait, then we allow them to wait. Sir, sorry, sir. So we usually do pre-anesthetic check of blood investigations, FNAC and ultrasound, sir. FNAC to rule out any other pathologies, sir.
What other pathologies you suggest, think of?
Maybe
apart from this?
Just to confirm, sir, gynecomastia and rule out other pathologies.
My question is, while you do you do liposuction and gland removal, right?
Yes, sir.
So, do you have the idea of what type of cannula you use, like which cannula you use for this?
We use a Mercedes-Benz type cannula.
Which size?
Uh,
For infiltration, you know, but I'm asking about for
five
the
mm,
liposuction, 5 mm. Do you use 5 mm, then after 4 mm, or only 5 mm?
No, sir. Actually, we are doing it in a government setup, so we don't have so much sophisticated instruments so that we can use it.
So you're using normal liposuction?
Yes, sir.
Not micro?
No, sir. The tubing is
Yeah.
also, sir, we use normal PVC tubing. We don't have any silicon tube access. So we're in a...
Hello?
Yeah. Next question. Yeah.
Sir, I have a question. Did anyone ask for a nipple areola reduction alone?
No, sir.
None of these patients
No,
are.
sir.
Did you offer anybody?
No, sir.
Have you done one anytime?
No patient asked him. Next question.
My question is, do you have any experience with this drug-induced gynecomastia? Have you come across any case?
No, sir. We have excluded all those drug-induced and older age patients, sir.
That was an exclusion. Next question.
Yes, sir.
In your presentation, you have told that doing liposuction by conventional tubes. What is your inference? Means what is your
Sir, in a
suggestion?
government setup, it is...
no, that is...
we can
So,
use...
because when we do liposuction and particularly in a gynecomastia, the fat quality is different.
Sir.
So even with doing the liposuction and conventional silicone tubing, we are facing difficulties. Those who do gynecomastia, they know. So what is your aim of the study, or what you want to give the message that is it as effective as doing the liposuction with a silicone tube?
Yes, sir. It is as effective as silicone tube.
So have you compared?
It was an observational study, sir.
No.
No, sir. I have not compared because silicone tube was not available, sir.
Okay. Thank you.
Thank you, sir.
Thank you, Dr. Prabhu. The next paper is, starts now.
Good morning. I'll be presenting assessment of surgical outcomes and quality of life following immediate breast reconstruction using autologous tissue. As we all know that breast cancer is one of the most common cancer in women, making up to 25.1% of all the cancers. And so the benefits of breast reconstruction are holistic, which includes improving body image, femininity, mood and health related quality of life. Aims and objectives: to assess surgical outcomes regarding flap survival, post-operative donor site pain, scar, health-related quality of life following immediate breast reconstruction. It was a prospective observational study with a sample size of 17. The study duration was 24 months, and the data collection tool were patient proforma, VAS score, POSAS, and rescue questionnaire. The inclusion criteria were females diagnosed with stage 2, 3, 4 carcinoma breast undergoing a skin sparing, modified radical mastectomy, with the age group being 18 to 65 years. And the exclusion criteria, which they don't consent for reconstruction, smokers, uncontrolled diabetes and hypertension, post-radiation, or any previous scar at the possible donor site that can adversely affect the outcome of our flap. The first picture is what we have designed as a modified latissimus dorsi myocutaneous flap with skin pattern being designed in a manner of Asiatic day flower petal shape. Then the lower image is a transverse rectus abdominis myocutaneous flap. It's a pictorial representation. And deep inferior epigastric artery flap. The results, the mean age was 40.06 years with a mean BMI of 23.22 kg per meter square. 8 patients received neoadjuvant chemotherapy, 4 patients underwent a skin sparing mastectomy, and 13 went modified radical mastectomy with right more than left, and the HPE was invasive carcinoma, invasive ductal carcinoma with no specific type. The duration of surgery in minutes were more for DF flap, that is 548.33, and for LD flap it was 447.85 minutes. Out of 17 patients, we did 7 latissimus dorsi myocutaneous flap, 9 DF flap, and 1 patient we did tram. For DF flap, we chose mainly internal mammary artery and vein. In 1 patient, we did thoracoacromion artery and vein. And 1 patient, we had to use cephalic vein as the
donor vein because the inadvertent injury to the internal mammary vein. So in terms of complication, two patients had partial fap necrosis. One patient had acute arterial insufficiency, which was re-explored immediately, and the flap could be salvaged. One patient had venous congestion. In that patient, the flap could be salvaged with re-exploration. In one patient, the alternative vein was used because intraoperatively we decided because of inadvertent injury to the internal mammary vein. And two patients had a wound dehiscence, one in donor side and one at the breast. In terms of pain score, we saw a gradual decline over a period of 6 months if in both LD and DF flap donor side. With more, the VAS score was higher in the patient who underwent a DF reconstruction. In terms of breast-Q questionnaire, there was a significant improvement in the psychosocial well-being and the satisfaction of breast following reconstruction. But there was physical well-being of abdomen, though the scores are saying that it has increased, but it shows that there was a significant donor side pain and discomfort in the post-operative period. So this is the individualized graph which showing the psychosocial well-being and the satisfaction with the breast. The patient 12 to 17, we saw that we see that there is a lesser satisfaction with the breast in the post-operative period because mainly these patients underwent reconstruction using a latissimus dorsi biocutaneous flap, which do not provide a significant volume to the breast. This is the breast Q using the latissimus dorsi for latissimus dorsi flap. And we also assessed that breast Q questionnaire whether there is any difference in the quality of life and the scar symptoms. So we found that patient with scar symptoms like pain, itching over the scar, they have relatively lower overall satisfaction, psychosocial well-being than the patient who don't experience these kind of symptoms. So this is the POSS score we did for DF flap, but it didn't show any significant difference between the breast scar and the abdomen scar. These are few clinical images. This is a lady with right breast carcinoma who underwent reconstruction using DF flap. That is a 6 months follow-up image. This is another case. This is a young female of less than 30 years. She was unmarried and she underwent using a DF flap. Then latissimus dorsi myocutaneous flap. And this is one tram flap that we did. In this we had supercharged this with thoracodorsal vein, but there was some thrombosis and there was partial flap necrosis as I mentioned, and we had to discard zone 4 later on. So discussion in a study with UJ et al. They also showed that the latissimus dorsi flap reconstruction has significantly lower rates of general and aesthetic satisfaction than the abdominal based flap. Dopplet and all, they had some other instrument for the analysis of quality of life, which showed that the quality of life following only mastectomy is less than the quality of life with reconstruction. Zong et al. Showed that the mastectomy with immediate breast reconstruction can protect the patients from a period of psychosocial suffering, dissatisfaction with body image and with sexual life as compared to those who underwent a late reconstruction. And Everas KE et al. In 2021 showed a statistically significant worse POSS scar appraisal for the abdomen scar than the breast scar, which in our case was not that significant. The limitation of our study was a smaller sample size. Other autologous flaps and implants were not studied. There was a shorter duration of follow-up, asymmetry of the breast as patients were reluctant to undergo a contralateral mastopexy. None of our patients opted for nipper reconstruction, and comparison with those who underwent only mastectomy was not done. Our study showed a better health-rated quality of life in women who underwent immediate reconstruction based on DF flap than LD flap. Thoracoacromion artery can also be taken as an alternative vessel for microvascular anastomosis. Though DF flap provides a good volume, but it also leaves a longer scar, and patients should be adequately counseled about this, and they should be taught about the scar management in the post-operative period. Our patient with scar symptoms showed lower breast Q than those with less or no scar symptoms. And so the worse the scar, the poorer will be quality of life. Thank you.
Thank you, Dr. Priyanka. This paper is now open to questions.
Is this word autologous necessary in this presentation? Do you have any non-autogenous tissue to reconstruct?
Yes, sir, autologous is necessary because we have not used implants.
Yeah, so you should have said with or without implant. Autologous is not the word used for comparing.
I have one question. So you have used the POSA scale, right? So can you tell me the full form of the POSA scale?
Patient observer scar assessment scale.
Okay. So patient, there is one scale of patient and there is one scale of observer. But you have mentioned here particularly what I saw in the discussion, there is a patient scale.
Yes,
Where was
only
the observer
patient.
scale? Okay.
No, we have not
Okay.
taken the observer scale. We have taken only the patient scale to assess whether the patient is having symptoms pertaining to scars or not, and whether that symptoms are affecting their quality of life or not.
Fine. Good.
See, these are, techniques, so, quite distinct. So naturally one produces less volume, others not. So how can be compared? You already know the result. Any other criteria you use for patient satisfaction or any other criteria you use?
No, sir. Actually, it was not like a comparison between two flaps. It was just observing the outcomes when we are using two kind of flaps.
One more thing is when you are doing a pedicle flap, that is done for a certain type of patients, with a certain size of the breast.
Yes, sir.
So did you take that into consideration that they will be well suited for that category and compare that with the DF? We can suit it for all the categories.
Sir, actually, it was very difficult for us to counsel the patient on the first part for reconstruction because none of the patient initially opted for it, and then counseling them to have a longer scar, taking a bulk from their lower abdomen was also difficult with explaining all the pros and cons pertaining to the surgeries that they might need re-exploration and all those things. And secondly, the harvesting of internal mammary artery. So when patients, they were reluctant for that, then we opted for a latissimus dorsi flap in those patients, despite of the volume and all those things. Where we found that there is like a significant, a total skin, there won't be any skin envelope. So there we tried to counsel them for reconstruction using a DF flap because they need like a proper coverage. So it was difficult for us to counsel them on the first place for reconstruction.
Thank you.
So the next, Dr. Vishnu Swaroop Reddy. Can we have his slides, please? Vishnu, your time starts now.
Good morning, one and all. Today my topic is a comparative study between proximal radiocephalic and brachiocephalic arteriovenous fistulas in end-stage chronic kidney disease in patients undergoing hemodialysis. So we all know hemodialysis stands as a crucial life-sustaining therapy for end-stage renal disease patients, and in these autologous arteriovenous fistulas have become the gold standard for hemodialysis. As we all know, distal radiocephalic arteriovenous fistulas are the more commonly used fistulas because of its lower complication rates and higher patency rates. From this, we had few questions to answer. What if there are no suitable vessels to perform distal AV fistula, or if there is a patient who has come with a failed distal fistula? Then we funnel down to more categories where when to perform a proximal fistula, or are there any criteria available for it? And why do surgeons prefer brachiocephalic AV fistula as a second option immediately after if a distal fistula has failed? So our main purpose of the study is, can we give an extra option for the surgeons? So the aims and objectives of the study are to look for an additional option comparable to brachiocephalic AV fistula, which is already being done. To compare proximal radiocephalic and brachiocephalic arteriovenous fistulas and evaluate which procedure is superior to the other. Our method of study was a prospective randomized control study over a period of 2 years, and sample size was 37 patients, of which 18 were in proximal radiocephalic AV fistula and 18 in brachiocephalic AV fistula group. So we have included patients from 15 to 70 years with failed or exhausted distal veins, and we have done a preoperative Doppler in all patients. Patients with inadequate caliber of distal vessels were also considered for, according to the Doppler study, were also considered for this. Exclusion criteria was amputation of extremities or any advanced peripheral disease, artery disease in the patient, and with inadequate caliber of proximal vessels or damaged proximal vessels, and if the vessels were already cannulated before, and patients who were lost to follow-up. So in the preoperative Doppler, the parameters used were, according to National Kidney Foundation guidelines, diameter of artery less than 2 mm, diameter of vein less than 2.5 mm, and any presence of thrombosis or stenosis of the vein, we consider doing a proximal fistula directly without doing a distal fistula. So these are the two groups. This is a pictorial representation and a clinical picture, proximal radiocephalic and brachiocephalic AV fistulas. And these were the parameters used to assess our study: the demographics, comorbidities, reasons for the creation of proximal fistula, proximal radial artery diameter and vein diameter below cubital fistula, cubital fossa among proximal radiocephalic AV fistula patients, mean fistula diameter at 6 weeks, mean maturation time, association between the diameter of the artery and the maturation time, and complications and interventions. Of these, we have observed that these three, the mean fistula diameter at 6 weeks, mean maturation time, and association between the diameter of artery and the maturation time, were found to be significant. So at 6 weeks, the proximal radiocephalic AV fistula group had a mean diameter of 5.38 mm, while the brachiocephalic AV fistula group had a mean diameter of 6.35 mm. So according to the rule of 6, we have designed the rule of 6. According to rule of 6, it is at the 6-week period, the maturation time of 6-week period, anything above 6 mm, we have considered it as a matured fistula. So the mean maturation time of brachiocephalic fistula group was 6.32 weeks, and the proximal radiocephalic AV fistula group was 7.88 weeks. And from this study, arterial diameters of greater than 4 mm were associated with lesser maturation time as compared to those with less than 4 mm arteries which had higher maturation time. So these were the diagram, tabular and pictorial representation of the results, as mentioned with the significance of p-value. Barring a few complications, mainly Steele syndrome was found to be the most common complication, mainly in proximal radiocephalic group of these fistulas is considered when compared to the distal fistulas. And there were two studies mainly which compared proximal fistulas, where proximal radiocephalic group has lesser complications like Steele syndrome mainly compared to the brachiocephalic group. And in Eldisoki et al. Observed in 16.7% in brachiocephalic group, and there were no Steele syndrome was observed in proximal radiocephalic AV fistula group. As the previous guidelines suggested, brachiocephalic AV fistula as the second option to distal radiocephalic AV fistula. But in our study, our follow-up was only 3 months. In these 3 months, we have not observed any Steele syndrome, or we had only minor complications like hand edema, nothing much apart from it. So our limitations of this study was we had a very small sample size, shorter follow-up period, that is 3 months. We couldn't assess the flow rate and flow volume, which was also included in the National Kidney Foundation guidelines. And we couldn't assess the how difficult it was to cannulate among these two groups once the fistula has matured. So to conclude, brachiocephalic AV fistula, as everyone knows, exhibits superior maturation rates and shorter maturation periods according to this study. But proximal radiocephalic AV fistula can be preferred for its anatomical preservation, giving an extra option in spite it having a longer maturation times. Proximal radiocephalic AV fistula can be used as a second choice of AV fistula reconstruction after distal radiocephalic AV fistula, or it can be used as a first choice when distal vessels are exhausted or not appropriate before going to a brachiocephalic group, AV fistula. Thank you so much.
Thank you. This paper is now open for questions.
Dr. Vishnu, how did you preoperatively assess the diameters of the
So that is totally based on the preoperative Doppler findings, sir. Yes, sir. It was a protocol. We made it according to the study. We did Doppler, preoperative Doppler, and postoperative Doppler for all the patients in our study group, sir. Postoperative Doppler, we did it at 6 weeks. If we found the diameter of the fistula was less than 6 mm, we repeated it after 2 weeks.
Dr. Vishnu.
See, radial artery. No, please go.
So you told postoperatively you assessed the diameter of the fistula. At what level you exactly measured the diameter of the vessel? At the site of anastomosis, or how long away from the anastomosis?
Sir, usually according to the rule of 6, we have 6 things we have to keep in mind, sir. One is 6 weeks to be the maturation period.
No, my
yes, sir.
Question is exact.
Yes, sir. 6 mm.
Specific.
Yes, sir. 6 mm would be measured at around 6 centimeters from the segment, single segment, 6 centimeters. We will measure the diameter, sir. And it should be very superficial, at
from
least
the anastomotic point.
Yes, sir. And 6 mm from the skin surface.
Okay. And I have a second question. So whether all the cases were operated by a single surgeon or multiple surgeons, because there will be a bias if different surgeons conducting vascular anastomosis.
Not a single surgeon.
Dr. Vishnu, I have one question. So you said failed AV fistula.
Yes.
So these failed AV fistula, were they acute failures where the surgeon performed the fistula, they thrombosed, or these failures were after the fistula worked for a while, for 2 months or 1 year and failed? Have you categorized?
Yes, sir. We categorized between primary failures and secondary failures.
So these were primary failures? Or
no, sir. It was mixed. We had both the categories.
Because if it's mixed, the problem with the secondary failures is that all these veins, proximal veins, have been cannulated multiple times.
Yes, sir. We have excluded that kind of patient, sir. We have seen that there is no cannulation. According to my study also, there is an exclusion criteria I have mentioned, that any cannulated vessels proximally we have excluded from the study, sir.
But see, cannulation has to be done. If the fistula is successful and you are doing AV fistula, means you are doing dialysis, after 1 year, you are bound to cannulate the thing. So I think those cases have not been taken up in this.
No, sir. We have excluded those cases.
Dr. Vishnu,
yes, sir.
One thing is proximal radial artery. It is in the depth.
Yes, sir.
And it has also multiple muscular branches.
Yes, sir.
What do you do with this?
Sir, the level of dissection, I would say it is difficult compared to brachiocephalic, which is much superficial. But when our main aim was, rather than the difficulty in dissection, we want a better second option, because these patients would need prolonged dialysis, sir, for longer periods. So our aim was to find an extra option for the patient, even though for surgeon it's slightly difficult to dissect and bring it out.
One more question. Was it side-to-side anastomosis?
End-to-side in all the cases, sir. End-to-side in all the cases.
Brachiocephalic fistula should be done electively without doing a proximal radiocephalic fistula in all these cases.
No, sir. I would suggest giving an option, sir. We usually, after distal radiocephalic fistulas are failed, surgeons usually prefer and go to brachiocephalic directly, sir. So there are many other options also available. This is one such option, sir. So I would like to consider doing a proximal radiocephalic artery AV fistula rather than going to brachiocephalic AV fistula, because in this study the follow-up period was only 3 months, sir. Probably on a prolonged follow-up period there might be any complications. According to other studies in a review of literature, any fistula going with higher flow rate has given Steele syndrome as a complication. In these 3 months we couldn't find many, and none actually.
Brachiobrachial fistula done in your case series?
Brachiobasilic, sir.
Brachiobasilic?
No, sir, not included in this study, sir. We have done, but not included in this.
So why did you not?
So that is also an option. Even that is a high flow fistula, sir, because we are going above the cubital fossa and
so
brachial
that is
artery.
usually not done because of this reason.
Exactly, sir. Thanks.
Next speaker is Dr. Anisha Ganguly. Dr. Anisha.
Esteemed judges, seniors and faculty members, today I shall be presenting our experience post-burn contractures of the neck from flexion to function. Post-burn contractures of the neck are one of the most common sequelae that affect not only the form but the ability of the patient to function. They lead to severe functional, cosmetic, economic and psychosocial implications that lead to the disruption of the well-being of the patient. The normal range of motion of the neck ranges from full flexion to full extension to approximately 130 degrees. The aim of our study was to determine the post-operative functional and aesthetic outcomes after incisional-excisional release of post-burn contractures of the neck. We sought to evaluate the extent of improvement in neck movements pre and post-release and also to compare the scar quality using a split-thickness skin graft versus a dermal substitute plus split-thickness skin graft by the Vancouver Scar Scale. This was a retrospective single-center study done at the Departments of Burns and Plastic Surgery at our institute from June 2022 to June 2024 with a sample size of 16. We accessed the demographic details, the pre and post-op clinical photographs, surgical details from the medical records department and followed up the patients for a variable period of 6 months to 1.5 years post-surgery, recording our progress and their progress with clinical photographs and videos. The Vancouver Scar Scale attempts to evaluate scars with the parameters of pigmentation, vascularity, pliability and height with a total score of 13. The lower the score, the better the scar quality. We included all patients 18 years and above with post-burn contractures of the neck who were willing for surgery and capable of consenting. Coming to the results, we had predominantly female patients with 14 out of 16 patients were female with the age range of 18 to 60 years. We sought to reconstruct these defects after release with one group having STSG alone and the other group having dermal substitute with STSG. This is a tabular representation of the results that we obtained with respect to improvement in movements in terms of extension, lateral rotation and lateral flexion of the neck. We also evaluated the scar quality by the Vancouver Scar Scale. A few clinical photographs. This patient was a 28-year-old female presented to us with extensive contracture of the neck which was released and a Polynovo BTM was applied with skin grafting after 3 weeks. These are the post 6 months follow-up after the patient showing neck extension. Another 38-year-old female patient who came to us with contractures of the neck was treated with Polynovo BTM and STSG resurfacing. These are the 8 months post-op follow-up of the patient showing extension of the neck. This 11-year-old boy came to us with a severe anterior contracture of the neck. Split thickness skin graft was harvested from the right thigh. These are the post-op day 14 and the post-op follow-up at 14 months. A female patient, 22 years old, who came to us with this extensive contracture of the neck was resurfaced with an STSG. These are the post-op follow-up pictures after 1 year. The short video where we used Polynovo BTM for coverage of the neck defect in an acute setting, where BTM was applied after debridement and kept in situ for 3 weeks. The delamination of the silicone layer was done after 21 days, followed by split thickness skin grafting. The patient was then post-debridement. These are the, moving on to the discussion. Resurfacing with both split thickness skin graft and dermal substitute leads to a significant increase in terms of neck movement in terms of extension, lateral flexion and lateral rotation. But the difference between the two was not statistically significant. While we moved to the Vancouver Scar Scale evaluation of the scar, we saw a significant difference in the scar quality with terms of pliability and pigmentation in patients who were resurfaced using a dermal substitute and a split thickness skin graft. As in accordance with the study carried out by Patnagar et al., in our study as well, resurfacing with split thickness skin graft led to a significant increase in neck movements. Dermal substitutes, although an expensive alternative, provide improved scar quality by providing a dermal template over the defect. In this study, it was observed that patients where dermal substitute was used along with a split thickness skin graft showed better scar quality as per the Vancouver scar scale in terms of scar pliability and pigmentation. This is in accordance with studies by John Hood et al. To conclude, I would like to say that dermal substitutes are reliable in reconstructing post-burn contractures of the neck as an effective adjunct with split thickness skin graft for better scar quality. These are my references. Thank you.
This paper is now open to questions.
Achha, in interrupt, how you decide your one contrast the release is adequate or not?
So we start, first of all, we start by preoperatively, we place for the positioning of the patient. Yes, sir.
Yeah.
We place shoulder rolls under the patient with multiple head rings under the head of the patient. Once our contracture release is complete, we sequentially remove the head links and then assess the adequacy of the neck release.
Dr. Anisha, you mentioned in your methods that you did incisional release.
Yes.
But in one of the cases I found
Excisional, sir. Incisional and excisional both.
both were done. Okay. Now, just one thing that comes to my mind. You're talking of dermal substitutes, whereas in your cases I probably did not detect an attempt to preserve the fat, subcutaneous tissue, because that is the most important component. If you preserve that, it gives a better equivalence in terms of the skin graft quality, pinchability, Vancouver criteria. So that you have not spelt out. So you've talked about dermal substitutes.
Yes.
Very expensive.
Right.
When you have expensive stuff in the neck itself. Okay.
Did he use any, scar therapy after the skin grafting was done?
Yes, sir.
So all these patients, they will be requiring, massage,
Yes,
using
sir.
pressure garments,
Yes, sir.
planes.
Yes, sir.
So all the patients he used all the three modalities.
Yes, sir. All three modalities.
So did you find the response that every patient followed up the same way?
No, sir. The compliance is definitely
Compliance?
is different with different kinds of patients. We did, but it was a mixed bag, sir. With both groups, dermal substitute and STSG, the compliance was a mixed bag. There were patients who were very compliant, who used silicone gel sheeting, post-operative scar massage, pressure garments in both the groups.
And did you find that one of the group was, even if you don't use, the results are better?
So in a dermal substitute application, even if the patient was not very compliant, we did observe that the quality of
Should have
scar was-
mentioned that.
Yes.
Thank you.
Thank you.
Okay, my question is, you said the scar quality was better when you used dermal substitute.
Yes, sir.
That means you are giving credit to the dermis, the substitute, which is giving more stability to the
Yes.
scar. So what is the source of this dermis?
So in the dermal substitute that
Yes,
we use,
yes, yes.
so this is basic. It's not a biological substitute. We use Polynovo biodegradable temporizing matrix, which is a polyurethane-based substance which provides a scaffolding for the growth of the wound bed into the scaffold and provides a better bed for the skin graft to be placed upon.
So how do you get this extra dermis? This is a substitute.
Yes, sir.
This is biodegradable.
Yes, sir.
So this, for this scar stability, you require dermis.
Yes, sir.
This is just providing a scaffolding.
Yes, sir.
What you have added is only a thin layer of dermis.
Yes, sir.
So if I put a full thickness graft,
Yes, sir.
would I get a better result than the dermal substitute?
It is possible, sir, but with full thickness skin grafting, the area that requires to be resurfaced is very large once the contracture is released. So harvesting that size of a full thickness skin graft would not be.
So what happens in the long run about this, the substitutes that are put, say 1 year later, is there any remnant of these tissues in the body or everything gets resolved and completely gets replaced?
So it gets reabsorbed into the wound bed within 3 weeks to 6 weeks.
So is there any remnant of this product, say 1 year after if I do a histology?
Further studies would be required to assess that.
Doctor, you did excisional release as well as incisional release. In which group of cases you found better outcomes as well as the function and aesthetics was concerned?
In terms of better functional outcomes, are excisional release is better.
And in some of the cases you use analogs, dermal analogs, and you did the skin grafting much later.
Yes.
So did you compare the excisional release and immediate grafting and a delayed grafting with dermal analog?
Yes, sir. That is the last patient that I showed the clinical photographs. That's an excisional release and immediate grafting, who had great results.
So compared to that,
Yes, sir.
release and dermal substitute, what were the results?
Dermal substitute still had better scar quality.
Thank you so much.
Thank you.
Actually,
Yes.
actually one more addition, as Bibhuti sir told, you can apply full thickness skin graft in the neck. If you don't have full thickness skin graft, we are thinking that sufficient skin is not available. You can take a full thickness skin graft on thigh and apply
Cover
SSG
it with
from other side. That will give a better result.
Yes.
Thank you. May I now invite Dr. Gayatri Mahalik, and maybe have the slides of Dr. Gayatri.
Good morning, respected teachers, seniors and colleagues. Today I am going to present topic outcomes of the wrist-crease incision for thinner crease, wrist-crease versus thinner crease incision for CTS relief. On introduction, CTS is the most commonly, frequently encountered entrapment in neuropathy, and the etiology is largely structural, genetic, biological, environmental and the occupational factors. And the main symptom of the CTS is intermittent numbness of the thumb, index and the long fingers and the radial half of the ring finger. And the 6 diagnostic criteria include nocturnal numbness, numbness and the tingling sensation in the median nerve distribution sites, weakness or the atrophy of the thinner muscles, tinel sign and the Phelan sign, and the loss of 2-point discrimination at the site of median nerve distribution. And for early CTS, the non-surgical treatment such as splint or the local steroid injection is usually recommended. However, surgery is recommended when there is rapidly progressive thinner muscle atrophy and the hand dysfunction, and persisting severe symptoms even after the conservative treatment for 2 to 7 weeks. And the persistent symptoms are a sign of disability which is evident on electromyography or aggravated 2-point discrimination. And it is my study was a type of prospective comparative study, and the period of study was from May 2024 to November 2024, which was conducted at the Tertiary Care Hospital. And the aim and objectives were, this study was to address the comparison between the distal crease incision and the thinner crease incision for the decompression of the carpal tunnel syndrome, with the criteria which includes the criteria for patient selection, intraoperative and the postoperative complications, and the improvement of the symptoms, aesthetic aspect of surgery, and the functional outcome in the follow-up period. Methods, inclusion criteria included all the symptomatic CTS with Phelan test positive for 1 minute, and the nerve conduction study, which are indicative of definite CTS. The exclusion criteria included the pregnant patients and the patient having definite mass in the carpal tunnel, patient having a history of hand trauma, recurrent cases, and patient with previous upper extremity surgery, and the patient with concomitant proximal nerve compression syndrome. The preoperative evaluation included all the patients who included who underwent nerve conduction study, ultrasound of bilateral hand, and all the serum electrolytes, CBC and RBS, and the viral markers and the thyroid function test was also done. The surgical technique, 2 groups are formed, and all the procedure was performed under local anesthesia. Group A included short transverse incision in the distal crease ulnar to the palmaris longus of the size 1.5 to 2 centimeter, whereas group B included incision at the Kaplan's cardinal line at the thinner crease with the incision size of about 3 to 4 centimeter in length. This is a picture of the marking for the wrist crease and the thinner crease incision. Post-operative splints were not included in all the patients, and patients were encouraged to use the hand normally, and heavy activities were avoided in first 20 post-operative days. This picture shows the method of thinner crease incision release after post-operative day 15 and follow-up up to 1 month. And this is by reduced crease incision release, the carpal tunnel syndrome with post-operative day 15 and after 1 month follow-up on the patient. In my study, women 27 number were in 27 number and men were 3 and with a mean age of 40 years. And on intraoperative complication, wrist crease nerve injury was present in one case, whereas in other cases where intraoperative complications were not seen. And on post-operatively, hematoma was present in wrist crease incision in one case, and recurrence was there in 2 cases of wrist crease incision, whereas hypertrophic scar was seen in one case of wrist crease incision, and thinner crease incision, 2 cases had hypertrophic scar after follow-up. And after 1 month follow-up, the improvement of symptoms was seen in 13 cases out of 15 cases of wrist crease incision, and 15 cases of all the 15 cases of thinner crease incision, they had improvement of symptoms, and aesthetic outcome was good in all the cases, and nerve conduction study was also improving, and recurrence was seen in 2 cases of wrist crease incision. On results, the mean surgical time from the skin incision to the closure was shorter than 30 minutes, and the patient who underwent a wrist crease incision, they returned to work after 7 days of surgery, whereas those with thinner crease incision returned to work after 11 days average of after surgery. And observation, recurrence rate was not found to be statistically significant between the 2 groups with a p-value of 0.1443, and recovery was not found to be significant statistically between the 2 groups with the p-value of 0.56. Aesthetic outcome was also not significantly statistically significant between the 2 groups with a p-value of 0.12. On conclusion, the difference between the 2 surgical incisions was was found to be statistically insignificant, but in thinner crease incision we can appreciate the anatomy of the nerve, and it will also allow to divide the ligament completely under direct observation without any neurovascular complication, and also any anatomical aberrations can also be easily identified in this case by using this procedure. And the limitation of study was a small sample size and short duration of follow-up in the patient. This is my reference.
Thank you. Now this paper is open to questions.
So, so you have mentioned about the injection Kenacort. So do you still use injection Kenacort, because while the patient will present to you, so what's the most common presentation of a CTS?
Numbness will be present, and also night pain will be most commonly the present of night pain.
Numbness. So the patient, when it comes to numbness, already it would have been grade 3. So that is the advanced stage. So how do you still will use intralesional Kenacort, or?
No, sir, directly.
No, then there is no use of okay, fine. So then one more question. For the after this, when you release the CTS, what is the ligament you cut?
So the transverse carpal ligament.
Okay.
I have a question. Excuse me. I have a question. In the clinical assessment, did you mention provocative tests for proximal entrapment neuropathy?
No, so proximal, I will see the function of the muscles, that is the FCR and FDB to the second finger, sir. Muscle I will check for the weakness to assess the proximal compartment.
There are provocative tests for that. Okay.
Well, considering the proximal compressor neuropathy, what is the next common median nerve compression syndrome in the forearm of the wrist?
Sir, in that Lacertus syndrome, sir. Lacertus syndrome.
Median nerve.
Median nerve.
Pronator teres.
Pronator teres, sir.
The question I really wanted to ask is, now you said that the common cause of median nerve compression is in the carpal tunnel.
Yes.
And you also want to exclude if there is a mass effect in the carpal tunnel also. How do you do that?
Sir, I will go for ultrasound. If there will be any swelling present, sir, then I will exclude the case.
Yes, I think ultrasounds should be considered as mandatory investigations besides the nerve conduction syndrome.
Sir, in my study, sir, I
You
did
have
that,
not
but
done
I did ultrasound of the, but it's
did-
not mandatory in every case of
No, no,
CPS.
you did not mention.
Sir, in pre-operative evaluation.
See, there will be nerve compression in nerve conduction studies, delayed latency, okay, and all those things. But supposing you think that there could be some cases where other things like flexor tenosynovitis in rheumatoid arthritis, in all these cases, you have to rule out this, and if required, you need to go for open approach. What I'm trying to tell you is that will give you an indication that this patient needs an open approach and this cannot be done by closed approach. Do you understand? Do you?
Dr. Gayatri.
Do
Dr.
you?
Gayatri. I'm.
Construction study along with the clinical symptoms.
Clinical
sir.
evaluation. By any chance, did you examine the cervical spine in these patients?
Cervical spine.
Should be examined, no? Because some patients may mimic as carpal tunnel syndrome in these patients. So how did you ensure safety with a risk-free incision? Because mostly it is a blind technique. So how did you ensure safety of the technique?
Sir, the ligaments are lifted with the use of instruments. Sir.
What instrument you use?
Sir, that CTS ligament lifting that instrument.
What instrument? Fine. Thank you very much. Thank you. Thank you.
Conventional and teaching is you have to follow the just parallel to the thinner crease, that is 5 millimeter, just to avoid injury to the motor nerves. Okay, that is a conventional. I think you want to disprove it. For that matter, you wanted to take up the study.
Sir, I wanted to show that with thinner crease,
Because
sir, with thinner crease approach, sir, blind, it will be not any more blind operation, so we can see the ligament
But you know,
properly
there
with
is also a 5 millimeter away from the thinner crease. That is, they know that, no?
Yes, sir.
Okay. Still you
Thank you, Dr. Gayatri. Now the next speaker is Dr. Binay Bhushan Sahu. Can we have Dr. Sahu, your time starts now.
Good morning, respected teachers. Today I am going to present a topic on comparison of skin graft tech by conventional dressing versus VAC. Skin grafting is widely used for wound coverage and reconstructive surgeries. Success depends on graft tech, bed preparation and post-operative care. Challenges with conventional dressings are suboptimal graft adherence, risk of seroma, hematoma and infection formation, graft displacement due to shear forces. VAC therapy was introduced in 1990s to address these issues of conventional dressing. My aim seminar objectives are to evaluate whether the VAC therapy improves graft tech, reduces complication and reduces hospital stay compared to conventional dressing. The inclusion criteria are wound deemed fit for split skin grafting, size less than 20 to 20 centimeter square, age 10 to 55 years. My exclusion criteria were non-bleeding tendency, raw area for head and neck area, allergy to dressing used in the study, age less than 10 years and more than 55 years, size more than 20 to 20 centimeter square, immunosuppressed patient, grossly infected wounds. Study design. It is a type of prospective randomized hospital-based study. It was conducted from January 2023 to November 2024. 60 skin graft cases were taken. 30 were divided into conventional dressing group and 30 were divided into VAC dressing group. Material and methods. Initial debridement of wound will be done surgically with dressing done with betadine saline. Once healthy bed of granulation is seen, SSG was applied. After SSG was laid, patients were divided into control group, that is VAC dressing group and conventional dressing group. Conventional dressing protocol. SSG was secured to the recipient side using circumferential staples. Then a bolster is applied to over the graft. The bolster is typically made of non-adherent dressing, that is yellow net, layer about SSG with betadine soaked cotton balls and sterile gauze over it. Based on the location of injury, bed rest and slab was advised to keep the area immobilized. Dressing changed alternatively or regularly depending upon the sockage. VAC dressing protocol. SSC was secured to the recipient site using circumferential staples, followed by placement of a non-adherent dressing, that is Gelonate. The baked sponge was cut to match the contour of the wound and secured to the surrounding skin. Continuous negative pressure was ensured by connected tubing through a vacuum pump in the form of portable unit bag machine, and suction pressure would kept at minus 100 millimeter mercury. Creation of effective negative pressure confirmed by watching of collapsed foam and absence of any gushing of sound air leak. Bag removed after 5 days and dressing done. The dressing in both groups were opened and percentage of graft take was assessed on 9th post-operative day. Statistical analysis. Data analysis was performed using statistical analysis tool SSPS statistics. A two-side p-value less than 0.05 was considered significant. Results. Age range from 10 to 55 years, 41 male and 19 female were taken. Mean age in the case was 37.14, control was 35.23. In vac dressing group, 24 male and 6 female were there. In conventional group, 17 male and 13 female were there. In vac dressing room, 11 patients were 10 to 40 years, 19 patients were more than 40 years. In conventional dressing room, 13 were 10 to 40 years, and 70% were more than 40 years. Nature of wound. In both groups, most common cause was traumatic, then burn, then diabetic, then infective causes. In my study, in both the groups, most common location of wound was foot, then leg, then upper extremity, then back, then abdomen. Seroma formation was nil in vac dressing group. In conventional dressing group, that is 16.6% cases. Hematoma formation was 6.6% in vac group and 23.3% in conventional group. Infection formation is 3.3% in vac group, 6.6% in conventional group. Average hospital stay post SSC was 10.94 days in vac group, 17.23 days in conventional dressing group. Maximum area of defect is 20 into 14 centimeter square in vac group and 20 into 16 centimeter in conventional group. More than 90% graft take on post-operative day 9 was 93.3% at 28 cases in vac group and 83.33% 25 cases in conventional group. Regrafting was done in 2 cases of conventional dressing group. These are my post-operative. This is diabetic fault ulcer of left foot. This is post-traumatic area of dorsal left foot. Vac dressing group is the post-fasciatum wound, post-infective area. This is a conventional dressing group, post-bone area of abdomen. Observation. Graft take was found to be superior in vac group, that is with p-value 0.22, but which is not significant. Hospital stay is increased in conventional dressing group, but p-value is 0.0145, which is significant. Seroma formation is decreased in vac group. Seroma formation, hematoma and infection all are decreased in vac group, but statistically not significant. Reoperation rate is increased in conventional group, but is not statistically not significant. Limitation of the study. Patient to patient variation of wound is there. Long-term follow-up is not obtained. Large size not included in this study. Extreme of age are not included in this study. Head and neck area also not included in this study. Conclusion. Though the study tilt towards vac dressing of our SSG, but statistically in the measure of graft take and complication profile are not significant. But study showed significant improvement in the hospital stay. Further study required for large surface area, head and neck area study, and with long-term follow-up. Thank you.
This paper is open for questions.
Excuse me, doctor.
Vinay.
Dr. Vinay, one thing is, did you do meshing, that is meshing of the skin graft?
Sir.
It was done.
Sir.
Meshing was done.
Sir. Meshing 1.3 to 1.5 is to 1 ratio.
Okay, fine. So that's okay. And for the conventional dressing, sorry, I couldn't follow. How did you fix the dressing?
Sir, conventional dressing first meshing was done, then skin was fixed to the recipient side using skin stapler. Then over it the gelonate was applied. Then betadine soaked cotton ball was applied over it. Then sterile gauze and soft pad also applied.
Did you use any pressure dressing?
In limb, for limbs, sir, dressing with slab given.
Did he use tie-over dressing for any patient?
Tie-over dressing are done in one case of abdominal dressing, sir. Tie-over dressing.
Now coming to VAC, how does VAC work, for retaining skin graft?
Sir,
What is the mechanism?
there is a strong, tight graft bed interface due to negative pressure. So there is a reduced formation of hematoma, infection formation, and there is a decreased bacterial load due to negative suction. It promotes angiogenesis and fix the graft and reduce edema. So it is slightly better than conventional dressing, sir.
Dr. Vishnu.
Sir, I randomly choose any wound, sir. I not differentiate fresh wound with this therapy or chronic wound this therapy. I randomly choose for any patient for VAC or conventional, not on no specific height.
In one of the slides you have shown, there is gross hypertrophy in the scar, in the dorsum of the foot.
Sir.
And on the slides you have mentioned that hematoma and infection are more in the conventional growth.
Sir.
So another thing I want to mention, have you taken into consideration the meshing of the skin grafts? And does it have any effect on reducing the hematoma and the outcome of the study? What is taken into consideration?
Sir, meshing reduces the seroma hematoma formation, but still there is seroma and hematoma.
I mean 1:1, 1:2, 1:4, 1:5.
Sir, meshing
Was it standardized? Was it standardized?
1.3:1 or 1.3 to 1.5:1 meshing.
So my question is, what is the normal pressure of a NPWT what you keep?
80 to minus 125 millimeter mercury.
Okay, it's minus 75. Okay.
In my case, minus 100 millimeter mercury.
Who decided that minus 100? I'm asking, who decided that 100?
Sir,
and is there any study which has the comparison study or any previous study which you had compared that it was the minus 100 taken for the study?
Sir, one article shows minus 100. It was fixed. Then I was fixed for this study, sir. Minus 100.
You haven't cited that. Okay,
yes,
fine.
there is study, sir.
Okay. So next question, my last question. Hospital stay you have written that is a significant.
Sir.
Okay. So who decided that hospital stay? You obviously you will be biased, no, while deciding the hospital stay.
No, sir. Wound.
Okay.
Nature of wound. Sir, nature of wound. If graft is healed, wound is healed, then
last question, Dr. Jaina.
Yes.
Sir.
Why did you decide to compare the wounds on after 9 days? Why not earlier? Why not late?
Sir, the neovascularization rate, the imbibation, inescalation, neovascularization, it is completed around 9 to 10 days, sir.
So did you keep the VAC for 9 days?
No, sir. VAC for 5 days. But the wound assessment is done on post-op day 9, sir.
Okay, so after this 5 days of VAC therapy, you went on for
dressing, alternative dressing, sir.
Okay.
Thank you, Dr. Sahu. So in this session, we are going to take one more paper, which has been preponed from the post-lunch session. Not post-lunch session, a later session. It is by Dr. Satyabrat Mohanty. And the topic is management of congenital hairy nevus. This is 8 minutes plus 2 minutes for discussion. So, Dr. Satyabrat, it is not a competitive paper, so he has to take a flight, so that's why we have rescheduled his paper.
Good morning, respected chairpersons. I thank you all to sit here since 8 a.m. constantly, and I trouble you for next 8 minutes. Please bear with it. And thank you the organizing team to invite me from Jaipur. Now I'll discuss about pediatric nevus. This is commonly called congenital melanotic nevi. There is cluster of melanocytes may be visible at birth, but sometimes it tardive, means it appears after a few years. It's due to there is less melanin pigmentation inside the lesion. And large nevi is a high risk of malignant melanoma. So there is classification: small up to 1.5 centimeter, then medium 1.5 to 19.9 centimeter, large is more than 20 centimeter, and giant is more than 40 centimeter. So coming to the etiology, it is unclear. This is dysregulated migration and proliferation and differentiation of melanocytes in skin and leptomeninges. It is due to activating NRAS mutation in Q61K and Q61R amino acid substitution, overexpression of hepatocyte growth factor, that is HGF, and scatter factor by c-MET proto-oncogenes. So incidence of melanoma is around 2.5%, highest with giant wadding the trunk around more than 60 centimeter, greater in first 3 years of life. Chances of melanoma is greater in first 3 years of life, and a peak occurs in adolescence also. So neurocutaneous melanocysis express excess deposition of melanocytes along with along the leptomeninges, high risk of large CMN and posterior actis. More than 20 satellite nevi will be present. Developmental delay and hydrocephalus and seizure also present in leptomeningeal disease. MRI during infancy is advised, and periodic lifelong follow-up is required. Now coming to small to medium, it is round to oval, homogeneous pigmentation, light to dark brown, sharp borders, rugged surface, and hypertrichosis. And large CMN may show asymmetry, irregular border, multicolored pigmentation, rugged texture, and nodular surface. So histopathologically, CMN involves nervous cells of deep dermis, subcutaneous fat, and appendages, nervous cells between collagen bundles, and nervous cells poor subdermal zone. Acquired nervous has limited to dermis. So patient selection, risk of melanoma in small and medium is approximately nil. So wait until child is fit enough to undergo excision under local anesthesia. And area which are cosmetically sensitive, we have to operate before school going age, because patient may feel ashamed in front of their friends. And large and giant nevi begin treatment as early as 6 months because there is great risk of malignancy. One thing I want to highlight about the malignancy, all the studies, they don't show there is less chance of developing malignant melanoma. But cutaneous melanoma chances are reduced. Leptomeningeal melanoma, non-cutaneous melanoma chances are not reduced after excision also. So treatment options are those are small, serial excision, debulking of the lesion, and excision with split thickness skin graft. This is cosmetically not appealing. Dermabrasion, curated chemical peel, and lasers. And tissue expansion, this is a workhorse in medium sized nevus, and free flaps for cosmetically sensitive areas. So now coming to the partial thickness excision, large and giant nevi, we usually do partial thickness excision, but it has not a good result. Early dermabrasion, curettage, and laser, leaving underlying subcutaneous fat, minimizing contour deformity. So then serial excision. For small lesions, we can do a serial excision, use inherent vasculoelastic properties of the skin to stretch over time, and small to medium with laxity of the local skin, we can excise with serial excision. Then for the large lesions, we have to excise it and apply split thickness skin graft if it is in the trunk or in the back. Then full thickness skin graft. We can use a full thickness skin graft in face if we are not efficient for microvascular surgery, or I have done these two cases in the same month. One is microvascular and one is full thickness skin graft. This is the full thickness skin graft I had taken from the arm, and I applied skin graft, split skin graft over the arm. So you can appreciate the final results, though it is not as good as microvascular or free flaps, but result is acceptable to the patient after 1 year. Then if it is involving nose, we can go for nasolabial flaps and Limburg flaps for small lesions. You can see we can easily do Limburg flaps. Then tissue expansion is the best option for large. Some principles are there. Donor site must be free from infection, have stable scar. The incision should be placed in the margin of the nevus and the normal skin. Partial filling of the expander, 10 to 20% of the listed volume. Proper position without folds. Close suction then for 2 to 3 days we use. Serial injection started continuous for 10 to 12 weeks, and waiting period is 4 to 6 months. Scalp expander pocket in the subglial plane above the periosteum. Port placement is preauricular area. In the face, we use the non-affected area, usually the neck, and eyebrow as lightened through the laser over time. This is the expander of the scalp. We have used this expander. And this is another expander for the face. We cover only the facial areas and left the hair bearing areas. This is another case of expander of the face. This is a final result after 2 expansions. This is another expansion. This is another case of tissue expansion. We have done a second stage surgery in this patient, and this is a final result. This is another expansion of the from the medium size, and for the trunks also expansion can be done, and from the for the axilla and arm also. You need multiple stages after expansion, but good cosmetic results. This is expansion of the shoulder and the back. These are for extremities, it is difficult to do expansion. So flaps, and if it is affecting the thigh, we can place it in the lower abdomen also. And this is free radial forearm free flap. We usually do in facial nevus, we usually prefer a radial forearm flap because ALT is somewhat bulky. This is another case of free flap. This case I have compared in the same setting. This is another case. We have left the eyebrow and done the free flap in the forehead and the face. This is another radial forearm free flap. And other therapies are topical therapies, but not so much effective. Now these are the challenges you left to all to what to do in these cases, because there is tissue expander is also difficult, and multiple microvascular surgery may be needed in these patients. So again I invite you all for the rhinoplasty conference we are organizing on 31st and 31st of January and 1st of February at our institute. I am the organizing secretary. Thank you.
Thank you. This paper is open to questions.
Dr. Mahanti, considering that the lesion is limited to the skin, why should you think of a full thickness, why didn't you think of a full thickness skin graft like I said?
Yes, I have done in full thickness skin graft.
Why did you choose some of these cases for free tissue transfer?
Sir, the full thickness skin graft results, the cosmetic, if it actually it is affecting the face and you need a large full thickness skin graft. I have shown you the results. The result is better in expander and microvascular radial forearm. Cosmetic result is better. but facial appearance, facial expressions are better in full thickness skin graft, because after radial forearm, facial expressions are not present on that side, but cosmetically it looks good. But in full thickness skin graft, you can have the facial expressions also. So I have done both cases, and both are satisfied with their results. At the same time, within a span of week, we have done these two cases. So this is interesting, same size, same site, opposite side of the face.
What will you infer? Which is better? So the acceptance.
Sir,
of the
it's
patient.
if facility
Considering
is,
that you are taking
yes,
a pre-radial flap, which also produces a lot of cosmetic
yes,
Cesarean ladies.
Sir, in my opinion, expander is a best option, a tissue expander. And if patient want a single stage surgery, we can go for microvascular radial forearm. And if we have a doubt, because neck vessels are very good, you don't have any, these are virgin vessels, so we can go for microvascular flap. So all these are options. You can choose according to your wish.
Thank you. Thank you so much. And with this, we come to the end of this most vibrant session of this conference. And while my co-chairpersons are making the results, and I have to make some observations that all the speakers presented extremely well. The overall standards of presentations were very high. The studies were, the studies were designed well, and statistical methods were also applied well. And the sample size was obviously shorter because you have a short stint in your colleges. And one point that I would like to mention was that most of you were reading verbatim from your slides, which should be avoided. You should know your presentation very well and use slides only for suggestions. And you must keep your introduction very short, and there is no need to greet when you are giving a competitive paper. And you must describe your study design well, and observations well, and the statistical method that you have used, discussions and clear conclusion. Too many examples and photographs will not add to your study, because you are doing a particular kind of a study that you have planned. But overall, I've attended many conferences, including our national conferences. I would say that all the presentations were of a very, very high standards, and you must keep it up. And that also reflects on the training departments over here, because all of them are mentoring their students well, and they're helping their students design their studies well. Thank you very much.
Participants for having really worked hard and come up with your papers. And three persons stood out for the clarity of presentation. I think that's very important. Couple of things, suggestions. One, please don't say coming to this or coming to that. Just come to it, that's all. And number two, please don't crowd your slides. Some of them, of your presenters, had too many stuff, It makes the audience go to sleep. So please don't crowd your slides. Put, valid points. And number three, please don't read out what's in the slide. Everybody is literate. Everybody can read. So please don't read out. You just sum up or add value to what is written on the slide. Yeah, that I think is very important in the years to come. When you keep on presenting later, that will really stand out, because nobody wants you to repeat all that is written. So please summarize or very nicely illustrate what you want to say. It's an opportunity actually. So yeah, that's about three things, but overall I think standard is very good. Thank you so much.
And one more thing. See, when you are presenting or preparing a slide, think that there are 1,000 people in the hall, and last people should be able to read your slide. So prepare the slide that way. Because most of the time we are sitting in front of the laptop and you are using. Sometimes we use a blue background and black letters because that I can read, but the last person cannot read. So see that that happens. And second thing is never use capital letters, all capital letters. Difficult to read. And use, see many people have used slides. They are so crowded it's difficult to concentrate. And you don't have to write so many things, history there, no. Write few salient points. And second thing is use 75% of your slide space. Make fonts bigger. And second thing is the comparison between the heading and the letter should not be too much. Because I think somebody had, many have used about 44, 45 font size and the others were about 20, 25 something. That differentiation actually doesn't look good because it's difficult to perceive. Okay, fine. Thank you very much.
One last point that I have to say that all three of us judges found it very difficult to choose one of you which will be the best. So I would say all of you were the best speakers. So these are the numbers that have been calculated out of our three of markings. So all of you did very well, but the numbers will be counted and results will come. Thank you so much.
Thank you, sir. Thank you, Subodh sir, Bhartendra sir, and Amresh sir for chairing a nice session of the PG Award selection. Thank you. Just now, sir, I request Subodh sir and Amresh sir to give a memento to Bhartendra sir. Yesterday, Bhartendra sir was not there in the program, so I request Subodh sir and Amresh sir. Please, sir. For Bhartendra sir, this memento. Dr. Satyavrat Mahanti, please come to the dais. You will get your memento from Subodh sir and also Amresh sir. NRO sessions yesterday you are not there also. Huh? Yesterday night, sir, actually we have felicitated our past presidents, except Falguni sir and Ramesh sir was not there. So I would like to request Falguni sir to come to the dais and we will felicitate it with the memento. Past president. Tripholaka book which is written by Falguni sir, a coffee table book, abstract photographs, painting and sketches, written by Professor Falguni sir. Tripholaka, as name suggests, is a loving production of three aspects of art: photographs, painting, sketches, created by Falguni Roy sir. Most of these are abstract in nature and do not indicate a superficial approach to the subjects. The themes range from everyday to the exceptional, capturing reality in many subtle nuances. They are aimed at anyone who might pick up the book to spend some pleasant time with it and to initiate a conversation with or without analysis. The entire proceeds from the sales of the book will go to the destitute home. Sakha. Thank you, sir. Thank you very much for this book. Next, I like to request Dr. Ramesh Das sir to come to the dais and we will felicitate as a past president. In the year 2017 and 18, he was the president of our association. Ramesh sir. Now we will have 15 minutes coffee break and we will go to all the stalls to visit there where the tea will be served. After that we will have a quiz competitions, Another Prasad Memorial Quiz Competition. The chairpersons will be Dr. Prithviraj Singh, Dr. Biswajit Mishra SEB, Dr. Santanu Subha. It will be coordinated by Dr. Lopamutra Maharana and Dr. Samir Patel. After 15 minutes, they are the quiz construct, but the chairpersons will be the three. Okay. Let us move to the stalls to visit all the stalls.
Call Gopika and Dr. Ahana to come and pick up chits. Anisha and Priyanka.
Dr. Gopika and Dr. Ahana are team F, and Dr. Anisha and Dr. Priyanka are team C. No, F.
मार्किंग कला अच्छे 1 2 3 4 5 1 2 3 4 5 जहाँ भी अच्छी कागज लिखी मार्किंग
Dr. Gayatri and Dr. Vinay. Dr. Gayatri and Dr. Vinay. Group B, Dr. Vishnu and Dr. Surya. Group A, Dr. Akanksha and Dr. Vidush. E, Dr. Shivans and Dr. Jyoti, you have now left is B. You are the fourth group. Quiz. Let me read out the rules for you. There will be 5 rounds in total, and 10 marks will be allotted for correct answers, and there is no negative marking, right? And questions consisting of 2 parts. Each part will be if there is a question which has got 2 parts, each part will consist of 5 marks. 10 seconds time will be given to you to think and respond after completion of the question. Question passed by the previous team will go to the next team, right? Marks will be given, but that will be half. I'm just
Members, you must be knowing that this quiz we have started in 2022 on behalf of our beloved professor, late Professor Ananda sir. You must be knowing everybody, he is very dear to everyone. Sir has expired in 2022. On behalf of him, we are doing this another memorial quiz every year, and it is going on very smoothly for 2022, 23, 24. So this is 4th quiz in his name. So I hope the teams which has been qualified, previously we were taking all the teams, but this time we have more number of teams. It's good, everyone is actively participating, and out of these, I think 6 teams has been qualified by the juries. So this is the final of the another memorial quiz, and this is being done by the association, and it will be done as decided by our associate our members. So all the best to all the participants. Let's start.
I request
all of you to please introduce yourself and your college. Team A.
I'm Dr. Surya SSP. I'm first year MCS Plastics in AIMS Bhubaneswar.
Dr. Vishnu, a senior resident in plastic surgery, AIMS Bhubaneswar.
I'm Dr. Binebhasan Sahu, SC Medical College, Kotak.
I'm Dr. Gayatri Mahari, second year MCH student at SCB Cutter.
I'm Dr. Priyanka Ban from AIMS Bhubaneswar.
Dr. Anisha Ganguly from AIMS Bhubaneswar.
We are Team D. I am Dr. Shivaram, second year resident from MKCC Medical College.
I'm Dr. Jyoti Ranjan Pradhan from MKCC Medical College.
We are Team E. I am Dr. Vidush Kumar, AIMS Bhubaneswar.
Hello, I'm Dr. Akanksha Rajput from AIMS Bhubaneswar.
Dr. Gopika Jit, AIMS Bhubaneswar. Good morning, I'm Dr. Ahana from AIMS Bhubaneswar.
Now we'll start the quiz. All the best to all the teams. We have 5 rounds. So first 5, all the pictures will be shown on the screen. So you have to see and you have to answer accordingly. And last round is a rapid fire round. The previous rounds each question carries 10 marks, but the rapid fire, each question carries 5 marks. And if it is passed, then the next team will get half marks for the question correctly answered. And rapid fire, there is no passing of the questions. So first round is pioneers of plastic surgery. You have to identify them. No, audience cannot. International plastic surgeon and tell one of his contributions.
Mekindo.
Time starts now for 10 seconds.
Mekindo.
No,
Mekindo.
no. The question is passed to team B.
Paul Tessier.
No. It's for team C. Okay, it's passed to team D. Team C and team, E, F, F.
Dr. Buck.
No. So it's open for the audience. Anyone? Yes, yes, yes. Sir, it's a request. Please raise your hand so that we have a small gift for the. Yes. Okay. Yes, sir. It's Auntie Jackson. Yes. The second question is for Team B. Time starts now. No, Team C.
Furman.
No, Team D. Please say loudly. I am not able to hear.
For the contribution of Tanish
First
selection of one,
identify the personality, then tell a contribution.
Jane Janko.
Yes,
Jankovic.
yes, correct. You have to also tell the contribution.
for tangential excision in the
Yes,
bonds.
very good, very good.
Jane Jankovic.
It's Zora Zanzikovic. Okay, very good. They get 5 marks. Team D gets 5 marks. Then question is for Team C. Identify this famous Indian plastic surgeon. Team C.
Professor C. Balakrishnan.
Very good. His contributions?
Classification of cleft palate.
Very good, very good. They get 10 marks. Then it's for team D. Identify this famous personality.
Harold Gillis.
Very good. One of his many, he has many contributions. Anyone?
Gillies principles of plastic surgery.
You can name a flap or anything.
Gillies flap.
Gillis fan flap.
Hand flap.
Okay, I give it. Team D also gets 10 marks. The fifth question is for team E. Time starts now.
Asoka.
No. Team F. Question is for team F. Pass. Pass. Team A.
Venkateswamy.
Yes.
Venkateswamy
Yes,
flap.
yes, very good.
Venkateswamy flap.
What flap? What flap?
Finger. Homodigital flap.
Neurovascular iron flap for the fingertip injuries. Very good. They get 5 marks. Team A. So next question is for team F.
Dr. Antia.
Very good, very good. And his contributions?
He gave surgeries for leprosy.
Very good, very good. And for helical rim defects, there's a chondro. Yes. Yes. There are 2 audience questions. This is one. Please raise your hands, anyone. So it's Sterling Burnell for hand surgery. Another question? Another fame? Yes, sir. Yes, sir. So we come to the end of the first part of the first round. This is the second part. You have to identify the instruments and tell its use. So identification carries 5 marks and use. So in the second part of the first round, you have to identify the instruments and tell at least one use. Okay? So we start with team A. First question, you identify the instrument and tell one use. Team A.
This is rose maxillary
Very
elevator.
good, very good. And one use?
Disinfection.
Yes, yes. 10 marks for team A. This is for team B. Time starts now. Team B.
Forceps.
Yes, one use.
Nasal venous. Fracture na.
Yes, yes. Or for evacuation of septal hematoma. 10 for team B. This is for team C. Team C.
This is used in rhinoplasty.
To name the instrument.
Yeah.
It's Afrix retractor.
Very good.
Used in rhinoplasty.
For retraction of the dorsal.
Dorsal nerve.
Okay. 5 marks to team D. Then direct question for team D. Timer. Okay, you pass
Sir,
it to
parietal.
team. No. Next team E.
Is this for microstomia?
No, no. Team F.
Skin retractor.
No. Team A.
Fibula retractor.
Very good, very good. For
For harvest of free fibula.
Not
For
retractor,
holding,
we-
for holding
yes,
the
yes,
bone.
yes. Okay, 5 marks for team A. Devised by whom? Very good. So this was for team D. Team D. No? So Direct question for team E.
It's hand splint to hold the hand while doing the surgery.
Has a name. Pass to team F.
Don't know.
Team A. Please don't prompt, please. Team A pass to team B.
Pass.
Pass.
Pass. So anyone from the audience? No, seti sir kale. Sir kale Vijay no sir. So this was for team E. Next question is for team F.
It's a needle holder.
No, no. Team A.
This is braider used in pulvertrap technique.
But what is it?
Braider. Braider.
Braider actually. But you have to use correctly. So
Braider.
should we give them or no? Sir, it a pass question.
Braid.
You have to name the
Braider.
no, no. Team B. Team C. Team D. He has already told the you. Team E. Okay. Anyone from the audience? Okay, it's a tendon passer. Huh?
Tendon.
Okay, I have a question for the audience. Yes, sir. Gilly steel for. Okay. Yes, sir. Doctor, sir. Okay, now, Samir, please tell the marks of round 1 after round 1.
Group B has got 10 marks in total. Group C has got 10 marks. And
So now we come to round 2. It's on aesthetic surgery. Just have to identify and name it. There are no parts. So if you identify, then it's 10 marks. Okay? So, okay, sorry. We'll start from team F. Okay? Time what? 10 seconds. So this is for team F. A 5-year-old girl. F row, F. F row empty. A 5-year-old girl has a ear anomaly showing a pointed helix and a third crust of antihelix. What is the most likely diagnosis?
Stall ear.
Very good. 10 marks for team F. This is for team E. Furnace conchomastoid sutures are placed for correction of which deformity?
Prominent ear deformity.
Very good. Prominent ear or bat ear. 10 for team E. This is for team D. Which type of graft should be placed for widening the nasal valve angle with an increase in both cross-sectional area and overall airflow?
Interpositional.
No. You have time. Okay.
Spreader.
Yes. Spreader. Team C gets, sorry, time was over. Team C gets 5 marks. Now this question is for team C. Markings for which procedure is shown in the picture?
A fluidilis abdominoplasty.
Yes, 10 for team C. Now direct question for team B. Name the procedures shown in the picture and what is it used for. Actually, if you identify, then you get 10. Team B. Yes, fast to.
Platysmal plication.
What?
Platysmal plication.
Yes, you can give it. It is platysmoplastic, cortical platysmoplastic. 5 to team A. Then team A. Direct question to team A. Markings for which type of incision for breast reduction is shown in the picture?
Inferior pedicle.
No, it has a name. You have time.
Vice pattern.
Yes. 5 to team F.
Question is type of incision.
Type of incision. Huh? Incision pedicle? No. F gets 5. Now from team A. Team A. Hotel team. Okay. Next question for team F. Team F. Identify the procedure of cleft lip surgery.
Millard's repair with molars modification.
Yes. No, just. Okay. Sir, should we give? Granted, sir is saying it's granted. Next for team E. How do you treat this condition and which muscle is targeted? You have to identify the muscle which is targeted in this condition.
This is zygomaticus major and levator anguli oris. So either
So what is done? It is not levator anguli oris.
zygomaticus major and minor, I think.
No.
Orbicularis oris.
No.
Huh?
What
वही
is
है ना,
done?
canine
What is done?
canine smile. This is
What is this?
canine smile. No?
Shall we pass? Next team.
This is, it's a gummy smile and levator labii superioris.
Very good. Team C, 5 marks. Then direct question to team D. Which laser is the gold standard for the shown condition? Team D. Be loud.
IPL.
No. Team C.
CO2 laser.
Yes. Team C gets 5 marks. Now direct question to team C. Identify the most common laser used to remove this.
NDAG, Q switch NDAG.
Yes. 10 marks to team C. Team B direct question. Identify this procedure.
FUE, follicle.
Yes. 10 to team B. Then direct question to team A. Identify the deformity and correct for this correction which muscle is targeted. What is this deformity?
Crow's feet.
Which muscle is targeted?
Orbicularis oris.
Very good. 10 for team A.
Oculi.
Okay. Yes. One audience question. Treatment they said, yes, Botox for the muscle orbicularis, but they didn't tell Botox. Okay, it's correct. I give 10 marks. Okay. So this is a wetting solution. What is the difference in solution between Kleen's formula and Hunstan's formula for wetting solution for liposuction? Yes. NaCl for yes, and RL. Yes. Chocolate to Unmiss. So Samir, please tell the marks after the completion of round 2.
Team A has got 35 marks, Team B has got 20 marks, Team C has got 45, Team D has got 20 marks, and Team E has got 10 marks, Team F 35 marks. Highest is now Team C, leading with 45 marks.
Now we come to round 3. Round 3 has, each question has 2 bits. Okay? So, yes, starting from A. So it has 2 bits, answering one, it is a direct question, answering 1 bit will give you 5 marks. If you answer both the bits, you get 10. And if it is fast, you have to answer both those questions bits to get 5 marks. Okay? So hand surgery, first question is for Team A. The above X-ray shows which type of deformity and mention the classification and the type.
Clinodactyly. Clinodactyly.
Delta phalanx.
Thumb duplication. Radial polydactyly.
Ma'am, what do we have to answer?
Blouse. Thumb duplication, Bloth classification, CMC joint is destroyed, 3C.
Now this is for Team B. Identify the deformity and describe. You can describe or you can tell the treatment also.
Ulnar dimelia.
It's a mirror hand.
Yes, mirror hand. Describe it or you tell the treatment.
In this, there is similar, like similar phalanx on both sides of the central ray.
Yes, yes, yes. 5 marks to Team C. Third question to C. Then direct question for Team C. Identify this pathology and what is the pathognomonic feature on imaging.
Clinodactyly.
Yes.
Delta phalanx.
Very good. 10 for Team C. Then direct question for Team D. Please don't prompt. Huh? You have to identify and tell one complication.
Hypertension of the distal phalanx, Schwannock deformity.
Mallet finger.
Ma'am, complication is Schwannock.
5 for Team E. Then direct question to Team E. What is a Jersey finger? How can you clinically diagnose this condition? Clinically. Everything is shown in the picture.
Jersey finger is FDP avulsion.
Yes, FDP avulsion. And how will you diagnose it clinically? Everything is shown.
There's a lag. The digital lag is there in when the patient is asked to flex the fingers.
Not flex.
On flex.
Can we give it? They have already told there is a
On flex.
lack of flexion of the fingers. Can we give it? Pass but do not get any marks. Like they have answered the diagnosis. So they get 5 marks. 5 marks. Anyone can tell you how you diagnose it?
We test for FTP by DIP flexion. But we can feel the tendon depending on what level it is cut. Sometimes we can feel the bony fragment or the tendon also here. we'll ask the patient to make a fist. Like he won't be able to make the fist. So there will be like there will be extension at the. Yes, is extended.
No, no.
But you said you asked the patient to flex. Okay, sir, Team F, what is this condition and identify the pathology? What is this condition known as and identify the pathology?
Dupuytren contracture.
No.
Or clawing.
No. Team
Claw hand.
No. Team D?
Nar claw hand.
No. They all are saying claw hand. Why are you repeating it? Team C?
Ape hand.
There's a name. Team D?
Apian deformity.
No. Team E?
Benedict's hand.
Very good, very good. Very good. And what's the pathology? Like what is the injury?
Median nerve palsy.
Very good. 5 marks for team E. This is for team A. Just a minute. Yes, this is for team A. Team A. No, out around. Team A.
Type 4.
Yes, type 4. And describe what is type 4.
It has a bifid at the level of middle phalanx. That thing at joint.
Now, marks after round 3.
Team A gets 35 in total. Team B gets 20. Team C gets 60. Team D has 20 marks. Team E has got now 30 marks and Team F is 35. So Team C still leads.
But they have answered correctly. Round 4. It will be 2 rounds, 2 set of questions. So we'll start from team F. Identify the flaps from the markings. Team F.
Singapore flap.
Yes.
Internal pudendal artery based.
Yes. 10 for team F. This is for team E.
Cutler beard flap.
Yes, 10 for team E. This is for team B. D. Team C.
Buccal myomucosal flap.
No. Very good. Team B gets 5 marks. Fam flap. Tell the full.
Electric myomucosal flap.
Then next question for C. This is for team C.
Orticogia flap.
Yes, pinwheel. Okay, we'll cancel this question. Yes. We'll cancel this question, sorry. So this is for team C. Team C.
Mustardy cheek rotation flap.
Yes.
Cheek advancement flap, sorry. Mustardy.
It's a rotation advancement flap. Yes. So 10 for team C. Then for team B. B. Pass to team A.
Dorsalis
Very
pedis.
good. 5 for team A. Now team A gets the question. Identify this flap. It has a name.
Cronin's omega. This is omega shaped flap. Rectangular.
Sir, shall we give it?
Omega
has
shape.
another name. Now you have to tell the name of this. If anyone answers, then they can also say. So team F.
Niranjan's bilateral wing.
Syndactyly release using seagull flap, seagull dorsal.
Given in green, same diagram.
Dorsal truncated flap.
No.
Seagull shape.
Lit.
Shall we give it to team A? Okay, team A gets the marks, but it's a globally class for the release of complete syndactyl. I don't know. So team A gets 10 marks. It's global leaf, but not we go to team F. Team F na? हाँ दिया है बना. Identify this flap. Team F.
This flap. Freaky.
Trapeze flap. Trippier flap, sorry.
Yes. 5 for team E. Now direct question for team E. Yes. 10 for team E. Team B. Team B.
Multiple.
You can see the second.
Butterfly shaped release of.
No. Team C.
Man flap. Jumping man flap. Jumping man flap.
Jumping man is what? It's known as 5 flap.
7-7 flap.
Very good.
7 flap.
Yes. No, no. Actually, one question was missed. So, okay, I have two questions. Shall we cancel? Okay, okay. So we have another question for team D. D, D. Identify this flap.
Carapansi flap. Gillis fan flap.
Fujimori gate flap.
5 for team C. Direct question for team C.
Bowler VY advancement, neurovascular flap, Littler's.
Team B. Team B. Team B pass to team A.
This is homodigital digital neurovascular flap.
Has a name of
Venkat Swami. Venkat Swami.
You say it loudly because I think passing it. So 5 for team A. This was for team C. So team B direct question. Identify this flap. B.
LD flap.
Thoracodorsal artery perforator.
5 for team A. Then direct question for team A.
Thoracoumbilical based abdominal flap.
Yes, yes,
Thoracoumbilical.
yes. 10 for team A. The thoracoabdominal flap. 10 for team A. I have a audience question. Only one audience question. Anyone, please. Any of you can also answer. Yes, Sohini. He hasn't answered. He just told that it starts with W. Yes, yes, yes. Yes. Chocolate after the initial letter. Huh, 4 rounds are over.
After round 4, after completion of 4th round, the marks are 70 for team A, 25 for team B, 75 for team C, team D gets 20 points, and team E has 55, and team F has 45. Team C still leads. 70.
Now we go to the rapid fire round. Rapid fire, you have to answer the questions within 1 minute. Each question carries 5 marks and there is no passing. Okay? No, I'll say just, I'll be clear, I'll be loud and clear. Multiple questions within 1 minute they have to answer. If you are not sure, then pass the question. Okay? I'll come to the next question and if there is time left, then I'll come to the questions that you haven't answered. Okay? So is my am I audible to everyone? Okay. So we'll start with team A or team F. So time starts now. The topical antimicrobial agent mefenite acetate is most likely to cause which major complication?
Metabolic acidosis.
Very good. What is the pattern of blood supply of flexor hallucis muscle according to Matthews and Nahi?
4.
Yes. In Z-plasty, what is the angle required to obtain 125% increase?
Pass.
Who introduced the pinch grafts?
Sorry?
Who introduced the pinch grafts?
Rivedin.
Very good. Steamer's sign is related to?
Lymphedema.
Very good. Kleinert and Verdun have classified extensor tendon lesions of the hand into how many zones?
7.
No.
Nine,
no.
nine, nine, nine.
No, it's wrong.
Pass.
Gold is commonly used in reconstructive surgery for?
Tarsal.
Gold is commonly used for reconstructive surgery for?
Tarsal plate.
No.
Pass.
Pass. Blowout.
Lag ophthalmosis. ठीक है, pass, pass.
Blowout fractures of the orbit are common in?
Pass.
Okay. How many correct answers? Okay. Now we go to team B. Time starts now. What is used to treat severe hydrogen cyanide poisoning?
100% oxygen.
You have to name the agent. Okay, fast.
Hyperbaric oxygen.
Androgenic alopecia in males is classified by? Don't know, pass it.
Pass.
Which nerve causes complete numbness of the ear lobule, most likely injured during facelift procedure?
Great auricular nerve.
Very good, very good. Chuang's angle is formed by?
Pardon, which angle?
Chuang's angle in brachial plexus injury.
Pass.
Groin flap is based on?
Superficial circumflex area pattern.
Very good. Self-inflating tissue expander was devised by?
Newman.
Pass.
Newman.
No. Prusansky classification is employed for? Prusansky classification is employed for?
Mandible.
No. Lymphedema tarda presence in? Lymphedema tarda.
More than 35 years. More than
Yes,
35
but
years.
time was up. Yes, you give it. Okay, how many correct answers? Okay. Now we go to team C. Central band and triangular ligament tear in extensor expansion of the finger results in?
Botany deformity.
Very good. According to Mathis-Nahi classification, sartorius is which type of muscle flap?
Segmental supply. Type 2.
No. Then abdominal wall reconstruction component separation was described by?
Ramirez.
Very good. Baker's flap is based on which artery?
Pass.
What is the most common complication using a smooth round silicone implant for subclavicular plane for breast augmentation?
Capsular contracture.
Yes. As per Mackinnon's classification, there are how many types of nerve injuries?
6.
Very good. Which is the most likely nerve injury and intrinsic hand muscle wasting with intrinsic?
Median. Ulnar nerve.
Sir, no. It is ulnar nerve. Triangulating sutures in vascular surgery was described by?
Carroll.
Yes. Blood supply of tensor fasciculata comes from?
Oblique branch of descending lateral circumflex femoral artery.
Yes.
Okay.
Wrong. Now we go to team D. How many correct for team C? 5 for team C. Team D. Name the procedure for repair of defects of the middle third of the auricle where a tunnel is made to insert the carved costal cartilage. No. In early management of burn injuries based on Jackson's model, which area of burn is most likely to benefit from aggressive resuscitation? 3 zones. Which is the lateral most tedious cleft? Trigonocephaly is caused by premature closure of which suture? No. Finger and palm incisions are described by? Burner. Okay. Then Rosen's score is used for interpretation of patient's functional outcome following which repair? Rosen's score. Pan flap for lip reconstruction was described by? Yes. Super microsurgery is a microsurgical anastomosis of vessels less than?
0.8.
Yes. According to Mathis-Nahi, gluteus maximus is which type of muscle flap? Yes, give it. Then for team, how many correct? Sir, 5 marks for correct answer. Which one was half set? Which one? team E. Okay, ready? Time. The Curie formula is a method for calculating the calorie intake. The Curie formula for patients between 16 to 59 is? Tell the Curie formula, otherwise pass.
25 into 40 plus
No. Congenital trigger thumb is treated by release of?
A1 pulley.
Yes. Aneurysm concept was proposed by?
Taylor and Palmer.
Yes. The most common fractured facial bone is?
Sorry?
Most common fractured facial bone is?
Nose.
No.
Nasal bone.
Yes, nasal bone. Rhytidectomy is the surgical procedure for correction of?
Facelift.
No. Grip strength is measured by?
Dynamometer.
Pass. Yes, dynamometer, yes. Macrostomia is associated with which cleft? Tesius cleft.
7.
Yes. The first use of word plasty was by? Use of word plasty. Plasty. By which?
Gilly.
No. Okay. Time up. How many correct? 5. For team F. According to Wallace rule of 9, the head and neck constitutes what percentage in children?
18.
Yes. Kite flap is supplied by? Kite flap.
Pass.
Transverse facial fractures above the level of the apices of the teeth, which includes the alveolar process, vault of the palate and pterygoid process in a single block is? Leaford?
1.
Yes. The faciocutaneous islanded flap based on skeletonized perforator and rotated 90 degree to 180 degree to reach the recipient.
Propeller flap.
Yes. Sensory radial nerve compression is known as? Sensory radial nerve compression.
PIN.
No, pass. Angular deformity of the finger in radio-ulnar plane? Radio-ulnar plane.
Clinodactyly.
Yes. Vascular zone 3 of abdominal wall is which?
The flanks, lateral.
Yes. Cauliflower ear is common in?
Perichondritis.
Yes. Who developed the very thin skin graft?
Pass.
Recipient pedicle for abdominal wall allotransplantation?
Recipient.
Okay. How many? 6. So we come to the end of the rapid fire round and also the quiz. So audience rapid fire. Okay, we have come to the end of the quiz. Now for the scores, you can come here.
Anyways, it might not be surprising who is the winning team, but I will go from the least marks first. Group D has got 35 marks and Group B has got 55 marks. Group F has got 75 marks. Group E has got 80 marks. Group A has got 90 marks. And last, Group C has got 100 marks. Congratulations to the winning team.
Team C is the winner and the first runner-up is Team A. Congratulations to all. It was a very close contest actually.
Thank you all the participants. Actually, it was a really marvelous competitions, and thank you. All are done very nicely, and thank you all the chairperson and co-chairpersons of the quiz competition. Thank you, Prithviraj, a lot from my heart. Actually, you have arranged so nicely this scientific committee. Thank you, Vishwajit. Santanu, Lupamudra and also Samir for arranging a very nice quiz competition today. It is memorable for all of us. Today is a very nice day, and I will request a photograph with all the participants and also chairpersons, president, secretary, and I think all of us. Then we will have another session for the sponsorer. This is very essential part of this, also one of the program. Then last session will be a miscellaneous program. Around three papers are there. Can we come to this dais and we will have a photograph? Can you switch on the lights? Switch on the lights.
Sit, sir, sit, sir. Yes, sit down.
TM to present the benefits of using biodegradable dermal matrix. Please, sir.
Everyone, I am Dr. Anirban Ghosh. I am an aesthetic plastic surgeon from Kolkata. So the topic is biodegradable dermal matrix in clinical scenarios. Now I start my presentation with the first slide, which says form follows and function. This is a famous principle by a famous architect, which says we should form a plan, we should follow it, and then we should get the best functional outcome out of it. Now there is a famous book on wound repair by Dr. Earl Peacock, which says we mammalian have lost the regeneration capacity. So whenever we have wound, it heals with scarring, it heals with wound contraction. Now coming to the basics of any wound healing, there are some phases of wound healing, right? Starting from hemostatic phase, then inflammatory, then proliferative phase, and maturation phase. This is all we have read during our pathology classes. Now, all the stages are interplay of certain cells of our body. Like initially, it starts with platelet, then neutrophil, followed by myofibroblast and all. Now, this is an important slide. How can we reorient the reparative process into regenerative healing, which should be the target for any kind of wound healing? So, the requirements should be, we should seal the wound. The wound should be sealed properly so that it heals well. Next is to minimize the inflammation of the wound. Next is, as we know, any kind of wound which is less than 2 millimeter, it regenerates. It doesn't have any scar, like the blood puncture wounds and all. There should be less of foreign body response. There should be enough cellular migration and neovascularization. The material which we use for dressing and all should be bioabsorbable. It should be biocompatible. The material should minimize wound contraction. That is, it should have a remodeling process. Another thing, we should try reconstituting it with a full thickness skin. Now, as we all know, big wounds, it heals with big scars. Complex wound, it heals with complex scars. Small wounds, it heals with small scars. Now, there are various technologies which are used for improving the quality of dermal matrix. As the past 2 decades, we have been using dermal matrix starting from 1990s. The first matrix which came in the market was Integra. which had certain technologies in it, followed by Matriderm, then this BTM. So all these dermal matrix, they use certain technologies like cross-linking, non-cross-linking, then microwound technology, then predictable biodegradability, and the sealing membrane concept. Now, whether we should have a matrix which has done cross-linking or non-cross-linking, this is again a technology. Like Integra, it doesn't have, it has cross-linking. BTM doesn't have cross-linking. Now what are the advantages and disadvantages associated with it? If we have a dermal matrix which has cross-linking, it will have better durability. But the matrix which has less of cross-linking or no cross-linking, the cellular invasion will be more. There will be better neovascularization. This is a technology, microchamber technology, which is unique to this Novosoft BTM. Now, some comparison between the biologics, like they are generally made of porcine and bovine collagen, unlike this Novosoft, which is made of biodegradable, it is made of polyester urethane. It is biodegradable. It is less immunogenic. This is also a slide which has comparison between allograft, xenograft and Novosoft. Again the same thing, like it is less immunogenic, it is more immunogenic, it is biodegradable, it can be used in contaminated fields. Now the main thing, the mechanism of action of this dermal matrix. This has a unique concept, which is this organizes a large wound into small interconnected wounds. And each of these small wound, it heals and it regenerates. This is something very unique to this product, which had not been there in the previous dermal matrix which we had been using over the decades. This also has less of foreign body response. So the major three things which we find with this product is it is robust in presence of infection. That is, we can use it in any kind of contaminated fields. Then it is designed to minimize contracture across the functionally important areas, like across the joints. Then it can be easily applied on exposed tendons and bones, since it forms wonderful neodermis on top of it. Now regarding the product, this product is basically biodegradable temporizing matrix. Now what is it made of? It is made of 94.2% of air, then 5.8% of polyester urethane. This is something synthetic, unlike the other matrices which we had been using over the years. 10 into 10 centimeters generally weighs only 2 grams, which is also unique. Now I'll show you some of the cases. This is a 40% burn, full thickness burn, where BTM had been used. Then the other use is in deglobing wounds along with fractures. This is also used in chronic wounds, mainly the ischemic ones, where there is paucity of vascularity. It can be used over exposed bone. Again, it can be used across in contracture release. The way we discussed just now, it can be used across functionally important areas like the joints. The moment we release this kind of contracture, generally we tend to have exposure of the joint and the tendons. So this kind of matrix can be placed on top of it. After 2-3 weeks, we put a skin graft. This is the best use of this BTM, which is like it can be used over the exposed tendon, mainly on the dorsum of the foot. This kind of wound is very common for we plastic surgeons. We generally get this kind of wound in road traffic accident wounds. This is the way we can put it as a sealing membrane. After 3 weeks, we delaminate and we put a skin graft. And this is a final picture after the wound has settled. You can see the pliability is good, the skin has healed well. And as we all know, less is more at times. Like though these dermal matrix is definitely not a substitute, but it is a good option depending on the case scenario and all, we can definitely include it in our armamentarium of practice. Thank you so much.
Next, the tries is not there, so I would like to request KCL for VAC installation therapy.
Good afternoon to all of you. I would like to extend my gratitude to the entire Plastic Surgery Association of Bhubaneswar and the organizing committee of Aprasocon 12Th for giving the opportunity to represent us in this event. And as you know that Activate, we are using two type of the machine. One is the Activate, which is compact and is morely used for the home care patient and also the patient who is going to be discharged, as well as the patient with small size of the wound. And we have another machine which is called the Alta machine, VAC Alta, which has 4 different therapy modalities, the VAC system, the Veraflow system, and we have the Prevena, and the last one is the Apthera. Coming to the Veraflow therapy is something which comes with the, or it's giving the top up on the VAC, which comes with the installation, or the NPWT with installation. In that Veraflow, we have 3 phases. One is the instill fluid or the instill phase. The second one is the dwelling phase, and the third one is the wake phase. So in instill phase, what happens? The fluid which we want to instill will be instilled on the wound, and then come to the dwell phase. Dwell phase is something where the instill fluid which has been given to the wound, now it will remain there for a particular time, whatever is decided by the clinician, which help in the solubilizing the exudates or the hard fibrin we can say, or the sloughage. And the last phase comes as the wake phase. So all the solubilized debris will be removed along with the infectious material and thick exudates. So that is called the VAC therapy, and the entire cycle will repeat based on our settings. It might be of 2 hours, 3 hours, whatever the customized setting we have done it. Now how it is helpful, the cyclic wash of the wound, as any biofilm which is getting mature in next 8 to 10 hours, so we give the cyclic wash in every 2 to 3 hours. So ultimately it helps in the reducing the bioburden and removing of the infectious agent from the wound bed. Now coming to the clinical evidences, we Solventum always believe in the scientific paper, research paper, and the clinical practices which should facilitate or support the clinicians to decide in their treatment options. So here is the coming to the clinical evidence of the solution. So which solution to be used, whether any solution is superior on another or not. So the study has been done by Kim et al. And the study has suggested if you are using the normal saline, it is also equivalent to any other antiseptic solution if you are using. So the study has suggested that not a single solution is superior on other solution. And in this study, they have compared with the Prontozan, which is 0.1 polyhexidine and 0.1% of betaine. Another clinical evidence is we have the consensus guideline, which is we have requested 13 panelists, expert panelists, who has suggested or assisted in suggesting the clinical consensus statements. So in that consensus statements, and it is done in the it is published in the International Wound Journal, Willy, in 2019. So they have also suggested the normal saline should be the first choice of the fluid while you are starting the installation therapy. In that statement, so consensus statements, they had given the indication, the type of the wound or the indication wounds which can be treated with the Veraflow. So any traumatic wounds, diabetic wounds, venous leg ulcer, pressure injuries, surgical including the diced wound, wounds with exposed intact bone, or the wound with treated underlying osteomyelitis. Along with they had given the wounds, wound type, which type of the wound should be treated with the, or should be the Veraflow therapy should be initiated. So they had given some certain types of the wound, like the wound infected or the contaminated wound in the presence of orthopedic fixation hardware, full thickness burn after excision, wounds resulting from evacuation of hematoma and when hemostasis is achieved, and wounds that are a bridge between stages or the delayed amputation. The another consensus statement in which they have suggested or they have found that some of the compatible solution which can be used along with the installation. So it is hypochlorite based solutions, silver nitrate, biguanides, lidocaines, ketonic solutions, isotonic solutions. So all these solutions are found to be compatible with installation therapy. Now in the next consensus statement they found certain settings while they have started the therapy with the Veraflow. So they had given like negative pressure wake time should be 2 hours to 2.5 hours if we are using the Veraflow. If we are using the Veraflow clean choice, then it is 2 to 2.5 hours, and the pressure recommended is minus 125 mm of Hg, and the dwell time which is given is the 10 minutes. Now we Solventum we have come up with the continuum, NPWT continuum of care. Continuum of care is nothing but it is essentially a step down guidelines or the concept to guide the clinician to use the right therapy at the right time for the right type of the wound. So ultimately it is helping in the effectively utilization of the right therapy which will help in the maximum outcome and the cost optimization in patient treatment. So here is the continuum, or can start smart with the Veraflow. So can start with the Veraflow clean choice dressing. And after one set of the dressings, when you found that the wound is now to be only washed or cyclic wash should be given, then come down or step down to the Veraflow therapy. Once the wound is clean and we are aiming for the granulation, then we have the VAC therapy where the robust granulation can be achieved. Here is the video of Veraflow therapy, how it works.
Delayed healing and wound complications can be a significant care and cost burden. Delayed healing and wound complications can be a significant care and cost burden. Wounds at risk of bacterial colonization and infection can result in excess length of stay and hospital charges. 3M Veraflow therapy combines automated topical wound solution installation, distribution, and dwell to cleanse wounds, with the benefits of negative pressure wound therapy to help facilitate the removal of wound exudate and other infectious material. But there are several other reasons to start the wound healing journey with Veraflow therapy. Let's first see how it works, then examine the data for why you should consider Veraflow therapy as a potential first choice to help promote wound healing. When it comes to removal of infectious materials, Veraflow therapy is a smart way to start. In the first stage of the repeated cleansing cycles, Veraflow delivers topical wound solutions that dwell in the wound, to help dilute and solubilize infectious material. Then, solubilized wound debris and infectious materials are removed under negative pressure to remove bioburden. Next, the negative pressure phase of veriflowtherapy promotes granulation tissue formation and perfusion to prepare the wound for closure. Now that you know the mechanism of action, let's look at the data behind veriflowtherapy. In a porcine full-thickness excisional wound model, the average granulation tissue thickness after 7 days treatment of veriflowtherapy with saline was 43% greater compared to 3M VAC therapy. Based on a published systematic literature review and meta-analysis, veriflowtherapy was found to offer statistically significant advantages when compared to control, which included VAC therapy. Approximately 1 less debridement was required for veriflowtherapy. Wounds were ready for closure almost twice as fast. Wounds were 2.39 times more likely to close. Length of therapy was reduced by more than half. Odds were 4.4 times greater for reduced bacterial count from baseline.
That was the study which is also suggesting some clinical evidences. Last we have our local representative, Mr. Durga Sahu. You can have his contact number. Thank you.
KCI for this excellent presentation. Now I would like to request Care Private Limited for the to present introduction to advanced wound management portfolio. Please.
Good afternoon, everyone. So my name is Shubham Gupta, State Manager in Advanced Wound Management Division from Smith & Nephew. So I am representing Advanced Wound Care of Smith & Nephew. So this is a clinical decision support tool and we can call like time wound preparation for advanced wound management. So this is a simple wound bed preparation technique like time principle that we for the wound bed preparation, for debridement, for remove or reduce bacterial load, for moisture balance, and for the tissue, edges, which just comes together. So we are having a different products available in the segmentation of TIME principle. So why wound bed preparation? So chronic wounds needs to be free from acute models of injury. The chronic wound is completely different pathological entity. The healing process expected in acute wounds has been interrupted in chronic wounds. So we all know like the basic principles of this. So chronic wounds do not follow the normal sequential phases of wound healing. Acute wound sequential phases of healing, and then there is an interruption. So tissue, the first step of time is T. T is non-viable or deficient. So factors affecting tissue stress like local edema, vascular supply compromise, deep infections, increased pressure of hyperkeratotic callus on ulcer rim, low albumin, increased local pressure, friction and shear, immobility, incontinence of feces and urine, like that. So the objectives in relation to treating tissue in chronic wounds: clear away dead and necrotic tissue, always ensure adequate tissue oxygenation. Tissue non-viable or deficient, so remove of callus or necrotic tissue, decreasing the bacterial burden, removal of phenotypically altered cells. First step is debridement. So efficient debridement is essential in treating all wounds, necrotic tissue in continually building up chronic wounds. Debridement is an ongoing process. Debridement will allow healthy granulation tissue to form, and then thus debridement reduces dead spaces that harbor bacterial growth. So the types of debridement we all know, like autolytic, surgical, sharp, enzymatic, mechanical and biological. So autolytic, the debridement which the range is also offering in advanced wound management. This occurs spontaneously in all wounds. Enzymes spontaneously separate necrotic tissue from healthy tissue. Moist dressing can enhance the environment for debridement. Cheap and cost effectiveness, Escher can contribute to the delay in autolysis. Surgical sharp debridement, fastest and effective way to remove debris and necrotic tissue. can leave a bleeding base which is known to increase the healing rate of neurotropic foot ulcers. So surgical debridement is normally performed. Usually it is a costly procedure. So like that. So it's an intraoperative and post-surgical debridement. Second is enzymatic debridement, uses applications of exogenous enzymes to the wound surface. Excess exudate may be produced with these agents. Available agents: bacterial collagenase, DNA fibrinolysis, prepinin, urea, trypsins. Mechanical debridement, used to physically remove debris from a wound, wet to dry dressings like that, and wound eradication can be uncomfortable and damage newly formed tissue. Biological therapy, larval therapy is re-emerging. Sterile larva of the Lucilius sericata fly is used, produce powerful enzymes which break down dead tissue without harming healthy granulation tissue, also appear to combat clinical infection, and moisture content needs to be at correct level like that. So this is the T where pathology, clinical actions which has to be taken to treating the T part in time principle. Then second is infection, inflammation. So the assessing is a very important step obviously, and contamination critically colonized infection state. So the systemic factors that increases the risk of infection, that is vascular disease, edema, malnutrition, diabetes mellitus, alcoholism, prior surgery or radiation, drugs or corticosteroids. So what are the local factors that increases the infection? Large wound area, increased wound depth, degrees of chronicity, presence of foreign bodies, necrotic tissue, persistent inflammation, and often as symptoms of infection. Transient inflammation is part of the acute wound healing process. Some chronic wounds are stuck in an inflammatory phase like venous ulcers, so where the eye has to be taken care of. So a superficial pseudomonal infection, and the figure B is like under surface of probe and deep infection in person with diabetes. So the sign and symptoms, and what is biofilms? Biofilms are microorganisms obviously attached to a surfaces segregated in hydrated polymer matrix, glycolics, of their own synthesis. So this is a bacterial benefit of creating a biofilm. So we have taken like I part, then M part is moist wound environment for chronic wound healing, increase the speed of reepithelialization, earlier and less prolonged angiogenesis, reducing of local wound pain, isotonic fluid, increasing the viability of WBC and decreasing the rate of infection. So moisture imbalance dry, it's a desiccation process, obviously slows the wound, and the edges which is normally not followed, acts as a source of infection, painful and uncomfortable for the patient, longer treatment time, and increased cost. So moisture imbalance, wet, excessive fluid causes maceration of wound margins, inhibitory to healing, conducive of bacterial wound colonization, painful, uncomfortable for the patient, longer treatment time and increased cost. This is the ideal pick for wound has to like maintain the moisture. So rebalancing moisture levels to those seen in acute wounds, not too dry, not too wet, so optimal moist is there. So what are the factors that influence exudate production? Wound type, depth, surface area, burns, extensive ulceration, wound infection, stimulation of inflammatory process, patient's condition, autolytic debridement, dressing choice. So dressing selections, clinical evidence, wound etiology, tissue type, levels of exudates, patient preference, cost and cost effectiveness. So what are the guidelines for use of the wound dressings? Use the dressings that will maintain a moist environment. Use clinical judgment to select a moist dressing for the wound being treated. Choose a dressing that will keep the peri-ulcer skin dry while maintaining the moisture within the wound. Use a dressing that will control the exudate without leading to desiccation of the wound bed. If possible, use dressings that are easy to apply and do not require frequent change, as this will decrease the amount of healthcare provider time required. Fill in any cavities within the wound to avoid impaired healing. Monitor all dressings, particularly those near the anus, which are difficult to keep in place. Review the dressing regime regularly to reflect the changes taking place in the wound. Take in moisture. Then last, epidermal margin non-advancing or undermined. So why does the epidermal margin fail to migrate? Failure of the epidermal margin to migrate across the wound is most obvious sign that a wound is failing to heal. If the margin is undermined, this may be a sign of critical colonization or infection. At a cellular level, the lack of epidermal migration may be due to many factors: non-responsive of wound cells, keratinocytes, fibroblasts, excessive inflammatory response, abnormalities in protease activity which may degrade ECM while it is formed. So reconsider the principle of wound bed preparation and the acronyms. Time. Has necrotic tissue been debrided? Is there a well vascularized wound bed? Has infection been put under control? What is the status with inflammation? To what level has moisture imbalance been corrected? What dressings have been applied? Next option is prepare the wound bed for advanced wound healing techniques, hyperbaric oxygen, stem cell therapy and concentrated growth factors. So we've taken this E part. So this is the principle of wound bed preparation. So these are the portfolio of ours in advanced wound management division. So as per the time TIME, we are having the solutions which are offerings in terms of treating the chronic wounds. So this is antimicrobial silver dressing, names Acticoat, Acticoat Flex and 11AG. 11 is a hydrocellular foam dressing. It's with AG and non-AG, non-adhesive, adhesive, all ranges are available. NPWT is a single-use canister-free device which has having a small portable pump, battery operated, with having 2 pads of dressings available in a single kit. It works for 7 days, and we are recently launched and come up with 14 days therapy as well. So the pump will work for 14 days with 2 pads of dressings. Like skin care and scar management, we are having the silicone gel sheet available with us, that is Sika Care. For post-op dressings, we are having the Legacy's brands available, post-op, outside post-op and Primapore. For the post-op dressings, we are having a device available with us, that is hydrosurgical device. It's a thin saline of 15,000 pascals per unit. So the debridement will be very easy in terms of without harvesting the new cells. The name is hydrosurgical debridement, brand is Versajet, and the foam dressing is 11 Life and 11 category, where the 5-layer, 3-layer, all AG, non-AG, non-adhesive and cavity fillers are available with us. So this is all about the portfolio, and this is all about the wound preparation as per this model. So thank you very much for the time.
You very well presented on advanced wound management. Now I would like to request Arjo Hunt to present on burn treatment care solution.
Esteemed doctors and my dear trade colleagues, it's Manmat Nayak, and I represent Arju as a for entire East India and Bhutan. So today we will discuss about burn treatment and care solutions. It has been offered by Arju. So what are the introductions of burn treatments? This is clinical basis and level of burns and treatment phases, infection control, pain management, and the Arju solutions. So these are the big 5 issues: PI, that is pressure injury or pressure ulcers, HAI, and patient's falls, and VT and MSD. These are the burn injuries depends upon the severity of the burns. Accordingly, we will treat and give the solutions. Then level of the burns, which degree it is, 1st degree, 2nd degree, or 3rd degree, or 4. Then we suggest to consist of 3 phases of to treat the 5 stages of the burn patients, that is acute phase, treatment phase and rehabilitation phase as per the Arju solutions. So acute phase, maybe we can consider to treat standard emergency procedures and hemodynamic stabilizations. So what Arju provide during the emergency situations, the concept we call it is a shower trolley. So we can keep the shower trolley at the emergency and give the dressing up, and we can clean up the necrosis tissue, and accordingly it will heal up the much faster to the dead tissues. So patient recovery will be very fast. This is battery operated and hydraulic as well. and it occupy only 3 feet by 6 feet or hardly 7 feet. So we can keep this concert or shower trolley on our emergency departments. Then we have a lateral movement bed. Sometimes for burn patients we require the lateral movement beds. We can have a lateral movement of 20 degree plus minus. So relief of the patients will be much faster, and patient will come up to the normal life in a fraction of maybe short span of time. The safe workload of this bed is 270 kg. This is the patent technology Orzo, Sweden. Then Enterprise 9000 we do have. So Orzo 9000 we do have bed. That this bed also carries the wing scales. Sometimes we have to inbuild the wing scale beds. So sometimes we have to understand the patient's weight rather than waiting for some assumptions. These are the clinical focuses of the Orzo, and safe SWL is 250 kg. This is the patent technology again from the Orzo, Sweden. Then we have a VT solutions, that is venous thromboembolisms, or DV2 we can normally call it as. Orzo provide the VT solutions in the rental as well as we trade it also. We sell it on an outright basis. The cycle is 1 minute, and it's having a 12-second inflated times, and which refill the vessels, and 48-second deflated times, which allows to refill the vessels. So we have a calf garment, we have a foot garment, we have a thigh garments. So pressure of the foot normally we recommend to 120. Our machine provide 120 mmHg. And calf and thigh we have a uniform circumference inflation deflations, and we have a sequential gradients 45, 35 and 30 also. So doctors, you can prefer accordingly the VT solutions from us also. Then treatment phases. We have a, I think again Orzo worldwide has a great, I think R&D department has invented the burn solutions, tanks, burn shower tanks. That is name is two models we have. One is the ceramic model, one is the stainless steel model. If Odisha is, as Odisha is concerned, we have two models are available. One is at AIMS. Last year we installed at AIMS, that is AIMS Bhubaneswar, and one Primofero, I mean Rhapsody, that is ceramic Western, worldwide Western type pattern, that is installed at SOA, some. So we have a hydromassage options. This is, we have a hydrosound as well as the hydromassage. Then how hydrosound works? It will create some kind of the electricity vibrations on the water. The tank will automatically fill the waters, 300 liters, 200 liters. Once it will reach the water level will reach to the sensor level, it will auto cut. Then we can just dilute the chemicals on the head end of these panels. There is a options. You have to select whether you want to apply the oil, you want to use the sterilizers, you want to use the disinfectants, you want to use the shampoo. As per the patient's condition or clinical intrinsic extrinsic factors you have to select. Then automatically from the machine head end panels it will come up, drop down, and you can, we can, or nursing sisters can do the all this dress up before this one, clean up all the necrosis tissues. This is we have patent technology hydrosound and hydromassage in our tanks. Yeah, this is hydrosound. Then hydrosound, how it works? We create some kind of sound. We have a hose pipe, so we create one kind of the bubble water outputs. Then this is the patient lifter or positioner. Because patient is born patients, we cannot place the patients directly on the inside the tank. This is the patient lifter or positioner. By this lifter or positioner, we can place the patients. Even also we have a backrest options also. It can go to 70 to 80 degree backrest positions also. And we can place the head up and entire body will be dipped down to the water levels of the tank. Then we can do our procedures, minor injuries, whatever. Then 3-part stretchability is there, and also even also we can have a movability on the SWL safe workload is 160 kg of this Miranti. Then we are expertise on the therapeutic surfaces. Orzo is well known in the worldwide therapeutic surface, that is air mattresses. We have different models of the air mattresses, but our brand name, our identity is the Nimbus. Nimbus is having the alternating air mattresses. So it provides the pressure distribution as well as the pressure relief also. SWL of Nimbus is 250 kg, having the 8.5 inch height, and it's a mattress replacement systems. So it can use on the burn patients also to avoid any kind of the pressure injury or pressure ulcers. We have a CPR facility to give the patients effective CPR. Then we have a microclimate management. This is skin IQ. Negative airflow technology, we have a microclimate management also to avoid any kinds of the IAD or any kind of the moistures. Then rehabilitations, we have a SARA combilises early mobilizations equipments also. We can have a lateral movement and tilt options also, 15 degree plus minus tilt and reverse Trendelenburg. Then we have a lateral movement 20 degree also. This helps the patients to at least reduce the risk of pressure ulcers as well as the early recovery from the disease. Then we have a patient lifters, that is Maximove. We have 3-4 slings used normally in our Maximoves. We have a walking jackets. We have a supine persons. You must have observed the film that Hrithik Roshan's that Gujaris. That machine was used our machines, that Gujaris, Hrithik Roshan was a paraplegia patient and he was using a supine person's device, that is this first one, so that's corner one, that one is supine persons, he was using that machines also. And we can have a walking jacket, we can have a sitting transpose, and we can have a lateral movement also. This is maximum. Then infection control, this we have to take care of the infection control part also. Arju is expertise on the infection control also. It's a human waste. I think we call it as a flusher or bed pen washers, because sometimes we are least bothered about to take care of the bed pens also. So as plastic surgery department is concerned, we have this is from our Getting A and Arju is the same company. So it's from Getting A group or Arju. So we call it as a bed pen washers. We have to change the chambers only if you want to disinfect and sterilize the urine bottles or actually on the bed pens, whether it's on lid or without lid. Never mind, we have to insert it accordingly. We train to the housekeeping and the concerned departments how it can be cleaned, and each cycle of the disinfections will be 7 minutes only, 5 to 7 minutes. And hardly it consumes 4 ml, 4 milliliter of the disinfectants. So the disinfectants can one canister, 5-liter canister can go up to for a year, having a cycle of 10 cycles in a day. This is also one important product, I think, Arju in a portfolio to avoid any sorts of the infection control. So that's from the Arju, Sweden. Thank you very much for giving your valuable time. Thank you very much.
For this insightful presentation. Now I would like to request Molnike to present chronic wound management.
Good afternoon all. So this presentation will be taking place for the antimicrobial portfolios of Molnike. My name is Arun. I am handling the Molnike Healthcare India as a clinical manager. So the Molnike offer a range of dressing that support the treatment of infected wound and the wounds those who are high susceptible for infection. So the wide portfolio, we are starting dressing, definitions to select appropriate dressing for the variety of wounds and the different anatomical locations. So our antimicrobial dressings are well known based upon the name Meplex AG and Meplex Border AG. Now we can see the indication. Meplex AG can be indicated for the treatment of infected diabetic foot, venous leg ulcers, pressure ulcers, partial thickness burns, which is highly using in India, and it can be used even under compression. Meplex Border AG dressings can be used for the diabetic foot, venous leg ulcers, pressure ulcers, partial thickness burns, even in the malignant wounds, surgery, trauma, and even under compression. Our gelling fiber, exo fiber that can be used for diabetic foot cavities, venous leg ulcers, and the compression areas. We believe that the major role of our antimicrobial dressings in 2 ways. The first one, it acts as an antimicrobial barrier, especially in the acute and the chronic wound, those who are high risk of infection. Then it can reduce the bioburden, especially in the acute and the chronic wounds and even in the burns. So this is Meplex AG dressing. It's an antimicrobial soft silicone foam dressing that can be designed for the management of low to moderate exuding wound. The 3 clinical challenges we are addressing is pain and trauma, delayed wound healing, and high treatment cost. Our value story is built upon it can reduce the pain and trauma during the dressing removal, it can reduce the healing time in the partial thickness burns, and it can reduce the treatment cost of the partial thickness burns. So the product features SafeTech is the interface that is a wound contact layer that minimizes the damage to the wound and skin upon removal. The outcome is that can reduce the trauma and pain on the removal. The silver sulfate is antimicrobial agent which is present over there. They are fast acting in nature within 30 minutes once in contact with the exudate that will function and have a broad spectrum of antimicrobial activity and sustained activity up to 7 days. So it can reduce the healing time, especially in the partial thickness burns. Then its design is multi-layered in design. SafeTech is an interface, absorbent form and breathable top layer that will absorb, retain and moisture vapor permeable and maintain a moist environment. It can reduce the treatment cost. So this is a construction. SafeTech is an interface that will reduce the pain and trauma. Then silver sulfate, broad range of antimicrobial activity up to 7 days. Then highly breathable backing film that will provide moisture vapor transfer and moist wound healing. So the 3 pillars of evidence, it contains 5 RCTs and 48 other case studies and case series. Apart from that, we have in vitro studies for the sensitivity towards both gram positive and gram negative. So this is one of the randomized control trial which was done for the cost effectiveness of Meplex AG versus SSD. So the key measures were cost and healing time. At the end of the study, you can see it provide a faster wound healing and less pain when these dressings were used. And if you're looking upon the number of dressing change were significantly lower in Meplex AG, that is just 2.2 compared to the SSD, that is 12 times were used. So the mechanism of action of Meplex AG, this AG positive binds to the bacterial enzyme that prevent bacterial cell to carry out the life-sustaining processes. Then AG positive binds to the bacterial cell DNA and interface with the cell divisions and replication also. Then again, AG positives or the silver ions bind to the protein in the cell wall, leading to the breakage of the cell wall, leaking of cell content, eventually the death of the cells. So this video will help to understand its mechanism. I think there is no sound. So another group of portfolio we have that is Meplex Border AG. These dressings are designed for medium to highly exuding wound. And the 3 clinical challenges we are related again pain and trauma, delayed wound healing and odor that can affect the quality of life of a patient. It will reduce the pain and trauma during the removal since it is also having SafeTech interface. Reduce odor may be used in the infected wounds and left in place up to 7 days for the longer wear time. So this is a construction of this particular dressing. The SafeTech is an interface with having a less trauma and pain during removal, antimicrobial activity up to 7 days, breathable backing film and absorbable polyurethane foam, and this dressing can be placed in situ without any secondary dressing. So that's all from our end. Thank you.
Thank you, Molniki. It was a very good presentation. Now moving forward to our miscellaneous topics. Now we will be moving forward to our miscellaneous topic. I would like to request Dr. Ramesh Das, sir, Dr. Sunil Raut, sir, and Dr. Satyavrata Rautrai, sir, to chair this session. Please, sir, I would like to be presenting today, and Dr. Satyavrat Mahanti, sir, has already been presented.
Medical College. We were working for a long time at Cuttack. And I know his expertise. He was doing hypospadias. I was once observing, and the result is excellent. Because hypospadias is a surgery. Most of us face the problem several times. I have operated for 8 times one hypospadias. So we will hear him, and he is well versed with that art. Dr. Prithviraj.
ଏମିତି କେମିତି ହେଇଗଲା? ନାଇଁ ନାଇଁ ଏମିତି ଆସି ସାଇଡ଼କୁ ଆସିଗଲା। ଓକେ 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 ଓକେ। Respected chairpersons, respected President APSI, respected Secretary APSI, and respected our Aprasocon President, and all the delegates, my seniors. Ruchi ma'am is also sitting over here. So I think I feel very much proud over standing here all before you, because individually I can at least address. Okay, so today I have selected this topic, a simple approach to a difficult problem, a perennial hypospadias. So perennial hypospadias, because this particular case, I think for out of my near about 20 years I have in this plastic surgery. Since last 2003 I joined, so it's a fast case of this much of severity I got, so that's why I felt I will present this case. Oh, it is only for the postgraduates, but before if I only classify hypospadias, this is a distal variety and proximal variety, because my this one perennially comes under proximal variety, so I have kept this slide. And this is amongst the proximal variety, mostly these are the penoscrotal one, the scrotal one, and the perennials. And so here this is it. Marker achi, pointer. Pointer. I think, sir, I want to know from Ramesh sir and also our respected President and PSI, Secretary sir. Then I think this case particularly, sir, I am interested to talk about. This is a partially operated. So the urethra is, it looks like the urethra is over here. Then a vaginal, dimple sort of thing, vaginal dimple sort of thing is there. Then the anus. So that's the urethral opening shares the anterior portion of the anal canal. So in that way, I think this is a typical case, because the perennial hypospadias also, as per definition, that is in between, say, the anal opening and the scrotal posterior limit of the scrotum. And when this proximal perennial proximal hypospadias is associated with microphallus, so I got an opportunity to see a case of microphallus also, because that's a one-day baby, so I could not have photographed that patient. So when it is associated with the microphallus, or it is bifid scrotum or penoscrotal transposition or cryptorchidism and DSD, then these things are called severe hypospadias. And this is causes of the proximal hypospadias, which about constitutes 20 to 25%. And mostly the distal hypospadias is very common, that is about 70%. And these are some of the causes. Here also in severe this proximal hypospadias, mostly the causes are idiopathic, so 70% of cases. And only in 30% we can assign some or attribute some of the causes to the defect, like either in the synthesis of the steroid hormone synthesis or adrenal hormones, or either in the level of the receptor levels, or some syndrome associated or chromosomal anomalies or some genetic factors we can assign. Otherwise, in most of the cases, like 70%, these are idiopathic. So embryology, as all of us know, it is the SRY gene which determines the indifferentiated gonads to get differentiated either into a testis, and there follows the lineage to which the fetus will develop towards, like whether she will go for a female or a male like. But once the SRY gene is there, that helps in the genital tubercle. The next slide I will go. So here the genital tubercle is there, that starts elongating. And about 6th week of intrauterine life, when this thing is cloacal membrane is there, and once it ruptures, around it is 6th to 7th week. So this anal canal has been separated from this, anal opening is there and it is separated from this urogenital sinus. But in this particular case, I think the anal canal and also the urogenital sinus from where the urethra develops, that becomes urethral plate, and the urethra develops from this region, and this is languid as a phallus. So I think in this particular case probably there is some problem here in this level of development, hence it has not, urethra has not formed. So this is again the risk factors, it is there. I'm not going to elaborate. It's multifactorial, unknown etiology, genetic, endocrine, and environment factors. So genetic factors also, as it's a predisposition of 8-fold increase in case of monozygotic twins. And similarly, if a father is having hypospadias, then the risk of the boy, the male child having is 8%. If the one of the sibling or male sibling is having hypospadias, and the other one, the chances is about 14%. So this is some of the endocrine factors, as I have already told, so I am not going to repeat this. So this is the literature. This environmental factors. So endocrine disruption by environmental agents like plastics, the pesticides on fruits and vegetables, plant estrogens, milk from the lactating pregnant cows, and plastic linings in the metal canes and pharmaceuticals are some of the factors. These are probably responsible for the increased incidence of hypospadias nowadays. Previously it used to be about 1 in 300 to 400, so now it has increased. This is a Western literature, so about say 7 cases per 1,000, so that is incidence increased. So this is again endocrine causes. So yeah, so our patient, this is the patient where this is general examination, says 26-year-old male patient with normal secondary sexual characters presented to us. And when I asked this patient, why you presented so late in this, at the age of about say 26 years, the very cool answer is, because see, this doesn't cause any problem to me, and the only problem is I just cannot urinate on the roadside. As usual as a male person they do, so I cannot do that. I need to have a closed space for my urination. That's the only problem I have. Otherwise I do not have any problem. My his friends informed him that it's a repairable problem and it can be repaired, so you better talk to some plastic surgeons, because they are doing sex change operations they are doing, so you better consult someone. Then he ended up in our unit. So here what I want to stress upon is, this is the anus where we have put the proctoscope, and this is the urethra where we have this infant feeding tube is there, and in between this is a dimple. So it's a blind dimple, but this is again a investigations. So his abdomen is normal, that is there is no female adnexal structures in the pelvis, and the karyotyping is again 46XY, and we do not have the facility for cytogenetics like FIS, that is fluorescence in situ hybridization, so we have not done that. And sex hormones, it is, all are in favor of male only, and in this particular case also he has well developed testes and also scrotum, so this hormone level is also normal. This is alpha testosterone is normal. This is the active form that is also in normal limit, and these are normal limit. So our goal of here in hypospadias it's orthoplasty, neometus at glance tip, and forward directed urine flow, urine in standing position, and aesthetically normal looking and functionally satisfactory. So that is the common goal of a hypospadias surgery. And these surgeries, as book writes, there are some say about 250 to 300 techniques are available to correct hypospadias. But when this perineal or the proximal hypospadias is there, the options decreases. Now, previously, when the TIP has come, people have started doing TIP for even in proximal hypospadias cases, probably not in the perineal, but most other cases, TIP can be done by shortening the height of the phallus, that is by Nesbitt's procedure. And now the literature says and the CODI is recurring. So the recurrence of CODI is occurring. So that is few literatures are there in against that of TIP procedures. So this is a technique, it's an age-old technique, and the most premier technique I would like to say. So there is a Thier's technique which is of 1869, and he followed that principle, and Duplay propagated his technique, and the name goes as Thier's Duplay. So this technique is classically it is conducted as in 3-stage procedure, like CODI correction and ventral tube formation and junctional fistula closure. And here we are forced to follow this 3-stage, because I think in 2 stages nowadays, in other cases like penoscrotal, you can go for a 2-stage hypospadias correction, but here we are rather forced to do a 3-stage and junctional fistula and kept a junctional fistula. Timing, it is within it should be operated 6 months to 18 months, but most of the cases they present to us about say 3 years or so, and this particular case it has come say 26 years. But what I want to stress upon is, after a thorough understanding of this, only for cases like gender assignment where the patient also participates, like in these cases of ambiguous genitalia, nowadays they are calling as DSD or DSD also, they renamed is at difference of sex development other than the disorder of sex development, and where, so when to operate in such type of cases, probably again it is where the patient himself should participate. So had this patient been presented at the age of 3 years or the right time, whether to operate or not to operate, or wait till the patient gives it, that is there. So this is the case where complete it's a bifid scrotum with some amount of scrotal anterior transposition I would not say, because after correction it got corrected. So this is totally a bifid scrotum, and the penis is it has stuck to the perineal area. And this is the after say in the fast stage we have done the CODI correction, and this is after the ventral transposition of dorsal hooded prepuce. The entire prepuce is covered, and after say 6 months it has matured, like it's very nicely settled. It has become soft and supple. I think now it is we have done second stage now. So in the second stage it is a very simple procedure, as the Thier's Duplay we have applied over here, and after the correction of second stage this one, and we left the junctional fistula closure, because we forced to do this, we cannot tubularize this area in the same go, so we left behind purposefully a junctional fistula, which previously the Thier's Duplay used to use this for diversion of the urinary diversions. Again, one more thing I would like to communicate is that in this patient, though we are operating in the just anal area, we have not done colostomy over here. I want to know the experiences also from the learned daily members, that We have just kept post-operatively, but kept the patient on IV fluids for 5 days, and and thereafter liquid diet, and on 7th day onwards, I think the patient took solid foods. So by the time the wound has settled, and this is one case, and previously last conference I showed you about the anal incontinence, obstetric anal incontinence. There also we did surgeries around the anus, and some of the literature says that diversion colostomy previously the surgeons used to do, but that case also we followed the same principle. We had not done diversion colostomy, being we have operated around the anus. So this is after the second case. The patient in the second stage, we purposefully kept a junctional fistula is there. Then the patient ended up in a single fistula in the just proximal to the mid-shaft area, and there is dehiscence of glandular dehiscence. There are some of the complications. It is associated with hypospadias. So in that third reoperation. So here the third stage, we junctional fistula did the closure, and also at the same go we did fistula closure and also glansplasty. So the junctional fistula, here we have taken the advantage of the Singapore flap, or that is pudendal thigh flap, which is based on the internal pudendal artery perforators, the labioscotal perforators, and it's a completely islanded flap. And also we did the flap, 2-layer repair of the fistula, and this is a flap cover from the scrotal tissue we have taken, and we did a glanduloplasty over here because a very deep grooved glands was there. We took advantage of that, and ultimately the case looked like this, and there is a intervening. So this is the scrotal end and this is anal, so we could able to breach this tissue with this flap. And so this is the flap we have marked over here, and we flipped this area, and this is we made just to cross over the midline, this area, and this is the flap after inset, and here is the anal opening. And this is junctional fistula and closure, same thing. And this is glandsoplasty. Okay. And it is the video. This patient is having a single leak, and most 99% I think is able to pass through the normal looking like tip which is present in the tip of the glans, a little bit sort of tip of the glans. Thank you, sir. Thank you, sir. So I want to know from my senior colleagues this: have you ever encountered a problem like this? Why I am asking, sir? Because of the perineum, it's sharing the anal mucosa. Both the openings, like the urethral opening, is present just anterior to the anal. I won't say anal canal, but there is no breach of skin, and it is a mucosa only, and that breech segment is occupied by the vaginal dimple. That is the thing.
It is most likely anorectal anomaly along with the hypospadias, proximal hypospadias. And three things are, so far as I am concerned, I have been doing hypospadias quite a lot, because one stage is impossible. Second is you have to increase the penile size.
Length, yeah.
What people are doing, and we are also trying to do, putting testosterone, either injection or solution is available. We leave it for 6 months so that the penis size, gland size become big and operable. So with the meatal stenosis, then there will be fistula definitely. And regarding the sphincter, if it is a congenital problem, one has to dissect the external sphincter and do a sphincteroplasty at the same time, so that incontinence can be avoided. Most of the 3rd degree, 4th degree critical tier used to repair the sphincter, and as usual, So this can be combined with it. And as you told, because hypospadias is a, who has touched it, will become miserable. Any surgeon, let it be a pediatric, plastic, urologist, some neurologist admit, they land up in trouble. And you have rightly put a perineal, pudendal flap, otherwise directly suturing, and the penoscrotal junction is the common site. Penoscrotal junction for two reasons. Erection is one problem. Second is you, when bandaging, you leave it to others. They put the bandage at the root of the scrotum and the penis. So gradually by pressure it gives way and becomes a fistula. So you have done a wonderful job because it is not easy. Everybody will not be interested because the blame is always on the surgeon. Everybody will do everything.
Audience? Any questions from audience?
Nice, you have to pick it up because most of the surgeons, they are diverting from the genitourinary reconstruction. We should take it off because it is a big field for plastic surgeons. We should not allow it. We can do better, we can give better result with magnification 6070.
Yes, sir, yes.
Not 2030.
Yeah, I forgot to tell, sir. Yeah.
Yes, with magnification.
Yeah.
So result.
Finer sutures, finer instruments and magnifications.
Yes, that you have to use loop and 6070.
70 PDS.
Thank you, Prithviraj.
Thank you, sir.
Dr. Misra from SCB Medical College, Associate Professor, SCB Medical College. He is a dynamic surgeon, young also, and he has a long time to go and doing good work at Qatar. So I request him to talk about functional reconstruction of upper limb trauma. It is a big subject. I think he will do the justice, make it short and
quickly, and showing two or three of the interesting cases. So just it is mainly for the youngsters who are starting. This is my first case. I will start from the top to the bottom. This is a compound fracture involving the humerus, and here we have done the latissimus dorsi flap for the coverage to tackle the osteomyelitis and wound healing. And this is the functional result what I get. So one of my presentation of purpose is that those who are starting their career now, they should do the follow-up of the cases, and it will be useful for the practice as well as convincing the patient that we should do the surgery. Now this is another case. Not always the cases are being referred to us in the ideal time within the 48 hours. Sometimes they refer to us when there is gross osteomyelitis, big cavity, and they will think that the hand will not survive, don't do anything. Again, we do the basic principles like do the radical debridement of the wound, remove all the dead bones, and then fill the gap with the latissimus dorsi flap. And this is the small video done in our department, which shows that we have dissected the pedicle and sometimes we have to island it. And this is the result which the patient gets. And when we do the talk with the patient, do the interaction with the patient, and they come up even if after 1 month or 2 months, and we can they are very happy to see the gaining the results. So this is to sum up from different angles. When the patient even came after the removal of the external fixator, we were planning to do any sort of bone graft for the bony defect, but since he has got the function, he was able to flex at least up to the 90 degree and able to flex his fingers and extend the fingers and able to eat, and so he was not willing for any further secondary reconstruction. Now this is another case in which we did the LD musculocutaneous flap, and the purpose of showing this slide is that usually it is thought that the distal 1/3 of the skin is not well vascularized and there is a chance of tip necrosis. but judicious use of the cautery or planning, that can also, we can raise the flaps, and this flap and the previous flap, they have extended beyond the elbow. So even up to the segment beyond the elbow, we can do reliably with the LD flap. Now this is for the beginners, because I also do flaps and fond of doing flaps, but if it is good granulating wound, do a good skin graft and don't mess it more than 1:2, apply the pressure garment, do the follow-up. If the graft is well taken and healed, still he can get the good flexion and extension of the fingers. So in some cases also, and you can go for skin graft. Now this is some of the cases I want to show to the youngsters. This patient has only adduction contracture of the first wave space, and we can go for the simple flap like either reverse radial or PIA according to their expertise. And this is of course one of the workhorse flaps, which is the groin flap. And now as more and more of the people are going for skip flap, I try to see if there is any perforator, and in this case I could able to find the perforator which is coming. It was this flap which I am showing, it was done for a single finger resurfacing, and we could see the perforator, and if you see closely, we can see the perforator pulsating, and now probably you can see in the center, the perforator is pulsating. So when you are starting to harvest the groin flap, try to identify the perforator, because unless you initially do the dissection around the perforator, you cannot directly jump to raising a skip flap. So these are some, this case is one of my early cases, when the entire surface of the dorsum of the hand was reconstructed with a large groin flap. Then this is another case of electric burn, high voltage electric burn. In a high voltage electric burn, during the initial phase of my career, I used to do groin flap. So these are some of the example of the groin flap, and we can, if we plan properly, we can close the donor site and we can tube the groin flap. And in this case, what I want to say that here it is a compound effect. Here the problem is that there is soft tissue loss as well as the patient has tendon loss, or they are damaged, means not loss, they are transected. So we can do two things. Either we can put a skin flap in the first step, and in the secondary we can do the tendon reconstruction. But with adequate debridement and primary tendon reconstruction or repair, I did the groin flap in the same setting. The trick in this case was I tried to did the groin flap in setting. It was more than 90%. Some of the people may say that because if you don't do the insetting properly, there is chance of infection and the tendons may slough out. But this didn't happen. So also I would suggest all the youngsters to read the article how to orient the groin flap. So in this case, I have shown with the palm facing upward. I had the videos also. If you plan the groin flap properly, the patient can easily supinate and pronate the arm. So you can start the physiotherapy early. And after I divided, you can see the sutures are still on, but the patient is able to flex the fingers. So this is how you can do the functional reconstruction. And this decreases the stage of the procedure. Now this is another case. Now propeller flap is being done both for the lower limb, and also in these cases we have done the propeller flap based on the ulnar artery for a high voltage electric current after debridement, and the flap has settled well. This is another case of ulnar artery perforator based propeller flaps. You always try to use the magnification and try to do the dissection. Even in the smaller flap, if you do the good dissection, you can go for harvesting many flaps which you are being not trained. Now come to this case. This is an interesting case. So this case was probably referred to us. These are all the cases I have done in the medical colleges, not in the private practice. So this is the case which the patient was referred to us probably maybe after 3 or 4 weeks after fixation. The orthopedician has just put a K-wire, and their main purpose of sending was that just give a referral that amputation is required and they do the amputation. Because if you see, we don't know what is the status of the thumb, and we don't know whether the hand will survive or not. But again, go back to the basic principle of plastic surgery. Do the radical debridement. remove all the implants and remove all the infected tissue, whether it is bone, whether it is tendon, whether any infected tissue, we debrided, and on table we saw that there is still there is no problem in the vascularity of the thumb. Then we waited for the 2 days and we planned our workhorse flap, that is the ALD flap, because first we wanted to give a good soft tissue coverage so that if at all the patient requires, we can go for any secondary reconstruction. So this is a large ALD flap harvested and the flap survived and the patient is happy, his hand is survived and he has not turned up. So now as we are doing, probably if this case would have been referred to me during the early days, I would have gone for either a full thickness graft or a groin flap. But now the people are doing more and more free thinner flap, and the purpose of the reconstruction is to give a glabrous skin coverage to the plantar surface of the palm and the sole. So the options available are we can go for a free thinner flap, or another option I thought I'll go for a medial plantar free flap. So we designed the medial plantar free flap, and it is a tricky flap. We identify the distal portion of the neurovascular pedicle, which was accompanied by the nerve to the great toe. We identify the nerve which was going to the great toe, and another nerve we have to preserve. We did the internal neurolysis, and according to the literature, we can, when we do the medial plantar free flap, we can anastomose to either digital artery and the dorsal veins, or there are some articles which also shows you can do the anastomosis to the at the snub box areas, and in that case we have to get a greater length of the pedicle. And greater length of the pedicle, the problem is that you have to do the interneural dissection, otherwise you cannot preserve the nerve. We did that thing because it was our first case, so I didn't dare to base it only on the perforator of the medial plantar artery flap, and this is one of the nerve which we have preserved, which was supplying the great toe, and we dissected right up to the bifurcation where the posterior tibial artery divides into medial plantar, lateral plantar, and there are many branches, but the trick only was we have to do patiently the interneural dissection and preserve the nerve. And we do the anastomosis, we monitor the flap, and this was the flap which was taken in the 10 post-op day. What another thing we did in this case was that, again it was our first case, so we opened the palmar thinner area, did the anastomosis at the radial side to end-to side to radial artery, cephalic vein, one vena comitatus, and we just put a skin graft over the, we didn't suture it because we thought it may compress the pedicle, so we put a skin graft over the pedicle, but the flap entirely survived. But in this case, like we do in the groin flap, we did the syndactylation kind of thing, and we removed the K-wire. The patient is on follow-up and he has came. We have removed the K-wire also just 3 or 4 days back, and now we are planning that we will divide so that the final outcome will be much better. Now this is the last case. So again, dorsum of the hand defect. The problem here is that there is metacarpal loss, loss of tendons, and soft tissue loss. So the options are first give a soft tissue coverage and then go for tendon or bone reconstruction. Flaps can be many, but nowadays we are doing ALD in our department. So this is after doing the first ALD. Yes, the problem in the flap is that on the left side, the flap is a little bit bulky, and because we do subfacially for the rapid harvest, and we have multiple cases in a single OT. But after reconstruction, what is the aim? Aim is to restore the pulp pinch, lateral pinch, tripod pinch, 5-finger pinch, volar grip, and the extension grip. Another problem which happened in this case was initially the patient was not splinted properly, so he developed the MCB contracture. So we did the capsulotomy, and after the capsulotomy, immediately I go for early rehabilitation in all the patients, and when the patient is in the hospital itself, I personally encourage him to do all the things. You can mark the sutures are still on, the capsulotomy sutures are still on, but on the second, third day, I tried to do this exercise. Patient is happy. He is able to do the key pinch. He is able to do the pulp pinch. He is able to write. And he can drink with the bottle. And the patient is happy that he has done the function. But our patients are always demanding. Even after getting the function, they will come, sir, you have done, now you do something because the flap is looking bulky. So what is the next option? Either we have to go do the debulking, but I found the literature that there are some examples and experiences of the people who do the liposuction for the free flap debulking. I tried the debulking in this case with the liposuction. The only thing we fear was that it may injure the vessel, but we know that in this case we had operated in our department. We had a note. We know that the anastomosis was done on the snub box, little proximal to the snub box area. So protecting the pedicle, we radically did the liposuction. After doing the liposuction, we get the extra skin and we sutured it. So this is again the patient, which is 10th day post-op. So the patient has got the function as well as the aesthetically he is very much happy. So this is from where we started and this is where we have finished. So this is just another, so with this I will conclude my talk. Thank you very much.
Thank you, Dr. Mishra. I think nobody has the patience to go for questions. So, thank you for nice presentation and nice collection of cases of hand reconstruction. The next is Dr. Ranjit Kumar Sahu, Additional Professor, Bones and Plastic Surgery from AIIMS Bhubaneswar. He will be presenting on writing scientific articles, which is very important. Yes, Dr. Sahu, please.
Respected chairpersons, distinguished guests, President APSI, Secretary APSI, eminent NROs, Dr. Balayar Singh sir.
Request to finish in time.
My dear friends and colleagues. Today, I think I am the last batsman in this Aprasocon festival, and it is a nice concluding, going to taking our all plastic surgeon to the level 2. Whatever we have discussed from tomorrow, these 2 days, only clinical. What is our lifespan? Maximum 80 years. Whatever you will earn, whatever you do, your earning and your lifespan on earth is 80 to 100 years. No plastic surgeon is living more than 100 years. But now, this is the last talk. You should live for 1,000 years by your literature, by your knowledge, by spreading your knowledge to the world. एक कहावत है, कोस कोस में पानी, 4 कोस में बाणी, 2 कोस में ठाणी, 100 कोस में ऑल एक्सटिंक्ट. इसके बाद कुछ है ही नहीं. आप देखो, whatever your location, what you are doing, how many people recognize you, how many people are coming for you for a help, for a service, localized, very localized, 10, 20 kilometers, 50 kilometers, max 100 kilometers. At best, if you are a best in your field, max 1,000 to 2,000 kilometers. But now, this talk will give you an opportunity, taking you a new interest for writing skills. And as I have got from this writing school, the temptation from my director, ex-director, Dr. Gitanjali, used to tell, this publication is your property. My ex-director in Jodhpur used to tell, in AIIMS, you have to write These two talks, these two lines changed my vision towards research, towards writing, towards thinking a new thing. So without delay, I am just coming to why we should write. Why we should write. Always, every human being, there is a tendency have a selfie. Let me look good. That is the cosmetic surgeon's role play. But you want an intellectual selfie. If you link thousands years, name, reputation, promotion, this is a simple thing. But the greater sense of this, and second is authorship, your impact value, your H factor. Always this is a thing. When we are attending an interview in a jury, these are the questions. We are apprehended, never talk of, never read, never interested, never taken an interest. But the important thing is a selfie. This is not physical selfie. This is your intellectual selfie. It will not constrain you to the 100 kilometers. It will take you oceans, far away from oceans, thousand, million kilometers. The whole science is nothing but is a refinement of everyday thinking. But what is the difficulty? This second line by Rudolph, brevity in writing is the best insurance for the pursuit. What is the brevity? This brevity is the originality, the authenticity, the integrity. Whatever you are doing a research or writing a paper or any project, what your originality, your data, originality matters a lot. What your authenticity, free from plagiarism, free from copywriting, free from copying. We are doing, it's a reflex of human being. We are doing from birth to death. But what a new thing you are doing, some new thing, originality. So this is a very daunting task. It's not easy, very tough. You have to be silent. You have to reach a sea beach to think the big ideas. So why it is hard? Lack of experience, poor writing habits, writing anxiety, unfamiliarity, lack of confidence, fear of failure, and resistance to the feedbacks. Sometimes you are very afraid of the feedbacks. So what to do? We have to start. All research process is peer-reviewed process. They need writing skills, technical writing skills, and the evidence-based science. That is the important. This is your platform. Then you are starting. So what is the important thing, basic things for your acceptance of your paper? So timeliness, importance, relevance, originality writing, quality of the writings, the study design, proper study design, the literature review should be focused and with a sufficient large sample size. This is also matters a lot. But what causes rejection? Inappropriate, incomplete, insufficiently describe the statistics. Over-interpretation of the results, use of inappropriate, suboptimal described populations, small bias or biased samples, the text poorly written. So now we are starting. Now we have that energy to start writing. Before writing, you think what type of paper you are writing. This is case series, case studies, course study, meta-analysis, original article. You have to think. Then second thing, once you're writing, there should be a blueprint. Where you will send, who is target the journal, the type of readership, which are the population who are going to read your article, then the type of submission, indexing and the impact factor. Then what is the important? The importance is the final criteria for the idea. Research idea is very important. This is the one point in this talk, vital. This is the one point, good research idea. How it will come? It is by using the final formula. It is feasibility, interesting, novel, ethical, and relevant. This final criteria should fix to this research idea. Then it should be scientific language, avoid conjunction or any jargons. Always avoid the first person language. Then you should use proper graphs, charts, tables, photographs, and quality and clarity in the pictures, short, precise video clips. Though if your idea is not original, so give due credits. Those are the supporters who are given prior to your idea. Then check the list. Then starting from point by point, title. This title is very important. It will come in the last. But as the headings I am discussing in the past, it is the poster of the movie. So it should be clear, concise and informative. Very few words, few keywords should be used and in the form of a phrase. Avoid any markings, and there should be a running title also. And abstract, this is your trailer in the movie. So it should be brief, accurate and concise, structured or non-structured, and this is the summary of the article. So when we are sending an article, the editor decks first see the abstract. So this is very important. So this is a trailer of a movie. Whether movie will long run, this will highlight. Your trailer will emphasize. So introduction. In introduction, three concepts. Background in the three para. Background, first para. What is the current knowledge existing? Then second para. What is the gap? This gap maybe in the theory, maybe in the application, maybe in the clinical side. Where is the gap? And second, the third point, why you are doing the study? What is the justification? What is the newer thing you are adding to the scientific community? What is the newer thing you are adding? Then knowledge gap, final, this Picot evidence-based practice for the research idea. Then good research questions should be there. Then review of literature, it is PubMed, Medline journals, books and articles. Then research methodology, this should be very important. And design of the study, inclusion, exclusion criteria, and the description of the procedures performed, approval from the appropriate authority, just like institutional ethics committee certification, everything is important. Then the design, population sample size, data collection, outcomes, statistical method, and the limitation study you should be mentioning. Results, this should be in a logical sequence, summarizing the observations in the form of chart or tables, accounts for all patients. Don't present any conclusion. You should not present any conclusion type of writing in the results. So discussion, this is very important part, and it should be in the most vulnerable aspect of this article. So it should be described instead of discuss. So discussions involve assessing the advantage and disadvantage of this perspective, assess and differentiate finding from other relevant research, and then you have to formulate the conclusion aligned in the data. This conclusion is very important. You have to very few, 3 to 5 sentences you have to write with the learning points. What is the new you are adding? And then reference, definitely. Then your draft is ready. Now you send. Then ethical clearance, if it is there, it is boost to your paper. Then send it for publication. It will reject or publish, but don't be harassed. Then reassess yourself. Then this is the last thing. Once you are submitted, this paper will go to the editor's desk first. Whether they will reject or they will review. That is the first. So once they will want to review, they will send different reviewers. So within some time, after some time, you will get a reject or accept. But if you are accept, you will be smiling. But if you are reject, don't be feel bad. It is an encouragement. One milestone more. What is the lacking you have to fulfill? Then post publications. This is the important thing when you are writing. When you are sit for writing, your paper is very nice, accepted, published in the journal. But after some time, your published journal, paper in the journal will going to retract. This is the worst thing for a researcher. So beware, be very attentive. There should be article withdrawal or retraction in this name. There should not be any plagiarism. There should not be any copy paste. The disclosure should be clear and clarity. Otherwise, one day, today or tomorrow, or years after, it happened. Years after publication, the article is retracted. This is very same thing. So you have to check up. And according, this is my team. Thank you and welcoming you all to our, this is year reconstruction. Every year we are doing some one part. So this time hope everybody will be there for making it a grand success. Thank you all. Thank you.
Thank you, Dr. Sahu, for enlightening the House about the process of writing scientific articles. Um, you are not the last batsman or last speaker. And to end the session or the conference, our senior most colleague, teacher, or mentor is here with me, my co-chair, Dr. Ramesh Das sir. He will be talking or delivering the last lecture of this conference. And it will be interesting, it's not related to plastic surgery, I believe. Sir will be talking about produce or Paris.
Chairman sirs, National President, National Secretary, our President, State President and Secretary, my teachers, colleagues, younger boys and girls. It is an immense opportunity to disseminate what Dr. Ranjit told, knowledge. Even if you have a degree, unless we practice and put it into knowledge, then knowledge has no meaning. So I thought the two things, produce or perish, publish or perish. Suppose in a community you don't publicize or don't come to the conferences and talk. So it came to my mind long years back, 20 years back. When I was at Cuttack, I could hear the cry for 6 months. One child, his relations killed him. He was the single child. Because of the family feud, he was killed. And 6 months, I was thinking, what is the things going on? How we doctors are involved? As plastic surgeons, how we are going to help? And what our doctor community, they are doing to the country and to the nation, to the family. So I thought, let me tell that either produce or perish. Leave your progeny, leave the footprints. I tell the young boys and girls, leave some footprints. And you see the whole world is in turmoil now. There is war everywhere. There is riot everywhere, even in our state, even in India, in several places. So, and countries are divided in front of us. In our lifetime also we find a lot of things around us, around our country. And China is suffering now. They are now paying the price. Without a good family life, if you don't have happiness, you can't see a patient. With a very sad note in the family, with a quarrel, you can't operate. Because you learned people, with your meticulous surgery or microvascular surgery, if you are in tension, your hand will shake. You cannot do it if you are disturbed from the family. So happiness will be a dream. So are we living happily? Most of us not. Because there is a lot of diseases, a lot of discord, a lot of turmoil in the family also and in the society. Diseases, imagine the cancer, stroke, diabetes, and we doctors created problems. People say, at times they say there is no doctor, good doctor in the remotest place. I tell it is better not to have a doctor because they will sterilize you. So physicians have slain more than anything, any war. We are really not avoiding minimum 2.5 crore children to come to this world in India only. Then what is the ethics? We have to do good to the society. It is, but instead we are doing a lot of harm in the name of family planning, in the name of educating our children, giving them good education, good position. Indirectly, we are harming our family. terribly demographic change. You can see in the paper, Europe is in turmoil. India subcontinent is in turmoil because everything is due to demographic changes. But good things are also being projected. You see Elon Musk, why he is having 3 wives and 12 children? He wants to leave his progeny. He has preserved his semen for the future use, those who want talented people, because it is becoming gradually existential threat for the European and Western countries. So also this will happen to us also in future within 20 years. Now of late our leaders have realized this nonsense should stop. They now, Andhra Chief Minister Chandrababu Naidu, they are Mr. Stalin, Tamil Nadu Chief Minister, they are telling have as many children as possible, otherwise their state is suffering economically and Niti Aayog is diminishing their money in the central level. You see, Anjanina Jolie, beauty, they say beauty will be diminished. Never. I have seen those mothers, those who have more children, they live younger, they don't have diseases. Those who go to the doctors frequently and want to restrict their womb, they suffer and ultimately they'll end up in hospital. Working women, it's a big thing because most of the girls I see, they are plastic surgeon. For them, I tell you, only your work, your position, good work will not take you to anywhere. You have to leave your footprints. At times, work wins, and there is quarrel in the family, no issue. Once I met a girl, both of them are doctors, and they don't want to, and the boy wanted to marry another lady. This is happening in most of our colleagues also. To remain spinsterhood, we can find in Bhubaneswar also, even in rural areas, how they suffer. If they don't have an issue, nobody is there, no relation, no brother, sister, no father, mother will die. You imagine a lonely life and you will end up to the doctors or psychiatrists, and that is a danger. Late marriage. We are propagating early marriage because ultimately you will end up in infertility, land up and in the hospitals. Nature, we are going against nature. Our doctors are always going against nature. You see, does she bother how many kids she is having? Because it is with the nature. But below you see, in the family planning camp, unfortunate ladies are waiting to be sterilized. Suppose one child dies or something goes wrong, what they will do? They will cry. Still the cry is ringing in my ears. Kama Sutra was originated by Rishi here in India, but we have forgotten. We have forgotten reproduction. Only about sex we know, but we are forgetting the reproduction is part of the pleasure. Where are babies gone? Most of the hospitals I go and see, even nursing homes, there is no labor table that is thrown outside. No delivery. And if it is delivered, then they go for cesarean section, most of them. And they fear, the ladies they fear, and the womb shrinks. 1, 2 children. Now we are trying to tell the gynecologists to go for 3, 4. We stand by and encourage them to go for 3, 4 cesarean sections. Empty nest, both of you are working and there is no issue. What will happen to your home, your income, your family? Ultimately, the disaster will come. There is a syndromic things will come. Lot of diseases, lot of mental instability, no sleep, nothing, and medicine will not help you ultimately. Why I presented? Because we have a long time involvement in the family planning program. And we have seen these dangers because you see innocent women, they don't know, we have motivated the workers, ASA, they have motivated and brought them and they need to be sterilized. This is the picture of the cesarean section showing the anatomy of the fallopian tube. What harm the fallopian tube did to us? What right we have got to ligate it and make the woman sterile? There are several methods. I am not going to the methods or techniques because 35 cases that I have operated, as a motivation, 2 cases I have motivated even if they have 2 children and rest they have lost 1 kid or other. 33 cases we have recanalized. It's very simple for you the so young and so expert in microvascular, those who are anastomosing into 1 millimeter vessel, these are not difficult. We use 780 Proline sutures, round body needle, and result is excellent if the sterilization is within 10 years. You can ask me how the patient you get, because I'm not, you may think that I'm not in this domain, but if you work, go on working on this, people will come. Sir, I have lost my child, I'm crying, I'm not having sleep. Then we go ahead and do the not much investigation. Hysterosalpingography we avoid because that will more damage the mucosa of the tube. Directly, if he is sterilized, at the report that is laparoscopically or open she has been sterilized, then we have to make her fertile again. These are several techniques. And unfortunately, our gynecological surgeons, they, even in rural areas, they cut the fimbria because the ovum cannot be received. This is a very dangerous thing. Mid and the mid tubal ligation can be recanalized because the lumen disparity is less. This is the method, and by simple microvascular microtubal anastomosis can give excellent result. Be a small incision, lift the uterus through the vagina, and only get the tube anastomosis and leave it inside the abdomen. Laparoscopically applied, we are trying, I have tried, and will future we will go on doing laparoscopically tubal recanalization. One case, male infertility, one has conceived out of 3 because result is very bad. Male, fortunately they are not going for sterilization, it is fortunate enough. These are the different sites we have observed, and mid tube gives better result. Distal tube is difficult because the lumen disparity is much more, and 2 women opted for recanalization even with 2 kids. I motivated them, go for more than 2 kids, because anything happens to one, what you will do? You will cry, nobody is going to hear you. And as you will pass on, you will pass on to the reproductive age 45, we cannot help you. In conclusion, to the mostly the young boys and girls and those who are parents, we have to motivate our kids to save our nation, save our family, because that's why I told produce or perish. I think this message I want to give, nothing to go into technically and results, because most of the cases they don't return back. The fellow who has referred or he is directly, he just convey, I am conceived. That is the greatest happiness that gives to me at least, because if you don't produce, what is the need of plastic surgery or any surgery or medical treatment? Nobody is there. It will be shrinking population like Japan, like any other country you see. So it's a very ringing bell. So everywhere I used to tell wherever I go, be careful because the demographic danger is coming and will haunt us very soon. Thank you very much, Dr. Giri, Dr. Misra, and all our team, those who have here. And unfortunately, I missed the talk yesterday, and they have given me the opportunity to talk and share my experience and my views about safeguarding our country and our nation and our family. Thank you very much. Jai Jagannath. Jai Jagannath.
Thank you. And your interest in reversing the gear from tubal ligation to tubal recanalization, which will definitely going to help our country in future. Thank you so much. With this, we are ending up this session. I thank my co-chairs, Ramesh sir and my dear Dr. Satya, and handing over the mic to our president for the...
Thank you very much. Thank you, chairpersons, for nicely our Aprasocon 2025, Aprasocon 2025. Huh?
Somebody has lost his key.
Somebody has lost the key, car key. You please collect for me and your. Huh? Santosh, huh? End of the session, and really after a hectic schedule, we are going to conclude our this session, this Aprasocon 2025. I should validate these functions and I will share definitely few names whose contribution was marvelous and they have helped me like anything in the Aprasocon 2025. The Bahubali of our Aprasocon, Sanjay Giri, the honorary secretary, the secretary of our association, who has helped me like anything. I have called him even in 12 o'clock night. Help me, ma'am. He helped me like anything. And he helped me from the beginning of the starting from these functions. And till today, he has told that I will support you. Thank you, Sanjay, for your support to me, anything. Both the organizing secretary, Dr. Santosh Panigrai, my colleague, my consultant in Apollo Hospital, and Dr. Satyabrat Rautrai, both organizing secretary, helped me in any way. When I called him regarding the souvenir and the memento, this Uttariyas, everything, they helped me. And they are collecting and they have collected all the products from Cuttack and also Bhubaneswar. So Santosh has given maximum time for the souvenir. It's really difficult to publish a souvenir. And I also realized on that day, he was staying in this press for almost 12 o'clock night, in the night of the 12 o'clock day before yesterday. And it was excellent. I have gone through these details of this souvenir. It is fine, fantastic. Thank you, Santosh. Satyabrat, you have also helped me, and when I called you for this memento, please stand up, please stand, and I really thank you very much for your help and support to me, both. Thank you, thank you. God bless you. Lord Jagannath bless you all. Thank you. Then, when I called scientific session was really, from the beginning yesterday I have seen, it was smoothly conducted by our scientific team, specifically by Prithviraj. He is the scientific chairperson. Whenever I told him that, Prithviraj, help me, what is the problem, and you call me, and he called me every time and he accepted my calls. Then the co-chairpersons, Santanu and also Dr. Biswajit, both helped. And we have also around 7 to 8 Zoom meeting regarding how to smoothly maintaining this program. Thank you, all of them. Then come to the quiz competitions. And I was also not aware, because actually the 2 to 3 years we are conducting this quiz program. And I have seen also this quiz is really interesting for all of us. Even I have not seen also in our national conference where the quiz is separately maintaining in our association. And both Dr. Lopamudra Maharana and also Dr. Samir Patel, they are the young plastic surgeons. I have given the opportunity, you do it properly with the guidance of this scientific chairperson and also Dr. Sanjay Giri. They have taken, I think today I have seen also this quiz. It was fantastically arranged. Thank you, both of them. Both of them are not there here, but I appreciate them. And thank you very much, both of them. Thank you. Then specifically my heart goes to Sudarshan sir. Sudarshan Baliyar Sang, at the age of 85, 86 age, he is coming and he has accepted my call. He told me that all the bi-monthly meeting you dropped me in my home, then definitely I will come your meeting. And he told me that definitely I will go with my son. And sir, it was fantastic. Your presence was immense and it helped me. Very pleasure for me, sir, actually. Thank you very much. Then come to all the chairpersons, though my international faculty like Dr. Sanjay Parasar, who was actually, he missed the flight due to some immigrational issues, but he was also contacting me every time. He told me that I will come and I will, all my body contouring procedure, I will explain from the beginning, basic to advanced. Even on that also, 2.5 day programs, he presented so nicely from the anatomy to advanced course of this body contouring. I think I have also gained definitely few knowledges of the body contouring. Fantastically it was done. And also day after tomorrow I will send a link if it is possible for the double chin corrections by liposuction and also surgical facelift. And if it is possible, then at 9 o'clock I will send Zoom link to all body, and you can join there and you will see this both the procedures. Thank you, Sanjay sir, though you are not here, and definitely thank you very much. Then Subodh sir, he is my teacher from 2006. After completion, when I joined, beginning of this my career, he taught me cleft lip palate, and even I think it was so simple for me. Any type of complicated cases, I do my cleft lip surgery fantastically, and it was only due to you. Thank you, sir. Thank you very much for accepting my invitation, and you come to with a lot of stress and hectic schedules. Then Vijay Kumar sir, no doubt I know you from 2002 when I was appearing this examinations, and you accepted my call. Thank you for, sir, my invitation. You joined. It was fantastically. Thank you very much, sir. Then come to all the sponsors whose contribution, without their contribution, it was not possible. And it is possible only due to their presence. I thank you all the sponsors, specifically TRIES, Aristo and Metridum. Thank you very much. Thank you. My team, audiovisual, Santosh Babu and also Prasanna Babu, both when I called, and you have seen also, Prasanna Babu, he is taking photograph every time. I think he has taken almost 15,000 photographs within the 2 to 3 days. Thank you, Prasanna. Then hotel managements, starting from Satpati Babu, Panda Babu, all, they have helped also. When I call him, don't worry sir, we will arrange all the rooms, whatever you want. Thank you for this hotel management. Then come to the NRO sessions. First time we have started this NRO. All the doctors like NROs, those who are practicing outside Odisha, like Amrit sir is there, Krishna Prushti, my junior, he is always with me. He accepted my invitation and came to this program, and it was excellent. Thank you all the NROs who presented this Aprasocon, and it was memorable for all of us. And you should come also in the future and guide us what to rectify and how to improve in future also. Thank you, Amresh sir. You are coming regularly, and it's really you are a member of our team. I should not tell also, but you are always a member. Thank you very much. And last but not least, these residents, PG residents, the MCS students from all the different parts of AIIMS, Bhubaneswar, SCB Medical College, MKCG, and some hospital, I think so. I have not missed any other institutes. I think the 4 institutes, they have all these MCH categories. They have participated these functions, and it was fantastic. And your PG and best paper, PG paper, and also this quiz competition was excellent, and you should continue these things in the future. God bless you all. Last, the Gotipuo program and Anjan, they have entertained yesterday night fantastically, though they are not here. Thank you, both of them. Again, this cricket team was the idea of our organizing secretary, Santosh, and it was fantastic. We have today morning we enjoyed this cricket, and we have 2 teams, and one first match, Sudarshan Boliar Singh sir won the match, and second match, Falguni sir won the match. Thank you, sir. Last, I pray Lord Jagannath, and you all should return to your home with a stand. Huh? Garland? Garland exchange. I will come. Then, if I missed any name, please excuse me for this one. And this was fantastically arranged, and my tenure is over. I will call my president, vice president, Dr. Ruchi Gupta madam, to this dais, and this is my duty to hand over the garland, this medallion to her. She will continue. Huh? Prize. Both the prizes are there. I will request Subodh Singh sir to come to the dais and please announce Boliar Singh sir, both. You both are juries. And sir, Sudarshan sir. Lastly, he will announce and I will hand over this one. Price this PG best paper. All the three, this one. All the three, and that one is the PG best paper. First, second, third year. First, second, and total third organizing.
So now the most awaited results, and my other co-chairpersons and judges are here. Hello. So this is time for the most awaited results of the PG Best Paper Awards. And as we had said already that all the papers were of a very high standard, and it was difficult for the judges to mark one as best or second or third. And actually all the markings had to be added and average to be brought out. So the third maximum marks went to Dr. Akansha Rajput. And the first runner-up is Dr. Gopika Jit. And guess, the first prize goes to Dr. Anisha Ganguly. Boys, where are you? So that's such a welcome change, right? Yeah, and may I invite Dr. Sudarshan Balyar Singh to come on the dais to give this very important trophy to the winners.
Checks are there, checks will be given later.
Checks are there.
Give the checks. Checks will be given to you later.
Dr. Anisha. The checks are there? So they just burn this. Dr. Anisha. Come and stand there. Come and stand there and get a photograph. Yeah, this is.
the another memorial quiz, I think the winner is Tipsy, Priyanka and Anisa. Yeah. Vishnu and Surya. Second is Vishnu and Surya. Gas you will take from Rolando.
able to match up with the and try to be better. It's very difficult, I know, because already the level of this conference is too high, and I'll try my level best to be at least reach over there or be better. Thank you. Thank you.